Respected members present for the session today. First of all, I would like to thank the organizers who have given me this opportunity to stand on this stage with my topic on this prestigious platform. The topic for my day is obesity, dysmenorrhea, and impact of exercise on adolescents. Why adolescents? Why should we talk on adolescents? First, there were neonates, then child, then adult, and geriatrics, and now adolescents. Because 1/4 of the total population is comprised by adolescents, 10 years to 19 years. And the adolescents have to go through physical growth, secondary organ growth, mental and brain growth, as well as psychological and emotional growth. Today's most adolescents are a picture of arrogance, dominating behavior on parents, struggling in their teenage amidst a valley of drugs, drinks, social media, live-in relationships, and at times, wrong lifestyle of parents. They are thus faced by obesity, bullying, and mental health. Childhood obesity has reached epidemic proportions as proved now and then worldwide. And this is directly seen with decline in exercise modality of the adolescents. Statistics say that childhood obesity has tripled in the last 30 years. It's actually a ticking time bomb. The recent statistics of 2022 by UNICEF says 1 in 10 obese children globally would be from India by 2030. Each one of us has to ponder on this. By definition, overweight is when the adolescent or child is between 85th to 94th centile of his BMI, and obesity when the BMI is more than 95th centile for his age specific. Dysmenorrhea is painful menstrual uterine cramps regardless of severity. Overweight girls have increased risk of menstrual problems. Exercise is defined by IMA-AMS as physical activity which is characterized by using planned, structured, repetitive movements to increase or maintain physical fitness. Dysmenorrhea, as we all know, is an important public health problem and associated with loss of school days and poor quality of time of adolescents. So I took this study with the aim to study the incidence of obesity among adolescents, to study the prevalence of dysmenorrhea among adolescents, and to study the impact of exercise on obesity and overweight and dysmenorrhea on adolescent girls. So I took 7 schools of my study in my city, and 1,050 girls were included in the city from 12 to 15 years of age. A questionnaire was given to each, which included their personal details, their menstrual history, lifestyle history, including screen time, daily exercise, profession of their parents, etc., etc. Height, weight were recorded, and BMI was calculated. It was plotted on Ellis pathway graph and shown to the parents as well as to the child. A session on menstrual hygiene, lifestyle, misuse of social media, importance of games and exercise, personality development was given, and simultaneous counseling was done. The girls were provoked to join outdoor games in the playground for 1 hour daily. Exercise session in the form of outdoor games for an hour was started. And after every 2 months, weight, height were reviewed of these girls who were attending the games daily. Simultaneously, stoppage of fast food, Chinese food, and stoppage of screen time was advised, and parents were advised to keep a close watch on these aspects of their child. The distribution was seen. 57.6% of the sample was overweight or obese, and 77% of the sample girls suffered from dysmenorrhea, and both the figures are highly significant and proportion to previous studies. So in the initial 2 months, there was no change in BMI of the girls. But as the days progressed, after 5 months, gradual decrease in BMI was noted. After 7 months follow-up, 70% girls' BMI dropped by 3. And gradually, after 11 months follow-up, 100% girls who had joined the exercise session had reduced BMI by 3, and 52% had reduced BMI by 5. The initial 1 month was a period of difficulty. It took pains to coax the girls for exercise. But once they came for 4 to 5 days, they themselves were interested in coming and became regular with their games. Automatically, their screen time reduced as reported by their parents. The maximum benefit was noted when the girls were of BMI more than 25. the impact of exercise on the BMI was again seen month-wise and plotted, and it was seen that more girls who were more than BMI 25 showed much more response. So to discuss, it has been proved now and then that regular exercise can bring drastic improvement in health, and more so if adolescents are involved. Firstly, it is difficult to get an adolescent to do what you want. And when an overweight or obese individual is involved, it is more difficult. But if once the adolescent is involved in exercise, or for that matter, in any one positive or negative habit, they enjoy it, and they become deeply involved in it. Children and adolescents should be prescribed physical activity that is safe, developmentally appropriate, interesting, and practical. And involving the other members of the family will improve the compliance of the activity. If rightly directioned, we get positive results with them. Evidence also suggests that non-physically active adolescents are more likely to become non-physically active adults, and then they are prone for heart disease, hypertension, osteoarthritis, type 2 diabetes, hyperlipidemia, as well as obstructive sleep apnea. So unless this outbreak of overweight and obesity is controlled at the grassroots level, that is at the adolescent level, its implications on future generation will be perilous. So why be complex? We should be simple, like a simple platter of daily food which contains a balanced nutrition of calories, proteins, carbohydrates, and fats. So it is possible that encouraging the development of physical activity habits in children helps establish patterns that continue into their adulthood. And dietary treatment for obesity is more difficult as far as compliance is concerned. So nowadays it is suggested that prevention of obesity and overweight in adults should emphasize increased physical activity rather than strict diet plan alone. The fashion of keto diet, as we all know, is on the rise in the adolescents for fast weight reduction. We all know that this may present with bizarre presentations of joint pains, psychological issues, as well as metabolic syndromes. So how can I help my overweight child? Allow them to know that you will be there to support them and be sensitive to their needs. Limit fruit juice, limit fast food, sit down together for family meals, make it an event, a time to share news and tell stories, discourage eating in front of TV, computer, or gadgets. Don't allow children less than 2 years to see television or mobile. And free play activities can be great for burning calories. A session on adolescence would be incomplete without a word about parenting and handling adolescents. An adolescent is in total turmoil and chaos himself. Parents are again in the same stage with upcoming views saying not to be strict with them, give them space and independence, etc., etc., etc. And the society is landing up with overweight or obese adolescents, late marriages, late children, more divorce, and broken families. The basic relationship of management is to be shown to these teenagers as an example by the parents. The 6 parenting mistakes which I would advise to avoid when handling adolescents is, overreaction should not be there. Always maintain peace and tranquility in the environment. Giving into your teens each whim. We should not do that. We should teach them discipline. Complaining, never show negativity. Breaking promises should never be done. We should be patient with them. Parenting requires a lot of efforts and experience. Thank you.
नहीं ये तो चालू ही ना. So now actually we have a international faculty from Mexico, Dr. Christian Eckelman. He's a dermatologist from Mexico. He's a dermatopathologist. He's a cosmetologist, aesthetic dermatologist, because in Mexico there are very few dermatologists. So he's one of the most
Can I share
eminent
my
people.
screen?
So we're just trying to patch him through. We're just waiting for the link. वो लिंक जोड़िए ना जो जूम के थ्रू जुड़नी है, तो वो है डॉक्टर क्रिश्चियन एकलमैन.
A ver, puedes hablar.
अरे वाह, okay. Good morning, Dr. Christian. How are you?
Good morning. Can you listen to me?
Yeah, I can hear you.
Hello. How are you?
I'm
And
fine.
I would like to share my screen so that I can share my presentation. Is
Yeah.
it possible?
Yeah, please screen sharing on kar dijiye. So before Dr. Christian can start his presentation, I would like to tell you all I met Dr. Christian in LA Irvine almost about 7 years ago, and he's been the source of inspiration for a lot of my work, because he told me that lasers and energy based devices are the future and injectables are going to be out in the future. What we speak about Botox and fillers and so many things. And you know, when another person shares the same wavelength which you are thinking about, you feel, and he's obviously senior to me, so you obviously feel that, you know, you are in the right direction. And because of him, I was able to, you know, be on that path, and now I have 12 PubMed index publications and everything else, and he's the source of my inspiration. I wanted to tell this to all of you when he's there online. So it is really a great honor, Dr. Christian, to have you here, and we hope that one day we can have you and your family in India with us and take you to our national parks. But today it's not possible. Today we have you online.
Thank you so much. Let me just get my presentation and see that it is. Are you able to see my presentation?
Yeah, it's visible to us.
Okay, so we can start now?
Yeah, you can start, please.
Perfect. Well, thank you, and I'm so humbled to be a participant in this important meeting with you. And it's mutual, everything that you just said, it's mutual for me, and I cherish our friendship a lot. So when you asked me to talk about my experience with lasers, I'm going to try to just show a little bit of what I do here in Mexico with light-based devices. And well, I'm Christian Eichelman, as Dr. Amarendra said. I'm a dermatologist. And like he said, it all started here in Beckham Laser Institute in 2016, where we sat during a coffee break. We were both training in lasers, and we just started talking about light-based devices, life, and everything in between. So basically, just to give you an idea, where in Mexico I live, this is the United States, this is Mexico, and this is considered the Mexican Caribbean. And I'm in a small place there called Playa del Carmen, which is close to Cancun, big city that almost everybody knows. I'm a little bit south from Cancun. And if we draw a line from my hometown all around, well, more or less, I think it's around Mumbai that it crosses. So we're basically on the same line throughout the globe. And this is where I live. I live in a perpetual summer, 365 days a year. It looks basically like this in the Mexican Caribbean. This is where I live here. This is another picture of my hometown. So basically, it's sunny year round. And just what happens where I live before I start talking a little bit about lasers. So the average climate data that we have is we're around 32 degrees Celsius. We have about 227 days of rain in a year. Usually it's scattered rain throughout the day, so it gets pretty hot and humid here. Relative humidity of 94%, UV index 8 to 10, and sunshine year round. So how do we do lasers? Well, we have to understand the skin, basically phototypes and the interaction between skin and the technology that we're using. So things we take into account in this tropical climate and in order to do lasers are obviously phototypes, sun tanning in patients, what we are treating, devices we're using, the energy we use, and knowing a bit about all this, we've created enough experience to make it possible. I've in several occasions, I've been asked by several dermatologists from the US, people that I consider my teachers, and they always ask us, how do you do lasers in the Mexican Caribbean? And I say, well, we've learned our way to do it. So talking about the same thing. In Mexico, we have a lot of diversity. This is the people that I work with, and this is the Mexican diversity of skin types. And obviously, in the place that we live in, we have a lot of expats, specifically from the US, Canada, and Europe. So we treat all skin types 1 through 6 here, and we have to know a little bit about this. And I'm going to start sharing a little bit of the information which I considered is the most important things that we need to know when we do when we treat patients with light-based devices. And obviously, we need to know what technologies are out there and the specific targets that we want to treat. And for example, in this little image that I'm showing here, a little range of the lasers that I basically use, and we'll talk about it pretty fast and show some examples, are KTP lasers, which is the 532 in the nanoseconds that I use for pigmentation in lower skin types. Diode laser for laser hair removal. Diode laser seems to be the most widely used for all skin types. And the YAG 1064, we use it as long pulse for vascular lesions, and when it's Q switched, we use it for pigmentation tattoo removal. Erbium glass 1540 nanometers, we use it for acne scars. We're going to show some pictures of that. And erbium YAG 2940, which is considered an ablative laser, different from the erbium glass, which is a non-ablative, that saying it doesn't drill holes in the skin. We use it as well for rejuvenation and acne scars. So something that we really need to understand here are the chromophores and the real targets that we are treating, because it's not always what we think. For example, when we're treating hair, the chromophore that we're targeting with the laser, let's say the 810 nanometers, it's melanin, but what we're really trying to destroy are the stem cells of the bulge. Same with vascular lesions. What we are with the chromophore that's absorbing the light is the oxymetahemoglobin, but what we're really trying to destroy are the wall of blood vessels through heat. And well, this is just a little image that I like to use in presentations. It seems a little bit complicated, but it's not. It's just the wavelengths and the absorption coefficient of the chromophores. And basically, for example, talking about erbium YAG, we can see that it has a high absorption of water. We see the melanin and oxyhemoglobin have different peaks. That's why several lasers can be used to treat several skin conditions, different wavelengths. But basically, it's just to understand that we need to select a specific wavelength to treat chromophore, and that's one of the basics of lasers. So as a general rule, I really like this drawing because when we talk about skin types or degree of pigmentation in the skin and energy, and we plot it in a little diagram like this, here in Mexico, our patients are usually around here, so our therapeutical window is quite small. So we really need to understand how to use our devices, because if we use too much energy, we'll have obviously adverse effects, and if we use too little, we'll have no effect at all. So basically, we are kind of like in this point right now. This is another slide that I really like. This was done with an IPL with a friend of mine, Jens Pettersen. He showed me a lot about specifically IPL. He's in Denmark, and this is a patient. This is an arm, and this is where the shirt is, and this is where there is no shirt. And this is a person that was out sun tanning with a shirt on, and then they did a shot with the IPL, and we can see just in 10 minutes how that suntan skin starts burning. 10 hours, 4 days, 10 days, and it can last up to 3 months. So we really need to understand our wavelengths and the devices that we're using. Now, choosing the right parameters, get to know your device. For me, one of the most important things to consider is restrict thermal damage to the selected chromophore. I mean, what we're really treating, we want the energy to be condensed right on that area, and diminish the heat dispersion to peripheral tissue in order to achieve a clinical endpoint and get the desired result. So basically, we have 5 modifiable parameters, and which are the wavelength, the spot that we're going to use, the pulse duration, the fluence, and the cooling devices. And every device has, these are the things that we could basically manipulate to have the best results. And always know your clinical endpoints. This is for me probably one of the most important slides of what I always have to share. And is when I shoot a laser, I have to see what's happening immediately in my first shot. So if I'm trying vascular lesion, I need to see that the blood vessel turns a little bit bluish or disappears momentarily accordingly to the device that we're using. If I don't see this, that means that my parameters are not correct, and I need to readdress them in that session or just in another session. When we're treating pigment, what we're looking for is a bronze color of the pigmentation. And if I'm not getting this, sometimes I do one shot, wait a couple of minutes, and you start getting that bronze discoloration on the pigmentation of the patient. And epilation will usually, the endpoint is to get perifollicular erythema. Generally talking, informed consent, that's super important for us here in Mexico. We're next to the US. There's a lot of liability, and well, we all know this as dermatologists, but what we fear the most in our skin types are hyperpigmentation, which is something that we could deal with, but you'll have a patient that's not too happy. One of the worst things that can happen with certain lasers is hypopigmentation. We do see that sometimes when we're using, for example, diode laser for hair removal, and we burn the patient. So we know that it's going to be a hypopigmentation that's going to last around 6 months, and we have to treat accordingly. Plus all the others that are not as frequent, well, pain and erythema and edema are usually expected with several lasers. Prepping the patient. So just a couple of minutes here. It's avoid sun exposure. We always tell our patients that 2 weeks before, they really have to address the way that they relate to the sun, using sunscreen daily, knowing what kind of medications patients are taking to avoid photosensitizing medications. In case of herpes simplex in the area that we're going to treat, obviously we start treating 2-3 days before and continue 2-3 days afterwards. Stop retinols and hydroxyacids 3 days before treatment. If needed, shave the area 1 day before, if it's the face or if we're doing laser hair removal. And usually I treat my patients, I prep them with 4% hydroquinone. That's something that we do here a lot for about 4 weeks before the laser, and they will tell them to stop it about 2 days before. So post-treatment care depends on the wavelength that you're using, but obviously cooling is something that we almost always use. Any kind of, when we're doing ablation, any kind of dexpantanol. There are a lot of creams out there, post-laser creams, they're all good. But what I really want to stress is that I do use a lot of steroids, specifically in the day that I use the lasers, and more specifically when I'm doing aggressive lasers like full ablation of the face. We'll see some of those cases in a moment. And what I do is immediately afterwards, I do clobetasol cream, for example, and I tell them to use it for like 2 days. And that saves me from some expected trouble eventually here in my type of patients. Peelings, when I do for pigmentation, I sometimes just leave a 5% retinol for a couple of days. And so we're going to move with some clinical cases. These are some pictures. Most of them are with just one session. I really like to show pictures of what to expect with the patients. I never talk about number of sessions with patients. I just like them to be convinced themselves that we're doing or we're on the right path. For example, this patient, we're treating this minimal vasculature here with one session. This is an IPL SWT, which means selective waveband technology. So basically the new IPLs, the basic concept of the new IPLs is that we could lower the pulse duration anywhere between 0.5 to 1.5 milliseconds. And that has been the game changer for the new IPLs, because that makes us treat these vascular lesions with almost the same precision, or I would show you with pictures, as well as other types of vascular lasers. So I love my SWT IPL. This is another patient where a little bit of rosacea. We change it just with one session. Then again, the joules are not so important as to the milliseconds when we're treating this small vascular lesions. This is another patient on the nose as well. We're having good results. This is as well with an IPL SWT. Nice results, just one session. Obviously, we've done others and the patient as well, but I like the wow effect. Another vascular lesions, not going to waste my time on that. That's with the long pulse and the YAG long pulse for more dilated, bigger blood vessels. That's where we're going. Port wine stains, this is immediately after what I expect to see, and this is after one session only. This patient has done pretty good, but this is what I called my wow effect with one session, so the patient is convinced to want to do other sessions. Obviously, vascular lesions on the face of patients that are being treated with Accutane or any kind of oral isotretinoin. It's very safe to do vascular lasers on them. More examples of that. This is as well port wine stain treated with an IPL SWT technology, as well with a 1.6 milliseconds pulse duration. Pigmented lesions, bread and butter, very easily to treat. Usually we use two devices, either an IPL or the KTP, the 532 wavelength, or the 1064 Q-switch laser for bigger pigmentation marks. We could see how we start destroying all those little blobs of pigment on our patients. And this is quite a nice result. I'm really happy with that. And scars and rejuvenation. So this is an erbium glass 1550, which is considered a non-ablative laser. This is a very good laser that has it has little affinity for melanin, so that's why I use it a lot in our phototypes here in Mexico. Nice results. This is after 2 sessions. This is a patient with angiofibromas. This we did full ablation with an erbium YAG 2940. This is another patient for perioral rejuvenation. She hated these small lines here, so with one session we could almost eliminate that. That's the only thing that we treated there. And this is another patient where we did full ablation around the mouth and fractional laser all over. And this is just a little bit of the pictures that we're seeing. This is what I expect, heavily crusting. I love it when I see it because I know I'm going to get good results. And then eventually you have a happy patient. That's full ablation. I love to do full ablation. This is for acne scars as well. We do full ablation for those around the mouth as well. She hated all this pigmentation and color. Another patient that really wanted to get her face treated. This is one session, erbium YAG 2940 nanometers. One session. We use it a lot for onychomycosis, for dermatophytes. Here we use the ND-YAG-Q switch laser. This is with 3 sessions. Patients that can't take oral medication or don't want to take it. This is the results that we get. I would say that it is it doesn't always work as well, but in about 70-80% we get good nail clearing. The FDA has that system license for nail clearing, so we're having good results on that. Hair reduction, again, this is something that we do a lot in the clinic, different phototypes. We always use a diode laser or the Nd:YAG long pulse as well for pigmentation. After 2-3 sessions, we expect to have this kind of results. I'm almost done. Pediatric patients, we usually see them for scars. Here we use vascular IPL, nice results as well. And as well, a little scar there. Here's the dermatoscopic picture. Usually it's very tolerable for the patients. Here we did one session of vascular IPL, and then we did the Frax erbium 1550. And tattoo, well, this is just a nice example of tattoos. Usually some of them are easily to treat. She only wanted to treat this area, the black and a little bit of the pigmentation. So that's a good result, I believe. So my recommendations for anybody that's using light-based devices is inform the patient and show them exactly what device you're going to use. Give specific informed consent for every device. Photos with standardized devices and dermoscopy really works. Look intentionally for body dysmorphic syndrome. Here in our population, as well as in the US, between 10 and 20% of the population have this. The patient and their partner should know what to expect when we're going to do full ablation. We don't want the husband or the wife calling us to tell us what we did on their face and that they're all scared. We need to let them know what to expect. Supervise always, endpoint, like I say. Anesthetics when needed. Don't forget to cool down the area to avoid bulk heating when you're going to do several lasers. And my take-home messages would be, know the skin types that you're treating and base your devices on that. Supervise the treatments if you're going to delegate it to one or other people that work with you. Don't underutilize your devices. That's something that I see here in Mexico a lot. Endpoints are always the way to go. You have to know them. Plan your treatments with time. Execute in an individual manner everything that you're doing. Use dermoscopy when needed, specifically in vascular lesions or when treating melasma. Don't talk about sessions. Better show results. Don't fear, but respect. And I hope I didn't take too much of your time, Dr. Malendra. I'm a little bit past 2 minutes, so sorry for that.
Thank you so much, Dr. Christian. That was an extraordinary presentation. And you joined us as midnight in your country and city. We are so grateful. And
Yes.
that's his email address. If any one of you have any questions to ask him, you will have noted his email address. And thank you so much, Dr. Christian. I think any questions which are there, they'll email directly. So what I'm
Okay,
doing
thank
is,
you.
after Dr. Christian has explained lasers to you in detail, I'll just take 3 minutes of your time, because I want to save on the time which was there for my presentation. You can utilize it. I'm just starting with my presentation. I'll take 3 minutes by the clock, because I'm not going through any theory. All of that has been extraordinarily explained by Dr. Christian. But I'll just show you what happened. We've not been in touch since the past 7 years. So 7 years ago we met, we exchanged some ideas, and most of the results which he's showing, about 60% of my presentation is almost similar to his. So that is what happens when two people connect and they are on the same lines, and we keep doing our own research and we keep finding out. My presentation is not working on this main computer. That's why it's taking this time. And if it doesn't work, then I'll... क्या हो गया भाई?
मैं चालू?
So I'm not going to be talking about any laser theory. It's there already. They've explained the various wavelengths. There's a target chromophore which we always target in lasers. And the main thing is that we do not have to cause any side effects. What in my experience I have noticed is that as much as lasers as we can do ourselves without using any technicians, that is the best results which we can get. I, as a rule, do all my lasers myself. People say that when do you get the time? It's not about the time, it's about the intent. So I keep seeing patients and I keep doing lasers. Even the hair lasers, except for the body parts of females, I do myself. And the main reason for doing that is that a laser surgeon is supposed to be an endpointologist. You need to know your endpoints. And how can you observe the endpoints until and unless you're doing your laser yourself? So many seniors get angry with me saying that you might be having the time now, but I don't want to insult them, but you can come and see my practice, how many patients I see every day, and still I'm able to do all the lasers. So as I said, it's not about the number of patients, it's about the intent. I'm so sorry for the delay. I know it's an airtight schedule, but these people are not able to connect my pen drive. If they're not able to do that in the next 2 minutes, I'll just... Yeah, so this is my lecture for today, GlobalCon 2023. The magic of lasers, impossible to possible. Your aging is now reversible. Your fat is now destructible. Your hairline is now preservable. And your scars are now healable. Beta, usko bada karna padega. These are my inspirations, my guiding. Next slide, please. ऐसे ही रहने वाला है ये. Okay. Next slide, please. आप next करते हैं. Next. जब तक मैं बोलता हूँ next करते जाओ आप. These are my PubMed Index publications. हाँ, next करते जाओ. मैं बोलूँगा रुकने. These are all my PubMed Index original research work which I have presented all over the world. This is my article in Dermatology International on lasers and EBDs. Next. This is my articles in IJDVL on onychomycosis. This is all my research work which I have published in PubMed Index journals. Next. So I started with 3 lasers, and right now I have 8 machines and lasers. All of them are US FDA approved and now EMI free. That is how much Jabalpur has given to me. Next. So this is laser hair reduction via Platina Pro, which is a triple wavelength diode, and these are the results which we are able to see. Next. See, again, PCOS hirsutism treated with the diode 810 US FDA. So I have 2 lasers in my practice. One is a plain US FDA 810 and one is a triple wavelength. Next. These are just the results of the LHR, which Dr. Christian has also shown you. I am showing you again. Next. So this is salt pepper hair. It was treated at a different center. She still had residual hair growth. She came to me, and this is what we have managed with a carbon atom dye. Next. So this is white hair reduction, which only 7 doctors all over the world are doing. We have applied for a patent for the carbon atom dye, and this white hair does not have any melanin in it. So there is no target chromophore. So we inject an artificial target chromophore and we remove the white hair. Next. Next. So this is the carbon atom dye which we have developed with in collaboration with a company in Korea and India, and we've applied for a patent also. Next. Next. These are my results of scars. I'm just showing before after pics. Next. This is a very bad case of acne scarring grade 4, which we were able to improve through various sittings. After 3 sittings, this patient stopped coming to us because he got married. I'll show you patients who still came to us after 3 sittings. Next. 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 All these are just scar results, so I'm just saying next. 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 See, these are acne scars beyond 3 sittings, and these are about 60 to 70% improvement in the acne scars. Next. See, this is about 80% improvement in acne scars. Next. This is a doctor, that is why I took a photo. This is a medico who I treated, and he was very happy with the results. Next. 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 See, this is a person who had a wedding in 2 days, and this is what we could do with lasers in active acne and post-acne hyperpigmentation immediately. Next. See, again, this is one of the best results which we had using lasers, biofillers, PRP, everything we use, and you can see the results yourself. I don't need to tell you anything. Next. 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 This is another doctor who I treated. That's why I've just put the photos there. Next. 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 बढ़ाते जाइए. Okay, okay. पिछला वाला एक slide. Okay, these are rightites, crow's feet, wrinkles, whatever you want to call them. This is not Botox or filler. This is only lasers, energy-based devices which I have used in this. Next. Next, beta. Next. Next. Chicken pox scars. Ha, next. Next करिए. Next. Next. Atrophic scars, and now this is lasers in melasma. Next. See, you can see the results. This is just a single sitting. Next. This patient came to me from after getting treated in Chandigarh. She saw my video online, came to me, and I was able to help her. So it's a very proud moment for Jabalpur. Next. After getting treated. So this is, all of us see that this in our practice, lichen planus pigmentosis, 2 sittings of Q-switch NDAG, and you can see the results. Oral treatment, sunscreen, everything is there, but this is the magical result which this can bring. Next. Facial melanosis, again just 2 sittings, and you can see the difference. Next. Next. Again, a case of melasma. We were not able to remove the lesion completely, but she had a wedding of her sister or something to attend to, and we could help her with lasers. So earlier in melasma, lasers were contraindicated, but now this is what we are doing. Next. 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 So this is photo tanning, which is improved with lasers in 2 sessions. Next. Next. I'm just moving through the slides. Xanthalma, freckles, all of that. So this is congenital nevus, which we've treated with a Q-switch NDAG and radio frequency ablation, and you can see the results. This was an 11-year-old girl. Next. Next. Acanthosis nigricans. Next kariye. Acanthosis nigricans, which is treated again pigmentation against PIH, vitiligo using PRP and eczema. Next. 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 See, these are the results that I was coming to this. This is the results of tattoo removal. Dr. Eckelman showed you his results. These are our results. We are using almost similar kind of machines and lasers here in India. Next. See, completely gone. This, I would say, almost 95% reduction. Next. Completely gone. Next. 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 See, this is sequential. This is a new technique which we use, which we give the energy 3 times at a difference of 10 minutes. This is a single sitting result of this particular tattoo. Next. So this tattoo was treated at some other laser center. This is how he came to us, and when he was taking treatment, the tattoo was removed, but there was a ghost image. We worked on the ghost image, and I'll show you the results later. Next. So this is the much awaited, which everyone feels very happy about, PRP in male pattern baldness. So male pattern hair loss and female pattern hair loss, these are the results which we are able to give with PRP sessions. Next. Next. Karte jaiye. Next. 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 None of these are results wherein we've used any kind of hair transplant method. This is pure PRP and oral minoxidil. Next. Female pattern hair loss. Now alopecia areata. Alopecia areata. Next, alopecia areata. Okay, on onychomycosis, Dr. Christian Eckelman just showed you his results. These are my results. Next. Next, these are all patients in India, and here it is opposite. They were taking itraconazole since 5 years, 4 years, and then we treated them. Next. Next, yes, sir. Choti cheez hai. Next, see, these are threads which we are using, facial threads, non-surgical facelift in Jabalpur. Next, I have a series of about 20 patients. I'll be presenting on them also. This is how we inject the threads, and these are the results. Next. 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 I'm just coming to the last slide. These are very small things, so I'm not so. This is one of my fortes. रुकिएगा यहाँ पे. This is one of इसके बाद वाला. So this is what we can achieve in a single sitting of cryolipolysis. People said that cryolipolysis does not work. That's my machine in the background. It's a US FDA approved machine. I am a KOL for this company, and these are the results. Next. So this is the next is one of my best results. This person could not do bodybuilding because of the operation. You will see the scar. Agla next करिए. Next. See, so he came to me with a 39.5 inches waistline, and when he left, his waistline was 34.8 inches without any exercise, just diet and cryolipolysis. Next. Next, these are all results of cryolipolysis. That's a book which I have written. That's a book which I have written on aesthetic dermatology, ethical aesthetic dermatology. What is ethical and what is not. So and thank you so much. That's the end of my presentation. Thank you. Sir, we use the carbon atom dye on the white hair before the laser. We leave the dye on for 20 minutes so it reaches the hair root and the isthmus if we are talking about transactional travel of the dye. So it provides artificial chromophore for the laser to work. The laser is blind until unless it can see a target chromatophore. Laser is very specific. उसको जहाँ मारना है वहीं मारेगी. तो उसको हम कहाँ मारना है वो बताते हैं, वो वहाँ मारती है, वो बाल खत्म हो जाता है हिंदी में.
So we'll be moving forward next session because we are already running late. The next session will be by Dr. Rajesh Kevat. He'll be discussing on SGLT2 inhibitors and cardiorenal benefits. Dr. Rajesh Kevat. Okay. Time lagega. So can we take the next speaker? Next, Dr. Ayushi. Dr. Ayushi Sthapak Karsolia. She'll be speaking on latest in leprosy management. And I would again request to kindly stick to 8 minutes plus 2 minutes. We'll be reminding you to stop at 8 minutes and we'll be finishing at 10 minutes.
Can you just help me with this?
Yes, please.
A very good morning to all the respectable delegatories and my seniors. And I'm very thankful to the organizing committee of IMA Jabalpur for giving me this wonderful opportunity that I can come and present my work and share my findings with you. I would also like to extend my gratitude to Dr. Amreen Pandey sir for making it all possible. So, of all the diseases that have ever plagued humanity, very few carry such a heavy stigma as leprosy. Even the word, it conjures an image of untouchables, the unclean, and those whose body parts are not completely stable. Though in reality, it is very different what the disease is. So I'm going to take you through a journey of how this disease and the treatment has evolved over centuries. I'm Dr. Ayushi Sthapak Karsolia, MBBS, MD Dermatology, Venerology and Leprosy, Fellowship in Cosmetology, Lasers and Aesthetic Medicine. My topic would be latest in leprosy management. So leprosy as it was understood, is it okay, sir? Now okay? So leprosy, as it was understood as it is an illness that is perhaps not widely understood, yet is widely known about with myths and the prejudice that surround the disease. Whilst you may believe that the disease is from a bygone medieval age, it still affects around 2 lakh people every year. Here I would also like to share that India bears the global burden of more than 52% cases worldwide. What is the horrifying history of leprosy? It was identified as a disease in India as early as 600 BC, and one of the vectors was believed to be the army of the Alexander the Great in the 4th century BC. Due to the lack of understanding of the disease, a lot of treatment modalities had been used in the past. I'll take you through a few. So bathing of the children in the blood of the lambs was used as a purification ritual, and it was considered that leprosy occurs to people as a result of the sins that they had committed. So you can understand the impact of the stigmata it has caused to the patients. Doctors also use the attempt of venoms and poisons to treat the disease and let the patient be cured of it. The most horrific, whereas, was the establishment of the specific colonies, the leper colonies, in which the patients were isolated from the rest of the population. There was also a term known as lepers, which were used to address them instead of the patients of leprosy. But what leprosy exactly is? Leprosy is also called as Hansen's disease. It mainly affects the skin and peripheral nervous system. It is caused by a bacteria, Mycobacterium leprae. It is very important to understand that leprosy is not contagious. It cannot spread by casual contact, merely by shaking hands or sitting next to a person or living in the same house. It does spread via droplet infections that is caused due to coughing or sneezing. The rate of infection also depends upon the immunity of the person. Malnourished and those living in the poor socioeconomic status are likely to contain the disease. However, we are not 100% sure about the mode of the spread because this disease cannot be reared outside any living host. However, 95% individuals are naturally immune to the disease owing to its longer incubation period. As per WHO Expert Committee 2010, in order to diagnose leprosy, we can go for these 3 cardinal signs. There are hypopigmented or erythematous skin lesions with definite loss of impairment. You have to understand the dictum that without sensory loss, you cannot diagnose a case as a case of leprosy. Involvement of peripheral nerves as demonstrated by definite thickening or by sensory impairment, and slit skin smear positivity for the acid-fast bacilli, that is on Zerrin staining. The first cardinal signs, however, when a patient presents to you in the OPD is more likely to be a hypoanesthetic patch with loss of definite sensory loss. This is the Ridley and Jopling's classification, which is the most widely accepted classification of leprosy. He has divided it into 5 poles: tuberculoid polar, which is a high resistance pole, and lepromatous leprosy being the lowest resistance. These are a few of my patients. The pictures are real. Thickened greater auricular nerve, you can see. The first one, single borderline tuberculoid lesion over the right elbow. The pole is tuberculoid pole. The clinical features that are associated with the disease are skin lesion. Sometimes the patient also presents with the weakness of hands or feet, numbness caused by a peripheral trunk involvement. Sometimes they present with deformities, resorption of fingers and toes, ulcers on anesthetic hand or foot, and sometimes in reaction. In reaction, the patient comes with nerve pain, sudden palsy, painful red eye, and even febrile illness. These are some of the other pictures of my patients. Multiple inverted saucer lesions, that is the borderline leprosy case, and the other one showing the claw hand deformity. Now, how will you diagnose leprosy? There are few lab diagnoses: the specimens, the acid-fast staining, which is the most common method, the skin and nerve biopsy, which is the most specific method. Animal inoculation is done on a 9-armed armadillo mouse, which is not very easily found, and it is a difficult to rare organism, so this is hardly done. However, in terms of checking drug resistance, we use this method of animal inoculation. The last one being the lepromin test. So India has taken an initiative of the National Leprosy Eradication Program, which was launched by the government of India in 1983. So here I would like to bring into your notice that the leprosy disease was eliminated in India in 2005. However, we still get a lot of cases, new cases, on a day-to-day basis. So this NLEP scheme is a 100% centralized sponsored scheme, and MDT is supplied free of cost by the WHO to the NLEP. The components includes decentralized integrated leprosy services, capacity building, intensified IEC, intensified monitoring and supervision of the drugs, and prevention of disability and medical rehabilitation. The classification as per the NLEP is into possibacillary and multibacillary. If there are 1 to 5 lesions, it is possibacillary.
Ayushi, you'll have 2 more minutes.
Yes, sir. And if you have more than 6 lesions, or it is SSS positive, it is multibacillary. Grading of disability, it includes hands and feet and eyes. These are the grades. This is the protocol of the NLEP based on skin patches and nerve trunks. They divide it into this. The referral services in NLEP are at various levels: sub-centers, PHC, district hospital, district nucleus, and reconstructive surgery center. I would like to tell you all that we have a reconstructive surgery center at the Victoria Hospital in Jabalpur, which I suppose is the only center in Madhya Pradesh. The MDT regime as supplied by NLEP, it is a color-coded method for better follow-up and better understanding of the patient. These are the newer drugs, fluoroquinolones, tetracycline, due to the increasing resistance to the MDT. Disability prevention, DPMR, is an initiative by NLEP which provide dressing material, supportive medicine, ulcer kit, MCR, footwear. NGOs, they provide an incentive of 5,000 rupees to the people affected with leprosy, and to the government institute 5,000 rupees per reconstructive surgery conducted. Conclusion: leprosy is curable if early diagnosis and treatment adverts, control of leprosy in most countries owing to national and subnational campaigns, and integration of basic leprosy services has made diagnosis and treatment possible. These are my references. This is my work published in the European Journal of Molecular and Clinical Medicine. Mahatma Gandhi ji said, leprosy work is not merely medical relief, it is transforming frustration of life into joy of dedication, personal ambition into selfless service. Yeah, I hereby thank you all for giving me this wonderful opportunity. I have dropped in my email in case of any question. Please get in touch. Thank you.
So thank you, Ayushi, and we'll be moving forward to another session from an international speaker. She'll be speaking on, she's Dr. Iriana Velensko from Ukraine, and she'll be speaking on the latest trends in international protocols on diabetes management. Dr. Iriana? Dr. Iriana? Are we audible to you?
Dr. Iriana, can you hear us? Hello, Dr. Iriana? Dr. Iriana, Dr. Shaunak, yes. Dr. Shaunak Patel sir has joined us. So Dr. Shaunak, can you present your presentation now? Sir, we'll move to the next physical presentation. By the time they're trying to connect them, so we'll move to the next physical
Rajesh.
presentation.
So the next presentation will be by Dr. Rajesh Kewat, and he'll be speaking on SGLT inhibitors in cardiorenal benefits. And I would request Rajesh to kindly finish it up in 7 to 8 minutes.
Good morning, everyone. Today we are discussing on very important topic, that is a new drug that was launching to treat uncontrolled diabetes mellitus. Initially, we are using these drugs in controlling only diabetes, but nowadays in obesity, in renal compromised patients, in cardiac patients also, these drugs having multiple benefits. So, so we are discussing in this in this lecture what's the other uses of these drugs beside diabetes mellitus. So next. So these are the combination of drugs which are using nowadays to prevent renal and cardio benefits. Next. So what are the unmet needs in type 2 diabetes? That is increasing prevalence of type 2 diabetes. Risk of increasing prevalence means it is more in age group 50 to 60 years, and there is a more of risk of complications like various micro and macro vascular complications. And due to high cost of not treating type 2 diabetes properly in timely, so difficult to achieve and maintain glycemic targets. So these are mainly 4 points which are unmet needs in type 2 diabetes mellitus, and we are facing nowadays these problems. Next. Next. So only 36% of type 2 diabetes patients have achieved target less than 7% HbA1c. That is according to ICMR India of 13. So this is cross-sectional study which clearly indicates that only 36% of type 2 diabetes patients have achieved target less than 7%. Next. Next one. Okay, this is a case, one case come, let us look a patient of type 2 diabetes, uncontrolled on metformin. He is on metformin without any other modifiable risk factor. Means patient is 42 years old male, having no history of any cardiovascular disease in his family. And he is type 2 diabetic since last 2 years and having no other any risk factors or comorbidities. His blood pressure is normal and BMI is 23. So in current investigations, having HbA1c is 8.5%, FPG is 162 and PPG is 210. Means he is having uncontrolled both fasting and postprandial blood sugar level. Next. So we are focusing in this patient, what we are mainly focusing, next slide. So this patient is currently on medication metformin on maximum tolerated dose. Next one. So what you think are the important aspects to consider before treatment modification? So we are mainly focusing on these 4 points in this patient. That is long life expectancy, avoiding dysglycemic legacy, quality of life, and all needs to be considered. So these are 4 points. Now, next slide. So first let's understand therapeutic and clinical inertia. What is it? That is therapeutic inertia is failure to start a therapy or its intensification, non-intensification when appropriate. And clinical criteria in diabetes care is delay or inaction to initiate or intensify behavior change. So these 2 points are very important. Timely treatment and next. Timely treatment intensification is critical to prevent complications. So substantial clinical inertia occurs in sequential approach, means patient is on one drug and after some years they are on dual anti-diabetic drug and after 7 years on insulin. So these substantial clinical inertia occurs in sequential approach. Next one. Next. Next slide. So delayed intervention in patient with type 2 diabetes. So risk of cardiovascular events are obviously increased. Next one. Next. 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 So these are the percent of complication, 1 year delay in receiving treatment intensification. That is risk of MI is 67%, stroke is 51%. Next. 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 So MI is 67%, stroke 51%. These are the various complications occurring when we delay the start of treatment. So when to initiate a combination therapy, what do the latest guidelines say? That's ADA 2022, absolute effectiveness of most oral medication rarely exceeds 1%. So initiate a combination therapy is very much important. So early combination therapy as per ADA 2022 in some patient initiate to extend the time to treatment failure. First is this, and the patient is having HbA1c greater than 9 or greater than 1.5% above target. So according to AACE 2022 should consider dual triple therapy. And as per RSSDI 2022 consider initiating combination therapy if HbA1c is greater than 1.5% above the target. Next one. So compelling reasons to initiate this combination, that is empagliflozin plus linagliptin as a next line therapy in a patient with type 2 diabetes inadequately controlled on metformin. Next. So these are the expert opinion for appropriate use of this combination in patient with uncontrolled diabetes with or without metformin. So appropriate the use of these drug on management of type 2 diabetes initial with lifestyle modifications. So these are the 3 points given, means in treatment naive means patient is on without metformin therapy, also we can use this drug, and in treatment also with consider along with metformin, and if patient is uncontrolled on along with metformin monotherapy. Next one. So these are effect on 8/8 pathophysiological aspect of ominous octet when added to metformin. These are the some drugs given which act on different organ like.
अच्छा सुनो मेरा वीडियो तो एक वो कर
of
लो
the
यार
drugs.
टेस्ट
So
टेस्ट
if
कर
we
लो
talk
मेरा
about the
वीडियो आ रहा है
SGLT2 and
पीपीटी चल रहा है
SGLT2 and DPP4 inhibitors, these are mainly act on what?
मेरा वीडियो दिख रहा है
In kidney in PCT
उसको
proximal
दे
convoluted
दो
tubule
वो
attacks
मीडिया वाले को
SGLT
दे दे यार
inhibitor
फोन
and DPP4
मीडिया वाले को
inhibitor
दे दे एक
in
सेकंड
incretin,
उससे बात
having
कर लो
incretin effect. So these are the various 8 drugs given which acts in different organ system. Next one.
Rajesh, you have 2 more minutes.
Okay. Next. So possible effect of combination on cardiovascular metabolic risk factors, weight, BP reduction, powerful early efficacy, low risk of hypoglycemia, and CV and renal benefit. We already discussed these points. Next one. Next. Next. These drugs can be used along with metformin for benefit for these effects. Next. Next slide. So these are early achievement of goal and durability of action on metformin background. Patient having HbA1c reduction was sustained up to 52 weeks in patient uncontrolled with metformin. Next one. Next. We have not enough time to discuss in detail, so we are focusing mainly on highlighting the main points. Next one. So further HbA1c reduction patient with baseline greater than 8.5% if we using this drug. Next. So these drugs are in different doses, that is EMPA in 25 along with Lina 5 and also EMPA in 10 in Lina 5 mg, and these are the effects of drugs on reduction
Rajesh,
in
you can
patient
summarize.
HbA1c. Next one.
You can summarize now. Please summarize now.
Okay, mainly we are focusing in these slides are that these two combinations are coming nowadays, which are mainly having various CV benefits, also renal benefits. These drugs can be used individually, also in combination with metformin. Sometimes SGLT2 inhibitor are the drug which are using in even non-diabetic cardiac patients and also in renal patients having creatine clearance greater than 30%. So as compared to other drug, when we are using these drugs, then if his patient is having creatine clearance greater than 30%, then also these drug having very beneficial role. So we are recommended in cardiac and renal patients to use these combinations. And one more important thing, as soon as possible we come in from single to dual anti-diabetic drug. This is very important because to prevent the various type of complications. So these are the main summary of the presentation. Thank you. Thank you so much.
Thank you, Rajesh, for a nice presentation, and I will request Dr. Stapak sir and Dr. Bhadwa sir to kindly sit as chairpersons. And We'll be going to the international speaker program now.
Actually, in Ukraine, after 12 p.m., there's going to be no electricity, and also these are one of our last international speakers. After this, there'll be no disturbance. So we are connecting. Okay, now both of them are there. So one after the other, we'll connect. First, Shaunak sir, if you can wait for just 10 minutes, because Iriana ma'am will have no electricity in another 15 minutes time. She's from Ukraine. So we'll keep you both of you online, right?
Yes.
Yeah, Iriana ma'am, you can
Right.
go ahead with your presentation. Iriana ma'am is from Ukraine. And her introduction will be given by Ashish sir. Ashish sir, we have very little time. Please be very quick with your introductions.
Yeah, Iriana, how are you?
I'm fine, thank you so much. No,
So
I have
Iriana is a
electricity.
very well-known personality all over the world, and she is a very good friend of mine. And thanks for accepting this invitation. And she is very active in all the societies in IDF, EASD. So without waiting much, we will be. I give you the mic to you, Iriana. Over to you. You can start your presentation.
Thank you, Dr. Ashish. I'm very happy to be part of your conference. And I all the time very exciting when I see how many people involved in many Indian conferences. It's super audience who really interested in different subjects. Thank you so much. I can share my screen. Today we will speak about communications in T2 diabetes treatment. Because you see, you have a lot of research and you spend a lot of energy for treatment, but sometimes, and this is not successful, but problem is maybe in communication skills, doctor. And the Joint Commission reported that communication failure rated that any lack of technical skills or understanding was a root to over 70% of serious adverse health outcomes in hospital. 2 out of 3 patients leaving the hospital don't know they are diagnosed. And in 60% of cases, patients walk away from a doctor visit not understanding what they're supposed to do.
हाँ
Instruction
एक
for
काम कर दे बस तू ना
medication and lifestyle change.
मैं म्यूट करूँ
People
एक
with
सेकंड रुक
diabetes
जा
internalize messages from
मैम
any
अब
resource.
म्यूट करने बोला तो फिर म्यूट कर रहा हूँ मैं
Sorry.
Shaunak, please mute your mic.
And if you look how it's very important effective doctor-patient communication, that increase motivation, reassurance, and support in increased job satisfaction, both of them reinforce patients' self-confidence. And this is increased outcomes, but decrease cost effectiveness. If you look at this big slides, that show that patient-doctor communication is big complex. But despite communication skill training in medical schools, doctors continue to demonstrate poor patient-doctor communication skills. Sorry, but I'm honest. But of course, we have many barriers to good doctor-patient communication. And because this is both ways, and we can see this is interpersonal barrier, a linguistic, physical, culture, and organizational moment. But also, if you look at this, it's not only big complex, and you see the 6 factor of communication risk, and this gender factors. Male physicians are more likely to overestimate their communication skills. Personality, behaviors factor, time urgency factor. This is, of course, you are all the time busy. You have not time enough for give a lot of time for patient to explain, but this depends on your outcomes. Patient in also literacy factor. Patient with English as second language may not be able to understand writing instructions. And social economic factor. Patients from low socioeconomic status desire less information, and of course, according to some culture beliefs. Important, but overlook communication lapse. Look, have verbal, you must actively listen, inappropriate choice of word, content, poor quality and quality of information provide could be also poor attitudes, a lack of respect and emphasis, and non-verbal eye contact, facial expression, and paralinguistics. But in same times, we can see resistance by patients. They patients have recognized they are not passive recipient and are able to resist the power and expert authority the society grants doctor. They can implicitly and explicitly resist the monologue of information transferred from doctor by actively reconstruction expert information to assert their own perspectives, integrated with their knowledge and other own body and experience. There, look, there it was uh, studied that patient communication wish list. The patients say that it's very important to provide to communicate about chronic disease management by making personalized recommendations based on information that are specific to patient and their individual needs, helping patient understand the currently and target health sending medication refill and pick up reminders, and delivery online couriers and checking to help monitoring disease. And look, the most complaints about doctor are related to issue of communication, not clinical competence. This is my recommendation to you. Read, I know you are busy, but sometimes you must develop an in another area, not only specific medical education. This is link, you can see this link to download this good, great book, Communication Skills for the Healthcare Professional. This also have part about diabetes and general guidelines to follow with patients, show respect and compassion, practical unconditional positive regard, show concern and interest, and practical objective to be next. Guidelines, principle for communication with and about people with diabetes. Sometimes you speak not only with patient and also with family. Diabetes is complex and challenging disease involves many factors and variables, and doctor must cover this. It's, to be honest, sometimes even impossible, but we try. Stigma that has historically been attached to diagnosis of diabetes can contribute to stress and feeling of shame and judgment. Every member of the healthcare team can serve people with diabetes more effectively through a respectful, inclusive, and person-centered approach. Principle recognizes some words, phrases, and descriptions are potentially problematic. You understand, but patient don't understand. They have not your knowledge, not your education. Use language that's free from judgment of negative connotation. Collaborate and in judging rather than authorization and controlling. But sometimes it's also need from my from my point of view. Avoid language with attitude, responsibility, or blame. Avoid language that infers generation, stereotypes. Use development and empathic languages. Also, they understand very important. Show that you understand problem people with diabetes and that it's very difficult to manage. Practical tips for better communication with patients. Introduce yourself. Speak in layman's terms. Checking your patient understood. But look, not ask, do you understand? Yes, of course. But if you exactly ask what I say, repeat please, and you see that it's big gap. Be adaptable, slow down and adapt to the situation. Gain content for what's going on the patient life and just be honest. And look how this is, I use this slide for show that we have a few moments for we must modify diabetes support service. Diagnosis, we must find some word. Another situation, we must find another word. And when complication factor develops, also we must find another solution how to communicate with people. The model of patient education. Why I say the patient education? Anyway, even treatment doctor support education. You must explain, and this is also education based. And you see there's a few models and you can use and combine this. It's a deliberative model. It's in additional, I tell you my preference, something like this. But I give you fact and help you find your preference, but you see this must be smart patient. And I give you fact and you decide what to do. But sometimes we use only paternalistic model. This is good model, but in same time, you must use different model for better involve patient in this process. Next, language philosophy. Language is powerful and words have the power to elaborate or destroy, And this is last time language allowed diabetes to change. And the International Diabetes Federation published in language philosophy because of the belief that there is a responsibility to set an example about appropriate language to others. You can find this in our site. And this is in Great Britain was document which show that language that encourages positive interaction with people with diabetes and subsequently positive outcomes. You see, I also put this link for find this document. And some some studies show that this is improve communication skills and competence in communication skill improve outcome. But training the doctor should include paralinguistic moments, which we sometimes forgot about. And communication training has been found to improve doctor-patient communication, but at the same time, the improved behaviors may lapse over time, and we need important to practice new skills with regular feedback on the acquired behavior. And please don't scare. This doctor-patient communication in the health area. You see, its more biggest conflict is only face-to-face communication. And can we
Ma'am, we'll request you to please summarize because we are running short of time. So if you could just summarize now because there are two more speakers after you. Thank you so much.
Yeah, and I definitely finish. Digital literacy, we must also look on these skills we need to use. I know that Indian doctors is super in this area. I know you use a lot of mobile and some apps for this. It's great, and but we must also expect that people with diabetes maybe have not this skills. We must teach this. And last, telemedicine with diabetes. We also not forget about all people who have not this skill, because a lot of studies show that we lost some all the adult people, not adult, elderly people, and this is a big problem. You must remember about it. In this case, thank you very much for your attention, and please, we must work on our communication skills. Maybe it's not so interesting, but I'm sure if you cover this, you will become more good results.
Thank you, Iriana, for accepting the invitation and giving such an excellent talk. So message is very clear. The communication with the patient, we are still lacking after so many years of digitalization. So we should individualize the communication skills also. We should not generalize these things as we do in the diet part. So please see what the patient requires and how the counseling should be done. So thank you.
Absolutely,
Thanks a lot.
Dr. Ashish.
Thank you so much,
Absolutely.
Ashish sir. Thank you so much,
Yes, sir.
Ariana ma'am. We are very grateful you joined us from Ukraine, and God bless you all, and India is with you. Thank you so much.
Thank you.
And
Thank
Thank
you.
you, Rihanna.
Thank you.
Bye.
now we
Bye-bye.
have Dr. Shaunak
Thank you.
Patel sir, who's been like a mentor and teacher to me. He's practicing all around the world in Singapore and Ahmedabad, and he's been trained in threads, and he's also instructor now in threads. So without wasting any more time, I present to you Dr. Shaunak Patel sir from Ahmedabad. Dr. Shaunak sir.
Thank you, Amrin. Thank you so much. Am I audible?
Yeah, yeah. Yeah, you are audible.
Okay, so I'll just start off with the presentation. If you could kindly let me know, are you able to see the presenter's view or my presentation as a whole?
No, you are visible. Just please share the screen.
Uh, okay. Can somebody tell me how to share? It's
Go
not.
downward. There is option of more.
Yes. It says stop incoming video. Only one option.
Share option is there. Share.
I'm not able to see that option, sir. It's just coming stop
You
incoming
can see
video.
the mute, stop video, participants, chat, reactions, share.
Share
You have
option.
joined through Apple.
Yes, sir.
Then there might be some problem. Can you see the share button?
Share button, sir. I'm not able to.
So tech team, can you help them? Hello.
Yes, sir. I'm there. I'm there.
Yeah. Can you see the share button?
Share button, sir. It's not there. It is only giving participants, chat, reactions, settings, more, and leave.
Go to more.
When I click more, there is only one option: stop incoming video.
Okay.
If it
I'll
is
try
possible,
to.
you can uh, talk without slide, Shonak.
No, no. See,
If there is any technical difficulty, then Ashish.
sir, Ronak, you have Shonak, you have any other gadget in your mobile? You are having the slides.
You can
It
talk
is in the
without the
cloud
slides also,
actually.
and just
I'll
let
try
us
to
know, because
log
we are
in
running very short
online
of
and
time.
I'll try to do something.
You can join through mobile. The four options are there. Share option is also there, so you can share the screen. Actually, sometimes Apple gives some problem for sharing.
One second. I'll just
Yeah, you join through
try
this
once
the
from my
link through the
phone.
mobile.
तब तक हम कर देते हैं, there is
You
still
join the link through the mobile. The joining which we have joined.
Yes, sir. I'll do that. But my presentation is on the cloud. It can't be visible without that.
Okay.
In the meantime, I would request the three speakers, Dr. Alpana Shukla, Dr. Rajesh Kevat, and Dr. Ayushi Stapak Karsolia to kindly come over the stage. I would request Dr. Pushpraj Patel sir to kindly felicitate our speakers. Dr. Alpana Shukla madam on the stage, please. Rajesh Kevat, are you here? Rajesh? Dr. Alpana Shukla is being felicitated by Dr. Pushpraj Patel sir. Dr. Ayushi Stapak Karsolia to be felicitated by Dr. Pushpraj Patel sir.
अवया ने खोली इसने बंद रखा.
Dr. Yogesh Sharma. Dr. Yogesh Sharma, are you ready with your presentation? So I would request you to kindly start your presentation on TB recent guidelines.
मैंने बोला 10-15 मिनट में.
So Dr. Sthapak sir will be giving his presentation first on latest advancements in phaco methods.
Good morning, dear friends. Now this is presentation on femtosecond laser in white cataract. This is the basically modern technology for cataract surgery. This femtosecond laser provides an ultra fast burst of energy. As we all know, there are mostly 3 types of laser. Femtosecond laser which photo disrupt the tissue, excimer laser which photo ablate the tissue, and argon which photocoagulate the tissue. ND-YAG and femtosecond photo disrupt. Their light energy can be absorbed by the optically clear tissue and create microcavitation bubbles that cause an acoustic shock wave that incides the target tissue. So you can see here the principle of femtosecond laser. The laser energy is absorbed by, आवाज बहुत ज़्यादा हो रही है. So this laser energy is absorbed by the tissue which result in plasma formation. Yes. You can see here, this is plasma formation, and expansion of plasma creates cavitation bubbles. So here is these cavitation bubbles which separate the tissue plane. So this is Victus femtosecond laser platform. With the help of femtosecond, what we can do, we can perform capsulotomy, lens fragmentation, arcuate incisions, primary and secondary incisions. For LASIK procedure, with the help of Victus femtosecond laser, there are corneal applications like we can create flap. Otherwise, in LASIK procedures, we create the flap with microkeratome, which is mechanical flap. There are therapeutic application also. We can do penetrating keratoplasty, intracorneal ring segments, lamellar keratoplasty, and we can create the pocket for collagen cross-linking treatment. It's a fast treatment. In cataract, we use the 80 kilohertz energy. For corneal LASIK procedures, we use the 160 kilohertz energy. So what do we expect of ourselves with new technology? Perfection, happiness, confidence, and professional satisfaction. For that, what does we do? Change and adopt the new technologies, offer new technology to our patients. With the femtosecond laser, if you compare the capsular axis, it is much better and central than the manual ones, which gives the proper centration for intraocular lens. Lens fragmentation we can do in different patterns: spider waves, circular, radial, grid, any type of pattern we can do with the femtosecond laser. If you compare the effective phaco time, routinely in phacoemulsification technique, we use ultrasonic energies. But when we combine this femto with the phaco, there is less use of ultrasonic energies. So effective phaco time with the femtosecond laser is 0.16 plus minus 1.21 seconds only. If you do simple phaco, then ultrasonic energy phaco effective time is 4.07 plus minus 3.14. More you use the ultrasonic energy, there are chances of the damage of the inner layer of the cornea, which is endothelium. So in femtosecond laser, there is 96% reduction of effective phaco time. मिश्रा जी हो गया चलाइए. So this is a video of my case, one of my case. You can see here, this is the patient. First you dog the patient, then you create the capsular axis, and this is the lens. You can see here the lens fragmentation. After that, you can appreciate here the lens fragmentation is going on with the femtosecond laser. Now this lens is fractured into many fragments. These are the air bubbles which are separating the different layer. Now you can see here the corneal incision with the help of femtosecond laser. You can see here this is the corneal incision which is done by the femtosecond laser. This procedure is done into the clean OT, not in sterile OT, because there is no any open incision into the eye. Then you shift the patient in sterile OT. Just separate the already created incision by the femtosecond. This is the incision which is already there. Just what you are doing is just separating the incision, and after that you remove the capsular axis, which is the anterior capsule. You just have to remove it. This is the anterior capsule flap, which is created with the femto. After that, with the help of the phaco tip, we remove the already fractured lens fragments. It is very easy. Otherwise, in such type of cases, it needs lot of ultrasonic energy to do phacoemulsification. Since this is already separated, so it is easy to remove the lens fragments and suck into the phaco tip. So this case is over. After that, this is another case. You see, first is separation of the corneal incision. This is the primary incision for insertion of phaco probe. Here is the secondary incision. Again, removal of the anterior capsule flap, which is created by the femtosecond laser. And after removing this flap, removal of the lens fragments which are created by the femtosecond. So rest of the thing is same. Thank you very much.
Can we connect with the international speaker now? Dr. Shaunak Patel.
Yes, everybody able to see me now?
Yeah, you may start.
Okay, fine.
And I would request you to kindly
Uh,
finish off in around 8 to 10 minutes.
Certainly. So, are you able to see my presentation now?
Yeah.
Right? Good to go?
Yeah.
All right. Very good afternoon to everybody, all the lovely people hearing me. Today, the topic I've been given is beauty, health, and nutrition, a dermatologist way to read the face. Now, as a dermatologist in our daily practices, what are the signs we see in the people's faces that enables us to, diagnose the deeper troubles they have? So, moving on. Today's agenda is in four parts: the damages to beauty, the health and the hair, health and the skin, and lastly, what's my take and my philosophy. So, the damages to the beauty are primarily intrinsic and extrinsic. The intrinsic would constitute mainly the hormones, the lifestyle, and the food. So, as you know, that the lifestyle is very fast these days, and people don't consume the food they used to. That affects the hormones and causes a lot of interior stress and damage. Whereas on the outside, there's a lot of pollution, there's a lot of wrong kind of a knowledge in people, so that they're not able to take proper care. As a result, there is UV exposure, the damage, and a lot of other things. So then moving forwards, what are the reflections of internal health on the hair? So just by observing somebody in your OPD, what can you say just by seeing the hair? Somebody has balding. That indicates they have a high proportion of DHT and a lower estrogen. Right. This especially holds true for the male pattern baldness. The loss of eyebrow corners, that would mean that some thyroid malfunction is there. The facial hair on the females, definitely it shows a spike in the androgens. It can give a hint of PCOS or some upcoming danger. So they must get an ovarian profile done as soon as they can. Thinning of the hair can happen both in males and females. The causes would be different for both of them. But upfront, basically, the loss of protein, the protein breakdown, and severe omega 3 deficiency holds true for both of them, both of the sexes. For alopecia areata, which is the classical patchy loss of hair, it clearly shows huge vitamin D deficiency. Now, there are periods in between people who take injections of vitamin D that they forget their doses. So, during these phases, these patches develop. So, a constant vitamin D level has to be maintained along with a good level of biotin. Now, a lot of the times it has been seen that people undergoing long terms of stress also develop alopecia areata, corresponding to a dip in the testosterone because of the rise of cortisol during the stress. Moving forwards, on the skin, it's very challenging and interesting to see because skin, as we know, it's the largest organ and it's multifactorial. So, some of the common things I was able to summarize. Let's take a look one by one. The dark circles that would appear in somebody who has gone for a crash weight loss. somebody who has a very low vitamin K, especially vitamin K2, somebody who has anemia, and a slow blood circulation. Apart from this, there are huge, so many causes for dark circles. I can speak for 15 minutes just on the dark circles, but the time won't allow so. The swollen bags would chiefly indicate a sugar problem, any kidney issues. Oily skin would mean that you are consuming more of carbs. A spike in the androgen would mean that you're low on zinc. You have your freckles and pigmentation problem, that just shows that there is oxidation injury. Just prescribe antioxidants and half of the problem is solved. Patchy pigmentation would mean again a deficiency of vitamin D or a parasite infestation in the stomach in case of kids. Continuing it further, we see a lot of ladies after their pregnancy who have come to our OPD regarding the pigmentation concerns. They have melasma, they have some pigmentation. That chiefly shows that there is estrogen dominance. So that has to go away. How? We can refer to the endocrinologist and they can make a very nice treatment plan for them. Concurrently, our treatment can also go along. Flaky skin around the nose would mean low omega-3 and high omega-6. Now, this happens especially when somebody is consuming a lot of cod liver oil, a lot of deep fried food. So the balance has to be 1:1, omega-3 is to 6. But then the balance tilts and the 6 rises. So what you can do is you can take a lot of this pumpkin seeds and chia seeds to increase your omega-3 and balance this ratio out. Now the cracked corners of the mouth would mean severe deficiency of vitamin B2. We see a lot of kids nowadays who eat the processed food, especially here in the cities. So this is my common advice. Just give them B2 and send them home. Acne would mean again a spike in the androgens, especially holds true for the teenage. If it's not the teenage, then maybe it's related to eating sugars or more of the dairy. So chiefly the insulin-like growth factor 1 is associated with that. The perioral pigmentation very commonly seen at the B12 deficiency, right? And the red skin around the nose, chin and the forehead would again mean vitamin B6. Now this is not very prominent in the dark skins as such is in the white skins. Right. So moving on. What can you tell when you see the nails? Right. We often see the nails, we just see the clubbing. Yeah, a lot of the MD medicine people, they see the clubbing. But apart from that, what can you diagnose? So the horizontal ridges on the nails, that gives you an idea that there is severe vitamin B1 deficiency. Dry flaking cuticles, that would mean that there's very low biotin. Brittle nails, white specks, all these things are associated with high sugar intake because sugar competitively inhibits a lot of other nutrition, micro trace elements and vitamins that gives rise to this problem. Basically, you might have noticed a lot of hangnails, peeling cuticles. That again is a function of biotin loss over time. So you need to give biotin. The good way to give biotin is the white of the egg. But somebody who is not very fond of the eggs can go for the tablets, right? So moving forwards, what's the solution? The whole problem lies in the formation of advanced glycation end products, AGEs. As the word holds, aging happens because of the AGEs, right? The protein matrix, everything becomes intercalated with the sugar crystals. So what happens is over time it loses the elastin and the collagen, the skin and the hair. So basically, don't combine. It's a huge discussion. Don't combine your sugars with the proteins. Don't combine it
Dr.
with the
Shona,
deep fried fats.
Dr. Shona, kindly finish off in around 1.5 minutes. Kindly summarize.
Sure. So the second solution would be autophagy. This is again a groundbreaking concept given by Yoshiro Osumi in 2016, I guess. He won the Nobel Prize for that. So basically, if you fast for long, that goes into starvation, and then the body consumes the dead products, the end wastes, and again recycles back the entire thing. So autophagy is one of them, and a focused food plan, of course. So the take-home message would be that you must, sleep well, exercise, feel happy to keep the stress hormones under check, good food, and all. So, what's my take? What's my philosophy? My philosophy is that understand the body, read the early signs to reverse the damage, and refer in time for the best outcome. Thank you so much.
Thank you, Shonak, for a nice presentation, and we would definitely like to have you once again later on. Moving on to the next presentation, it will be by Dr. Yogesh Sharma, and it will be on TB recent guidelines. So, bye, Shonak. Thank you.
Thank you. Thank you.
And Yogesh, again, I would request you to finish off in 8 to 10 minutes. The speaker after this is Dr. Pradeep Kumar Jain, and I would request him to kindly be prepared for the next presentation.
Dr. Aditya. Yeah.
Good morning, everyone.
I'm very sorry, Dr. Yogesh. We just have to, our chief guest is here. So before the stage only, I'll request Pawan Sthapak sir and Tankha sir to please inaugurate today's event by lighting of the lamp and by offering prayers to Mata Saraswati. So we'll start by inauguration of the event, and then we'll have the award ceremony and take the chair, because unfortunately, despite a personal tragedy in the family, Pawan sir has come to us. He has to go to Chhatarpur. He's lost a family member, but you see his commitment. He's here with us, and I requested him to stay back, and he stayed back. His entire family is waiting for him in Chhatarpur. So that is why we are respecting Pawan sir's time, and we'll go ahead with the inauguration of the event first. विवेक अंकल के बारे में जितना बोला जाए उतना कम है. आज जितना आप ऑडियो विजुअल अरेंजमेंट देख रहे हैं, ये श्रीराम ग्रुप ने जो कराया है, दैट इज़ बिकॉज ऑफ विवेक अंकल. और न्यूज़ एक्स से विवेक अंकल ने हमारा टाई अप करवाया, इंडिया न्यूज़ से हमारा टाई अप करवाया. और जब भी मैं विवेक अंकल के पास जाता हूँ IMA के किसी भी काम के लिए, वो कभी हमें मना नहीं करते. थैंक यू सो मच विवेक अंकल. विवेक अंकल, इसके बाद आपके हाथ से हम स्थापक सर भी आज हमारे स्पीकर थे, तो उनको एक मोमेंटो दिलवाना चाहेंगे. और 2-3 स्पीकर्स और जो थे, डॉक्टर राजेश केवट है ना यहाँ पे, तो इसके बाद मैं मोमेंटो दिलवा देता हूँ, फिर विवेक अंकल की स्पीच करा दूँगा. सबसे पहले अकॉर्डिंग टू प्रोटोकॉल मैं रिक्वेस्ट करूंगा हमारे डॉक्टर पवन स्थापक सर के कि वो पुष्पगुच्छ के साथ हमारे चीफ गेस्ट विवेक अंकल का स्वागत करें। पवन स्थापक सर जो हमारे IMA प्रेसिडेंट, सक्षम के नेशनल प्रेसिडेंट, बहुत सारे पोस्ट पे हैं। पवन स्थापक सर, मैं रिक्वेस्ट करूंगा डॉक्टर पुष्पराज भटेले सर से, डॉक्टर नीरज सेठी सर से और डॉक्टर राकेश पाठक सर से कि वो भी पुष्पगुच्छ से विवेक अंकल का स्वागत करें। मैं रिक्वेस्ट करूंगा संगीता श्रीवास्तव मैम से कि वो भी पुष्पगुच्छ से स्वागत करें विवेक अंकल का। किससे दिलवा दें? जी, करवा। जी, मैं मोमेंटो दिलवा। अब मैं रिक्वेस्ट करना चाहूँगा सबसे पहले हमारे WHO कंसल्टेंट जो आए हुए हैं डॉक्टर योगेश शर्मा, उनका मोमेंटो विवेक अंकल के हाथ से और पवन स्थापक सर के हाथ से उनको दिया जाएगा। योगेश शर्मा। अब मैं रिक्वेस्ट करना चाहूँगा डॉक्टर राजेश केवट जी को कि वो आए, इनने डायबिटीज़ पे बहुत अच्छा टॉक दिया है अभी, वो अपना मोमेंटो कलेक्ट करें। अब मैं रिक्वेस्ट करना चाहूँगा आज के हमारे जो मेन कोऑर्डिनेटर्स हैं आदित्य परिहार जी, प्रोफेसर डॉक्टर वरुण भारद्वाज सर और विशाल कस्तवार सर को कि वो प्लीज़ स्टेज पे आएँ और विवेक अंकल के हाथ से अपना मोमेंटो ग्रहण करें। और अब देखिए पवन सर भी हमारे आज के स्पीकर थे, तो मैं विवेक अंकल से रिक्वेस्ट करूंगा कि पवन सर का भी इसी लगे हाथ सम्मान कर दें। अब मैं रिक्वेस्ट करना चाहूंगा पूरी ऑर्गेनाइजिंग कमेटी को स्टेज पे जल्दी आ जाएं, क्योंकि हमारे सुविनियर का भी हम फिर से अनावरण आज करवा रहे हैं विवेक अंकल के हाथ से। ऑर्गेनाइजिंग कमेटी के जितने लोग हैं, सारे लोग जो ऑर्गेनाइजिंग कमेटी में, मैं नाम नहीं ले पाऊंगा क्योंकि मुझे मालूम नहीं कौन कौन है यहाँ, बट जो ऑर्गेनाइजिंग कमेटी में प्लीज़ स्टेज पे आ जाएं। मैं सुविनियर का अनावरण फिर से करवा रहा हूँ और प्रेस में भी यही वाली फ़ोटो जाएगी, तो विवेक अंकल के पास जो खड़ा रहेगा उसको ज़्यादा फायदा होगा। और हमारे आज के शो के मेन हीरो रामेंद्र करसौलिया जी अगर आए हैं, क्योंकि 2 दिन से हम उनको याद कर रहे हैं बट वो आ नहीं पा रहे हैं, अगर आ चुके हैं तो रामेंद्र करसौलिया जी को मैं स्टेज पे बुलाना चाहूँगा, उनको स्मृति चिन्ह भी देना चाहूँगा। और उनको 3 दिन से नहीं आ पा रहे, विवेक अंकल आ गए बट रामेंद्र जी नहीं पहुँच पाए। रामेंद्र जी प्लीज़ स्टेज पर आइए। और इसी के साथ हमारी जो सुविनियर थी जिसमें विवेक अंकल का मैसेज है, जिसमें सारा कुछ है, वो भी हम इसी के साथ विवेक अंकल के हाथों से फिर से इनॉग्रेट करा रहे हैं। डॉक्टर बाबू सर भी स्टेज पे आ जाएं प्लीज जल्दी से। अब मैं विवेक अंकल से रिक्वेस्ट करना चाहूँगा कि हम लोग सबको वो अपने उस स्पीच से इनलाइटन करें, प्लीज़।
प्रिय डॉक्टर अमरेन, प्रिय नचिकेत पानसे, डॉक्टर नचिकेत पानसे, मेरे प्रिय सभी डॉक्टर मित्रगण, भटेले जी, पाठक साहब, संगीता जी, अभिजीत और तमाम आज उपस्थित भाइयों बहनों सज्जनों, Amren is a very enthusiastic person and he loves doing things. He's a doer, I'll put it this way. और उसकी कार्यशैली भी अलग किस्म की है. He likes to force things, also push things. And this is the sign of a efficient person. जो आदमी डूअर होता है, he likes to do things at any rate, at any cost. जब मैं रोटरी में एक्टिव था तो मोस्ट ऑफ माई रोटरी फ्रेंड्स जो क्लोज थे मेरे से यूज्ड टू बी मोस्टली सिख जेंटलमैन. तो लॉट ऑफ अदर्स वुड आस्क मी कि तनखा साहब आप इस जितने रोटरी में आपके फ्रेंड्स हैं, क्लोज फ्रेंड्स हैं, ये सिख क्यों हैं? मैंने कहा अंतर ये है, मैं आप लोगों से कोई काम बोलता हूँ तो आप मुझे 10 कारण बताते हो कि काम क्यों नहीं हो सकता, और मैं जब उनको काम देता हूँ तो वो 3 कारण बताते हैं कि काम क्यों हो सकता है. सो दैट्स द वे आई लाइक द वर्ल्ड टू मूव. एंड सबसे पहले तो कंग्रेचुलेशंस डॉक्टर अमरेन एंड हिज एंटायर टीम, डॉक्टर पानसे एंड एवरीबॉडी, कि आपने इतना बड़ा ये आयोजन किया. इट्स सच अ बिग फंक्शन. यू कनेक्टेड द वर्ल्ड विथ योर मेडिकल एसोसिएशन. You not only connected the state but the country, but internationally. So many doctors. You also connected lawyers, and they spoke on, I believe, medical negligence. And I'm so happy that such efforts have their own benefit, because at the end of the day, it's good education which leads to good results. जितना आप एजुकेट होगे, जितना आप समझोगे चीज़ों को, उतने रिजल्ट्स आपके बेटर होंगे. लेट मी शेयर विथ यू, जो मेडिकल नेग्लिजेंस का जो सुप्रीम कोर्ट जजमेंट है, इट इज़ एक्चुअली माई ब्रेन चाइल्ड. आई एम द वन हु आर्ग्यूड इट. इट वॉज जस्टिस लाहौटीज बेंच. ही वॉज द चीफ जस्टिस ऑफ इंडिया एट दैट टाइम. और मेरा व्यू था कि डॉक्टर्स आर अ प्रोफेशनल बॉडी. इट्स लाइक सपोज मैं कोई केस आर्ग्यू करता हूँ सुप्रीम कोर्ट में, हाई कोर्ट में या किसी भी ट्राइब्यूनल में, एंड द क्लाइंट सेज आई एम नॉट सेटिस्फाइड. नाउ क्लाइंट का प्रोफेशनल प्रोफिशिएंसी क्या है टू अंडरस्टैंड कि व्हाट आई एम सेइंग वाज नॉट द बेस्ट. क्योंकि आप जो मेडिकेशन देते हो, इट इज एज पर योर डायग्नोसिस. क्लाइंट, the patient may want a lot more, but diagnosis may not permit that. So, and especially surgeries may, of course, mistakes happen, but the question is not, एक होता है deliberate, or I would say not deliberate, but something which you, gross negligence के मारे, you leave something which should not have happened. And one is while you're doing your job, something happens. इसमें फर्क है. And that is the line I was telling the Supreme Court based upon Australian and European precedents at that time. कि साहब हम operate कर रहे हैं to the best of my ability. I may still fail. I'm a human being. He's also a human being. I don't know how when I touch this part of his body, how the other parts would react. 100% nobody knows. So that's what I explained to the court with all these precedents. And the court, Justice Lahoti, appreciated it because I believe he has many doctors in his own family. So he knew the problems of a doctor. So that is why we decided, and the Supreme Court said, that there would be a layer of protection before any case is registered by police against a doctor. मतलब आपका अगर complaint है, if you make to the police, the complaint will have to be sent to a body of experts who will evaluate your complaint, and then if they find it grossly negligent, of course case would be registered, you will be punished, because gross negligence is not acceptable. But agar if it is part of your professional duty which you are doing diligently, nothing will happen to you. And that has now become the law of the land, and it continues to be the law of the land. So जब अमरेन ने मुझे बताया कि जबलपुर के lawyers are going to speak on it, and I thought you told me Varun is also one of the speakers. So I felt nice. Number two, I felt always the doctors का जो एक role है, they have a much bigger role in this country than what role they are accepting and doing. Do you realize you had people like Dr. B.C. Roy heading not only their professional bodies, but also heading the biggest state of India, Bengal? And while he was chief minister, he would also do 2 hours of private practice without charging every day. So doctors' ka role doesn't finish with a clinic. Doctors have a larger public role. And it's time that doctors also came forward in public life to take up larger public roles. Jab tak India does not get into professional hands, you will continue to be in the hands of mafia. Sand mafia, liquor mafia, business hands, business people. क्योंकि होगा, क्योंकि उनके लिए this is protection. Politics is protection for them. It's like protecting themselves by getting into public life. So I am a great votary of professionals entering public life and taking public responsibilities also. IMA can take a very big role in this. Not only that, the other day I was addressing Rotary Clubs of Delhi. I was presiding over a function in which Justice Sanjay Kaul, the second senior most judge of the Supreme Court of India, who's also the chairman of NALSA. NALSA is the National Legal Aid Authority. And I told Justice Kaul in that Rotary meeting, which I also repeated 3 days back in a parliamentary committee meeting where NALSA had come before the parliament for grants. And Supreme Court Registrar General was there. Other officials were also there. Justice Secretary was there. Everybody was there. I said, legal aid was commenced by 2 people, Justice Krishna Iyer and Justice Bhagwati, if you remember, in the 70s. And they traveled all over India to create a climate for legal aid कि गरीबों को how legal aid can reach the poor. क्योंकि नहीं तो poor के पास पैसा ही नहीं है. How will you get justice? If there's no, first of all, to get justice, you need access to justice. So somebody has to create that access for you. Later on, 80s में, 89 में or 88 में it became a law, and now you have National Legal Aid Authority, State Legal Aid Authority, District Legal Aid Authority. तो मेरा एग्जाम्पल ये था कि आप लोग ने अथॉरिटीज बना दी, जजेस को बैठा दिया, ऑफिसेस खोल लिए, एंड ऑफिसेस में आप वेट करते हो कि हमारे पास जब कोई आएगा तब हम उसका काम करेंगे. I said you have reached a plateau, and if you want legal aid to become a reality, make it a public movement. Officiousness, officialdom cannot make a public movement. Public movement comes from through the will of the people. जब लोग डिसाइड करते हैं कि हमको समाज कल्याण में एक भागीदार बनना है, We have to be part of, we have to be stakeholders in the upliftment of the society. That is the time a public movement starts. Similarly, I want for doctors. And doctors can also, like access to justice must be at the doorsteps. I also feel medical aid assistance should also be at the doorsteps. कई बार हम लोगों को महसूस होता है, and this is a common complaint, रात को किसी की तबीयत खराब हो जाती है. It's very difficult to reach a doctor. मैं बुराई के तौर से नहीं बोल रहा हूँ ये, क्योंकि doctors also need rest. They also need to sleep. But you still need an arrangement which can act fast at night to reach the people. बहुत कुछ हो रहा है, हो भी रहा है. Emergency numbers आ गए हैं, बहुत सारी चीज़ें हो रही हैं. But it's not still good enough. आप अगर जनता से बात करेंगी, if you talk to common man, he will tell you कि अभी भी at times that रात को access to medical aid is not easy. I'm only putting these questions because I'm addressing a very learned fraternity. A fraternity which is concerned about people. A fraternity which is not only living for itself, but it is also living for others. You are a part of a very noble profession. In fact, doctors is a very, very noble profession. So that is why I felt that I must say a few things which may motivate you or may guide you to take up these other issues more seriously. I believe you still have a very wholesome conference. बहुत अच्छे papers पढ़े गए. Papers were not only read nationally, locally, but also internationally. You had award sessions also. And I believe you had a lot of interaction also. I think Amren and Dr. Panse, you've done a brilliant job. We will give you a separate award for this, not here, somewhere else. But this is the way young doctors should be working. This is the way this profession should be working. This is the way you should be involving not only yourselves, but involving others with you. And it's for everybody's gain. Ultimately, जब कोई बाहर से व्यक्ति अपनी बात आपको बताता है, अपने पेपर पढ़ के बताता है, तो उसके he has an idea. And that idea may also click to you. He may have a good idea also. जो अच्छा idea नहीं है, आप उसको discard कर दोगे. Nobody forces you to carry on with everybody's ideas. So it's a wonderful way of doing it. I don't know whether such conferences are happening as in the usual course, or it was a new initiative. Very good. That's why I said Amren and Dr. Panse are capable of new initiatives, and they've done it. And they've shown to the world, not only to Jabalpur, to the world, that IMA is not dead. IMA is kicking and alive. Well done, doctors. Well done, the new next generation of doctors. मैं देखता हूँ ना, मैं जब धीरावानी साहब का बेटा और पांचे साहब का बेटा और डॉक्टर मुखर्जी के बेटा सबका जब इन लोगों को देखता हूँ तो मैं कहता हूँ the next gen has arrived. The next generation has arrived. So the older generation now can take it easy. So I'm grateful that you invited me. I'm happy that you're doing well. I'm elated that you reached out to so many people all over the world, and let this become a beacon and as a mark of guidance for everybody else, that this is how the progress should happen. Let me thank Chintu, Ramendra. आपने इसको डिजिटल किया पूरे इस फंक्शन को, जिससे you have also shown the way that it's not necessary to invite people to Jabalpur or any place. आजकल की this is my fight also in the courts. Why should everybody go to court? Why can't you have more digital courts? Why can't it be on VC? Why should everybody go and stand? Why should everybody go and wait? World is changing. Technology is making you change. So take advantage of technology. Take advantage of the new science. Become more accomplished. Become more proficient. And I'm sure the society will benefit from your effort. Thank you. Jai Hind.
I'm so sorry, I forgot to felicitate our observer from the MP Medical Council, Dr. Bharti Sahu ma'am. She is here. She's been patiently observing everything. Last day she was, yesterday she was here for 10 hours. Today again she's going to be here for 10 hours. We salute your commitment, ma'am. Thank you so much. And we would like you to receive this award from the hands of Vivek uncle.
So, good afternoon, everyone. Thank you for inviting me here. Sir has talked about some community participation, and that I'm going to highlight what's new in the TB program. But before that, I would like to mention one thing. This is the first time I'm here in the IMA building, but my relationship with IMA is more than 10 years old. Patak sir might remind, we met in Delhi when we started IMA student wing. From those days and today, it's a big movement in MP. Thank you, sir. So today I'm going to talk about the Pradhan Mantri TB Mukt Bharat Abhiyan, what it is and how it is being implemented in the state and why it is the need of the hour. So, as you can see, the objectives are to provide additional support to the TB patient, because you know that nutrition is the key factor involved in the TB care, because patient, if it's not getting a proper nutrition, then the care cascade cannot be completed and he will eventually fall into the vicious cycle of tuberculosis again and again and again, and he will even continue infecting other people as well. Community involvement, which is much need of the hour, because there is somehow still after so many years the program is running, but there is a lack of IC, lack of interaction with the people, and if someone is infected with tuberculosis, isse dur rehna hai. I'm sorry to say that, but I have observed within many medical practitioners, even I'm not saying all, but a very few of that, but still they practice that वहाँ से बात करो, दूर से मास्क लगा के बात करो. You are right, you have to protect yourself, but at the same time, just imagine the condition. मुझे TB हुई है और उस वक्त मुझे कोई बोलेगा कि मुझसे दूर रहना, बात नहीं करना. The COVID, the pain we also felt. जब डॉक्टर हमें टच नहीं कर पा रहे थे, तो ना डॉक्टर को मजा आ रहा था, ना पेशेंट को मजा आ रहा था कि मैंने डॉक्टर को दिखाया है. The touch has to be there, the communication has to be there. So this is a step which central government has initiated, where we want to normalize tuberculosis as a normal disease. And also we are trying to leverage the corporate social responsibility scheme here. What we are expecting is the TB elimination, it will be a big major jump for the TB elimination program. Then it will generate awareness among the public, it will reduce the stigma, the out of expenditure of the patients will be reduced, and the nutritional and other outcomes of the patient will be improving. So who can be a Niksha Mitra? We call it a Niksha Mitra. Now you are helping the patient, it will be a Niksha Mitra. Any corporate organization, any NGO, any elected representative, political parties or individuals. And I'm happy to say that Sagar IMA Association Sagar has committed 100 patients to be adopted by them, and they are already supporting 5 patients. And in various capacities in different districts, 1 or 2 IMA members are already adopting the TB patients. So it is a very good start, and IMA is a very big body, like having 2.5 lakh of members across the nation. They can support many patients through themselves and with the help of their supporting partners. So minimum duration of support is 6 months, 1 year, 2 year or 3 year. Whatever you choose, you can go for it. You can select a particular patient, you can select a geography, maybe it a block, maybe it a PHC site, maybe a sub-health center site, whatever you want, you can just choose among it. What supports are offered, it's a nutritional support which is mandatory because nutrition is must. You know, still people practice not to oil and ghee and other nutritious things in TB. So this has to be supported. Diagnostic support you can offer, then vocational support and additional nutrition supplements if required. So this is the basic guidelines which you have recommended. Cereals and millets around 3 kgs, pulses 1.5 kg, vegetable oil, groundnuts, multivitamins, fruits, eggs, whatever one can afford. Just adopt at least one patient. That's what I request all of you. The status of Madhya Pradesh and Jabalpur I have compared here. The total Nikshmits which have agreed to support TB patients are 3,884, but the burden of TB you can see there are 96,000 patients still on treatment. So we need to increase the numbers. Actual patients who have received TB basket, food baskets in Madhya Pradesh are 6,600, while in Jabalpur it's 106 only, and only 22 Nikshmits are supporting these patients. So it's an appeal and it's a request to all of you to just think about it, connect with your respective district tuberculosis officers. This is not a big deal for a medical professional, for a doctor to support at least one patient for 6 months, and it hardly costs around 3,000 rupees. I myself am supporting more than 2 patients in some districts I'll not disclose here, but I'm supporting. So for IMA, I can say like it can adopt different models. There are 4 models which are being practiced at different states, at different levels. In Madhya Pradesh, since IMA is a big body, I am showing you these 4 models where one the DTO can directly share the line list of the patients with the IMA body, and the doctors can take up the patients. The IMA body can assign another NGO where the list of the patients will be provided and you can support the patients. Another model is through the PHCs or health and wellness centers through public distribution system, which we can explore. So these are the options which can be explored from your side. And another one option which is implemented very efficiently in Gujarat is through the Reliance Smart and Big Basket. They have connected the donors with the agency, and the agency is directly distributing the food baskets to their doorstep of the patient. So patient is not bothered and you are not bothered, because most of the time doctors can pay money, or even the donors can pay money, but they don't have time to visit the patient always, or just buy the basket and hand it over to the patient. But they can do it through an NGO or agency, maybe through the DTO or an NGO or the direct body like IMA, they can do it. So this can be planned out. And here now I'd like to highlight Meenakshi Kshatriya, who has done wonders in Madhya Pradesh, and not only in Madhya Pradesh, even at the national level. She is a 13-year-old class 8 student of St. Xavier's, Jabalpur, and she has adopted one patient in Katni district out of her pocket money. So she has done wonders, and everyone at the national level has praised her. And a matter of fact is, she is a resident of Jabalpur and she has adopted a patient in Katni. That's interesting. So geography is not a boundary for anyone. Whichever place you want to support all over India, you can. And together we can end TB for sure. I have few requests for the IMA president, sir, since I'm associated with you and I have the right to. So, sir, first of all, sir, notification is very, very important. And in Jabalpur, we have seen that only 2,287 patients were notified in the private sector last year, which is far less in comparison to Bhopal and Indore or Ujjain. The private sector size is huge as compared to those cities, but the notification was less. So I request you, sir, to kindly write a letter to all the IMA branches and request them, all the fraternity, to notify each and every patient. Second request to you, sir, kindly request all the members of your body in Madhya Pradesh to be a Niksha Mitra and take at least one patient, sir. Then another request to you, sir, whatever CMEs, IMA conducts a huge number of CMEs across the year, but we lack the connection between the TB program and IMA. So we have to establish it And what we need to do is, whenever there is a CME, we can inform the DTO of the concerned district and allot him 2 to 5 minutes, not more than that. Only 2 to 5 minutes to share the crisp information on the updates in TB. And the last request to you, sir. We doctors are very good clinicians, but we are not that good authors. We don't document things. Documentation is very, very important, and we need to document whatever our findings are. It may be a case study, simple case study, that this was the patient and we have found out, we treated this patient with these drugs, these were the challenges, and this is how we have treated this patient. This can be a simple case study. But when we see in a global view, there are so many case studies which will be helpful, because most of the time private practitioners come to us and they just say that in our practice we have seen this. That's fine, sir, you have seen this in your practice, but kindly document it. Only these requests to you, sir, and I'm thankful to you for inviting me here. Thank you so much, sir.
Thank you so much, Dr. Saab. And I promise you all of the things which you said, we'll write a letter to all our members. We will document and we'll publish all the cases also. And earlier there were regular programs of IMA, but because due to the COVID, the link broke. But I promise you in the next 6 months, we'll have at least 10 programs like this, and I invite you every program. And an excellent talk, and we will stay in touch with you. And I promise you full support. Thank you so much.
So the next session is by Dr. Pradeep Kumar Jain, and it will be on unrepaired congenital heart disease in adults.
में 2-3 इंटरेक्शंस भी आ गए, इनॉग्रेशन हो गया उस चक्कर में, मॉर्निंग में डिले हो गया, स्थापक सर को तो पहले हो गया, सबको यही बोल रहा हूँ कि जल्दी जल्दी करो। मेरे लेक्चर में मैंने 4 मिनट्स रखे, बस मैं 4 मिनट पूरा फिनिश करूँगा।
सर एक्चुअली ये जो है इसमें सिर्फ इंट्रोड्यूस करना है मुझे। दैट विल बी फाइन।
टाइमर तो मेरा मुंह ही है।
अच्छा जी 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 थैंक यू सो मच।
सो चेंज करना है।
वेरी गुड आफ्टरनून। वो बोल रहे 2 मिनट और रुक जाओ।
आपकी कौन सी है, ये वाली ले लिया था ना?
So we can proceed with our sessions now.
Very good afternoon. Very good afternoon to all the respected delegates sitting over here. So first of all, I would like to thank the organizing committee who has given me this opportunity to share my experience on this platform. So today my topic is unrepaired congenital heart diseases in adults. So we all know that congenital heart disease is the most common congenital anomaly in pediatric age group, but very few data about the unrepaired congenital heart disease in adults are available worldwide. So we decided to plan this study, and this is first of its kind from India. We all know that VSD, ventricular septal defect, is the most common defect in pediatric age group, while due to its hemodynamic effect, ASD is the most common in adult age. So considering CHD very rare in adult age group, there are high chances of errors in diagnosis of CHD. But with proper diagnosis, many of these CHDs are amenable to surgery and leading to improved quality of life. So the aims and objectives of this study was to to find out the detection rate of unrepaired CHD in adults, and to compare any discrepancy in diagnosis of CHD on echocardiogram report done other than our center. So this was a retrospective observational study conducted over a period of 1.5 years, and more than 18 years old patients who came for transthoracic echocardiogram for any reason were included. While repaired CHD, uncomplicated bicuspid aortic valve and PFO were excluded. Further, the reports were compared for any discrepancy in reports done outside our center, and then classified them based on their effect on management. So out of 6675 transthoracic echocardiogram, 89 cases of unrepaired CHD were diagnosed. That is 1.33%. So mean age was around 36 years with the female predominance. 91% were acyanotic and 9% were cyanotic. Most common CHD was ASD followed by VSD and then PDA. Out of these 89 patients, 8 were Eisenmengerized, and the oldest patient was 74 years old with congenitally corrected transposition of great artery. So this table shows the major classification of congenital heart disease and their types. So most common was left to right shunt lesion, that is 57 in number, and out of that, ASD was most common, that is 36. Rare cases like atrioventricular septal defect, AP window, RSOV were each one in number. Among obstructive or regurgitant lesions, aortic stenosis was most common, and there were 2 cases of coarctation. In cyanotic lesion, TOF was most common, followed by single ventricle physiology, and 1 case of CCTGA with VSD with PS was diagnosed. Among miscellaneous causes, Epstein and Oily was the most common, while idiopathic dilatation of pulmonary artery was found in two patients, absent LPA, corrected transposition of great artery, and arrhythmogenic right ventricular dysplasia, each in 1 cases. So based on the comparing the reports from outside, these reports were categorized as major and minor based on their discrepancy. So minor discrepancy where the diagnosis was not affecting the management of CHD, while in major the diagnosis was affecting the discrepancy, the management of CHD. So out of 25 discrepant reports, 16 were major. And this table shows the major discrepancies. So a case of VSD with RCC prolapse and severe AR was diagnosed as a case of severe rheumatic AR outside. Similarly, a case of congenitally corrected transposition of great artery with dysfunctional RV was diagnosed as a case of ICMP, ischemic cardiomyopathy with TR and MR. Diagnosis of coarctation of aorta was missed and was diagnosed as a case of eccentric LVH. A case of TOF with absent pulmonary valve was diagnosed as a case of VSD with pulmonary stenosis. And case of ASD and pulmonary stenosis were reported normal outside. Similarly, normal study was reported as ASD outside, and VSD with AR, which was reported outside, was actually restrictive AP window. So now I'll discuss few cases. So here we can see that on left side, the tricuspid valve is on left side. So this suggests that on left side the ventricle which is on the left side is not left ventricle, that is actually right ventricle, and the ventricle on the right side is actually left ventricle. So this patient was diagnosed as a case of ICMP, ischemic cardiomyopathy, but actually this was a case of congenitally corrected transposition of great artery, where RV was dysfunctional as it was pumping to the systemic circulation. Now this is the second case where a 24-year-old male with significant high BP on multiple antihypertensive for the last 3 to 4 years came to us with history of headache and leg pain. And in this parasternal long axis view, we can see that there is no significant left ventricular hypertrophy, and the size of LV is also near normal. But whenever a young patient with significant hypertension comes to me, I always put a Doppler in descending thoracic aorta, and that gives a clue towards the diagnosis of coarctation of aorta if we find a dampened Doppler signal, just like in this patient.
So please summarize in the next 1 minute.
So this was a suprasternal view where we got coarctation of aorta with maximum gradient of 70. This was a case of a 26-year-old lady with dyspnea on exertion with dilated RARV. Here we can see that atrial septum is intact, but in such case we should rule out RVOT obstruction. And in bicaval view, this patient has sinus venosus HD, which got operated, and this is the post-operative image showing no residual shunt, and patient is doing well in follow-up. This is 58-year-old patient with dyspnea on exertion with severe CCF, with features of CCF and severe AR, came to us but on echocardiography, and was diagnosed as a case of rheumatic AR outside. But on echocardiography, this was a case of restrictive VSD with prolapse of RCC into the VSD, causing restriction and severe AR. So this patient also got operated for VSD patch closure and aortic valve replacement, and is doing well in our follow-up. This was a case of 22-year-old patient with dyspnea on exertion, came to us with, and diagnosis was TOF with absent pulmonary valve, but was diagnosed as a case of VSD with PS outside. This M-mode examination shows that there is significant dilatation of LV and the ejection fraction was 35%. So this adolescent patient came to us with history of intermittent palpitation, sweating, headache and abdominal pain with significantly high BP and with features of congestive cardiac failure. So this patient on examination was found to have pheochromocytoma and the LV dysfunction was because of hypertensive cardiomyopathy. And this is the post-op image 6 months after the surgery and this shows normal ejection
So I think
fraction
we
with
should
normal
cut down
study.
now.
So concluding my this presentation, considering unrepaired CHD in adults as rare, many of these patients were misdiagnosed on clinical or echocardiographic basis. So emphasis should be given to detect congenital heart disease while doing echocardiography, and most of them, if managed, can have near normal life expectancy with no significant morbidity. Thank you.
So thank you, Dr. Pradeep Jain. It was really an enlightening talk. And now I would request Dr. Jiten Paryani. He'll be speaking on technology proving to be a boon to chemotherapy patients.
Thank
Dr. Jiten Paryani, please. And I would again request all the speakers to kindly cut down on the time, and you should focus more on take-home messages, what a general IMA doctor can learn actually. We do not want technologies in your specialty. We want take-home messages by which we can actually learn how to and where to refer the patients correctly.
Thank you everyone for giving me this opportunity to present my lecture on chemoports. We are talking about cancer treatments that have gradually been progressing. Now the technology and the treatments have progressed such that the cancer is mostly treatable. Even the patients that are non-treatable, cancer has now become a chronic disease. We can control them with chemotherapy regimes and the lifespans are gradually going on increasing. So when we are talking about the treatment, the chemotherapy forms the major part of the treatment. Slide. About 75% of the cancer patients will receive chemotherapy in one form or the other. It may be either be the sole form of treatment or maybe complementing surgery or maybe giving through radiation. Usually we give cancer chemotherapy through veins by mixing the drugs in the bottles and long infusions are being given. Like this is the gradual process that we usually determine in our hospitals and wards, and all these things have been associated with chemotherapy since long. But gradually over the period of time, since the chemotherapy regimes have increased, the lifespan has increased, the patients have receiving more therapy than ever. There's an increasing problem of vascular access. The patients are getting thrombophlebitis, we are not able to find the veins, all the veins are being exhausted. So this has constantly been appearance that we have taken through the messages and taking through in our wards. These have now become a gradual appearance. So as the technology has been available, the long-term vascular access to the chemotherapy patient has become a priority for all our patients. We are trying to make chemotherapy to our patients most comfortable. So the next device that has become is the chemoports. The chemoports are a small subcutaneous device that have been implanted inside the chest wall, which helps the patient to enjoy good quality of life while going under the chemotherapy and without any risk. These are small devices which are placed under the skin, which one end is placed inside the heart and provides permanent vascular access and easy access to the bloodstream. There is a small device that has been implanted in the chest wall, which goes through the subclavian vein or the interjugular vein into the superior vena cava and is implanted in the chest wall. And this can be placed inside the chest wall for about a year, 2 years, 3 years, as long as the patient is receiving chemotherapy. This procedure can be performed in local anesthesia or general procedure. Gradually, we are performing more under the local anesthesia. No blood reports are required, no requirement of patient coming nail by mouth. A 20-30 minute procedure can be performed and this patient can receive chemotherapy through port. See, this is the X-ray that will be showing the hub implantation of the place. The port is placed in the chest wall and the catheter is placed in the superior vena cava. See, the access to the chemo port is through the Huber's needle. It's a special type of a non-coring needle that can be placed that gives access to the chemo port and gives bloodstream access to the patients. We put the chemo port, the syringe inside the needle, and then we withdraw the blood, and then it can be used for chemotherapy. This is a kind of device that has been placed, and that has been placed under the patients, and the chemotherapy drugs can be given through that. It avoids the needs for pricking any veins, putting in any cannulas, multiple pricks. Blood can also be withdrawn for tests. CT scans, MRIs can also be done through this same. See, as we know, it provides a very good vascular access. Easy bloods can be withdrawn for various tests, and CT scans and MRIs can also be done. It prevents the patient discomfort, staff discomfort, medical facility discomfort, so that the patient can undergo easy chemotherapy. These are the multiple chemotherapies we are giving through this drug. Gradually, we have also started doing in pediatric patients. Vascular access in pediatric patients is very difficult, and so this is another patient we have done in 5 years old patient is suffering from non-Hodgkin's lymphoma. I would like to show a video. This is a small procedure that has been showing how we do it. This is a triangular mark for the alignment of the internal jugular vein. We are gradually cannulating it through putting the local over the chest wall and the infusion. Gradually cannulating the internal jugular vein. Passing on the guide wire. This is the dilator that we pass it through. The dilator is used for passing out the sheath through the neck axis to the internal jugular vein. Extending the incision. This is the guide wire that has been passed. See, this is the sheath that has been passed through it, and this is the sheath that will be implanted inside the body. It is made of silicone. It is inert, and it does not cause any reaction to the patients even after putting it for 1 or 2 years. We can see the blood flow coming through it. Now we will tunnel the sheath into the chest wall through a separate incision placed on the chest.
Jiten, can we move a bit fast, please?
Yeah. We are creating a space around the chest wall. See, this is a tunneler that we are passing through the chest wall through the neck incision. The tunneler has been passed and it has been connected to the end of the sheath.
So we have 1 more minute to summarize,
Yes,
please.
yes, please. The chest wall is out. We have brought it to the chest incision, confirming the blood flow. This is a device that has been connected, and this will be implanted in the chest wall, and the vascular access will be through this device. We are keeping it for 1 year, 2 years, till the chemotherapy is going on. We can keep it there. So in short, I would be liking to say that hemopod devices are the new technology that has been proving the boon for chemotherapy patients. Since the treatment now these days are going on for years and years together, it provides easy vascular access, access to for blood reports, investigations, etc. can also be done and can be kept into the body for about how many times, how many years the treatment is going on. It's chemically inert and it is usually a boon for chemotherapy patients. Thank you so much.
So thank you, Jitendra, and Dr. Atul Patel will take the next session, and I would really request Dr. Atul to kindly finish off as soon as possible with more of take-home messages and less of demonstrations. Dr. Atul Patel will speak on IPOM Plus.
क्या हो रहा है? ये इसमें ओपन नहीं हो रहा. एक्सक्यूज सर, इसमें ओपन नहीं हो रहा. हाँ, इसमें ओपन नहीं हो रहा है. ये ओपन नहीं. ये मेरे को दो, मैं वहाँ से प्ले करता हूँ. आपको देखना है इसको? नहीं, चलो फिर प्ले कर दो. डबल क्लिक. Excuse me. Morning, all of you. First of all, thank you very much, all organizing IMA committee. Special thanks to Dr. Amrin sir to giving opportunity to present here. I, Dr. Atul Patel, would like to present IPOM Plus next 10 minutes. Next. Before history. First, go back to history. First time introduced by in 1993, Dr. K. Leblanc did a 5 incisional hernia surgery. Used 1.5 to 6 centimeter defect size. They used PTFE mesh and stable fixation. They found less morbidity to conventional open repair. It was popularized and modified further worldwide. What is basic principle of IPOM? Basic principle depend on Laplace law of hydrostatic. It means forces that cause hernia formation are the same forces used to secure the mesh in place. Basic initial step of IPOM: adenolysis, hernia content reduction, bridging of the defect with mesh, and mesh fixation. Go back. See, I did this case, why this IPOM surgery is better. Here, this is the case of 45-year female comes with umbilical hernia. Anyone can tell how many defects are there? it looks like one defect. But glory of this IPOM, in intra-abdominal, you can see all defect. After dissection, we find, next slide, we can see there is two defect, which we can miss in open surgery. In laparoscopy, you are in the dome of abdomen. You can see each and every defect. Next. Basic modification. What is difference between IPOM and IPOM plus? In IPOM plus, apart mesh, we close the defect, which reduces seroma formation, mass migration, reduce less recurrent hernia, pseudo hernia, etc. Sac cauterization, okay. And sex is excision, reduce seroma. Mass coverage, 3 to 5 centimeter. I would like to prefer 5 centimeter. Many surgeons prefer 3 centimeter, but it's good to cover 5 centimeter hernia sac. Mass composition, composite mass or coated mass. And for fixation, we can use absorbable tracker, non-absorbable tracker, suture or glue. Not go into detail, but most and very important step is port placement. If you are a laparoscopic surgeon, you have to know where to place port. First thing, for umbilical hernia, we place port, left lumbar region, optical port and 2 working port. In infraumbilical hernia, we place epigastric port and optical port and bilateral 2 working port. In case of left lumbar, right optical port and 2 working port, and in epigastric region, infraumbilical optical port and 2 working port. This is very, very more important step. Keep away 6 to 7 centimeter from defect. Sorry. Next. Double click, please. I would like to show a short video of, this is 55 female umbilical hernia. Here you can see very well defect. This is the omentum content inside the wall, abdominal wall. Doing adenolysis very carefully and maintaining the hemostasis. You can see there is bleed. We maintain, you can see very well, this is hernia sac. After that, we make a preperitoneal mesh bed. Here, at least 6 to 7 centimeter peritoneal bed, we have to carefully make. This is very important step. Like in first slide, I said that if you not make a plane, you can miss that defect. And many times, it replace the mesh. Very carefully making the plane, pull down all contents. This is the hernia sac. You can see very well hernia sac. We excise it. Why we excise it? It's very important. Most common complication in incisional hernia like post-LSCS schemes, incisional hernia, umbilical hernia, any ventral hernia. If you sac left, it causes seroma. And it's hell many times in open surgery. Patient came 2 months, 3 months for dressing and dressing. That's why this step very important. This is the difference between IPOM and IPOM plus. We here close with V-lock suture or valve suture. This is two-way suture. We close antivert and retrovert. You can see very well this defect are closing with V-lock. This is the mesh. This is composite mesh. Why it's called composite mesh? You can see very well there is 2 sides. One glistening side, gelatinous glistening side, or another one is rough side. You put the glistening side in inner side and rough side to the abdominal sides. With the help of suture pusher, we pull out with percutaneous incision. With the help of needle, we identify the exact port where needle we have to push. After this, we pull out the suture one by one. This is technique important because between 2 threads, at least 2 mm distance would be there. You can see I am pulling out one by one suture. You can see very well stuck with abdominal wall. With the help of tracker, I am fixing the mesh. At least 25 to 35. You can see each 1 to 2 centimeter. I am fixing the mesh all over surrounding the mesh. You can see this absorbable suture. And we are already using transfacial, closing it Okay, next. For less time. Okay, what is the post-op concern? Post-op concern, basically most common complication for first 24 hours, pain. How can you reduce? You have to give good analgesia, tab blocker or abdominal binder. Most common late complication, seroma. How can you reduce? Already I have seen in my video, sac excision, defect closure, mass infection. In OT, you have to very sterile, like ortho surgery, in this surgery, and change gloves whenever you are putting the mesh. Difficulty in further abdominal access. Definitely, there is multiple adhesion in abdominal surgery, like came with incisional hernia, recurrent, and recurrent occurs. Recurrent occur. Technical aspect. What is difficulty? Definitely,
Dr. Atul.
difficult. Training supervision.
Dr. Atul, it's a request. Kindly complete now quickly.
Yes, sir. Then cost effective. We want to. This is costly. Transfacial and intracorporeal suture we use. Next, newer technique. Apart this, IPOM, TAPP, TEP, TARM, ETEP, RES, ETP, TR, Milos, Scola, and etc. Various surgery in hernia. With comparison, other method, we use IPOM for 2 to 6 centimeter obese patient. Next one. Various studies occur here. E-retrorectus repair. Here less pain, extraperitoneal mesh. Disadvantage is injury to nerve vessel and a large tissue plan. IPOM plus advantage is easy, reproducible, and maintain integrity of abdominal wall. Next. Please next. Various study. In this study, incisional hernia group have more recurrence chance than primary hernia, and non-absorbable tracker is better than absorbable suture tracker. Next. In comparison to ETAP and IPOM, in ETAP there is less post-operative pain, short hospital stay, and no difference between pre-op and post-op complication. Next, please. We talk about robotic ETAP did not reveal a benefit post-operative pain to offset the shorter operative time and surgeon workload offered to our IPOM. Next. We talk about 2 to 6 centimeter. Can we do more than 8 centimeter? Yes, we can do with IPOM plus more than 8 centimeter with the help of endoscopic abdominal compartment separation. Next. Can we do with recurrent hernia, recurrent incisional hernia, IPOM plus? Yes, we can. It's very last one. Yes, enormous stabilization in minimum SSS hernia repair, a lap IPOM plus, definite indication. This is offer well-out procedure, and nowadays many surgeons doing robotic IPOM plus. A properly done IPOM plus is properly selected patient gives great outcome. My personal advice is learn all the technique, use them judiciously. Thank you so much, sir, for listening me.
Dr. Atul, it's a request. Kindly be on the stage. And now I would request Dr. Behrani, sir, to come on the dais and please felicitate the speakers. Dr. Yogesh Sharma, Dr. Pradeep Kumar Jain, Dr. Jiten Paryani, and Dr. Atul Patel. And kindly pass on the mementos. Dr. Atul Patel. Dr. Jiten Paryani. Dr. Pradeep Kumar and Dr. Yogesh Sharma. Okay, then we'll move on with the next session. And next speaker is Dr. Vishal Kastwar, and he'll be talking about quest beyond hyperglycemia therapy in diabetes. Sir, wait a minute. We would like to request Bharani sir to please felicitate Dr. Vishal also before he commences his talks. Thank you.
Please connect this laptop. ये वाला connect कर दीजिए. So I'll be going very fast and we'll be discussing on what we should do in diabetic patients apart from controlling glucose and why. So, slide लगा दीजिए. So basically diabetes we believe is a disease of hyperglycemia and all of us are managing hyperglycemia, but it is not just hyperglycemia, it is a disease of cardiovascular, renal, retinal, neuropathic illness as well as musculoskeletal and psychosomatic illness, which is all progressive. So whatever treatment that we are instituting to our patients should focus on all those problems and the treatment should be progressive in the due course of time. The complications of diabetes that are usually discussed, DKA, NKH, hypoglycemia. Most of us will not consider anything beyond it. We are also managing our patients for prevention of dehydration, some patient who is nearing surgery, recent acute illnesses, and family or peer pressure is what for most of the patients will come for treatment. But these are only acute complications, but these will be rare and these need treatment but only sometimes. We need to treat these problems, CAD, PAD, we need to prevent all those problems along with psychosomatic problems which also include erectile dysfunction, insomnia, depression as well as aches and pains that keep on occurring. So diabetes treatment, there is a problem, we are not treating diabetes appropriately and this is the international data. 50% of our patients are undiagnosed, but among those who are diagnosed, only 1/3 of patients have achieved the target HbA1c of below 7. And that is why preventable complications are rising, because it is still being managed as an acute disease with very short-term glucose management goals, and we are managing it predominantly through drugs. There is no proper discussion on non-pharmacological supplementary therapy, monitoring, and adherence or motivation. Diabetes basically is a multi-front war and has to be managed on multiple fronts, which not only include diet, drugs, but also include exercise, and we not only need to manage hyperglycemia, we need to prevent vascular diseases, we need to manage the reduced flexibility that is happening in our patients, and insomnia, depression, diabetic distress, intimacy issues, and carelessness, all which is being developing in our patients. What we need to do is, we should think beyond management of hyperglycemia and diabetes, and that should begin with ensuring adherence and motivation. Most of our patients who would come to our clinic would just maintain the motivation for let's say around 2 months, 3 months, and the entire treatment motivation, if it comes, it will exist for just 2 or 3 years. Ensuring adherence and motivation is important because drugs don't work in patients who obviously do not take them. And this is the international literature. Approximately 20 to 30% of prescriptions are actually not picked up from the pharmacy itself. Most of the patients would just go to the doctor and will not take the treatment that has been prescribed by the doctor. 50% of adherence is there. 10% of estimated hospitalizations cost can be reduced by just ensuring adherence, and up to $300 billion in the US are being lost because of lack of adherence to treatment. What are the reasons for non-adherence should be identified: forgetfulness, concern about side effects, perceived lack of efficacy of treatment, perceived lack of requirement of treatment, and high drug costs all need to be managed in order to ensure motivation of patients. There are evidence-based approaches that have been defined in the literature, being discussed in conferences in order to ensure motivation, which begin with education and discussion. Motivational interviewing should include addressing the specific barriers of the patient. हमें patient से पूछना चाहिए कि what is the actual problem that you have because of which you are not adhering to the treatment. It may be pill size for some people, it may be the number of pills for some people, it may be the frequency of pills for some people, for finances it can be there, and dexterity and dependence. We should try to find out the problem and we should try to address it. Family involvement is what we are not doing for most of our patients. We should try to entrust at least one family member for the well-being of that patient. The husband should be asked in the clinic to take care of his diabetic wife. The children should be asked in the diabetic clinic to take care of their particular grandparent. If you entrust one patient in your clinic for the well-being of that patient, obviously the treatment adherence would be there, because in a chronic disease like diabetes, long-term treatment will become more and more difficult for a single mind unless he gets motivated by somebody else. We can do motivational phone calls and reminders from our clinic. There are methods which can be done and should be utilized prescribing glucose monitoring, as we'll go in the next slide, is important because glucose monitoring is a tool which actually lightens up this dark diabetes management picture. Hyperglycemia, the patient will never recognize that there is high glucose level inside the blood. And if he is not recognizing, he will not take treatment, or he will not take treatment for a long period of time. So glucose monitoring has to be prescribed on the basis of what his status is. What is the medicine he is taking, whether he is developing hypoglycemias, whether he is developing some acute disease, whether he is self-dependent, what his financial status is, what is the frequency of his visit to the clinic should decide whether he should monitor more frequently or not. And if the patient is living in a far away rural area, you may prescribe him more frequent monitoring and ask him to come at a longer, after a longer date. Again, prescribing size, we are just telling the patient to walk, walk and walk. Walk is a good exercise, but it's the least good exercise for your body. There are specific recommendations given by ADA regarding what exercise recommendation that a patient should receive. And diabetologists, clinicians, and I believe most of the GPs should apprise themselves about the options that we have for diabetic patients and what would the best exercise for diabetic patients. It's not only the walk. Walk may be just one of the exercises, but it's not the best also. There are different exercises that are recommended. If you are keeping on prescribing walk to your patients, there are a lot of patients who would come back to you and claim that they don't have time, they have knee problems, they have some muscle problems, and that exercise cannot be done, and you'll be just shut up. You should know the options that you have to all the patients, and you should also know what variation of exercise should be done. Walking daily is a good exercise, but if you on alternate day, if you can mix some muscle training, that would be better. And for those who are having age 75 years and more, you should try to include balanced training in exercises. Those patients who have knee problems, who cannot walk, you should give some literature, some training to the patient so that they can sit and do some exercises. These are a form of sitting exercise that the patients can do. These are some yogas that the patients can do if they don't get time to walk or they don't have space to walk. And these are some muscle building exercises that you can explain at least to those patients who can do it. These are the options that should be prescribed and advised to the patients if it is possible. Walking is not the best exercise. It is just one form of simple exercise that can be done. And reduction of sedentary time is another recommendation by American Diabetes Association, which says that after every 30 to 45 minutes, the patient should move for 2 to 3 minutes in order to prevent his, in order to improve the flexibility of his joints and prevent the muscles from going into spasms. Again, diabetes is not a disease which can be managed by medicines, exercise and diet. Vascular protection is one of the most important aspects of diabetes, because most diabetics, even if they are controlled, the possibility of them developing vascular diseases, heart attacks and strokes. Heart attacks increases by 2 to 3 times, strokes increase by 1.5 times. So vascular protection should be a part of all your prescriptions. It's not only diet, exercise, medicines, it should be vascular protection that should be provided to all the patients in order to prevent the future risk of heart attacks that the patients are going to develop. But for vascular protection, you do not only require to bring down HbA1c under control, you also require to bring down blood pressure to target for diabetic patients. For most diabetic patients, the blood pressure target would be around 130/80. Cholesterol levels have to be brought down, and it's not the cholesterol level that decides your vascular protection, it's the percentage of cholesterol that you have reduced from the baseline. So even for a patient who is having LDL cholesterol at 110, at the time of initiating treatment should have a target of reducing it by 50%, that is 55 milligram per deciliter should be the target set for the diabetic patient. All diabetic patients between age 45 to 75 years are recommended to take a moderate intensity statin, whatever the cholesterol level is, in order to prevent the long-term development of myocardial infarctions and stroke, and that should be included in all the prescriptions of all the diabetes patients. Aspirin was being given by a lot of diabetologists earlier, but it is not a standard recommendation now. It is only in the secondary prevention, because the incidence of hemorrhages were found to be only quite high with aspirin. Other aspects, sleep, sexual hygiene, should all be managed, and these things are, if the patient claims of insomnia, you will just prescribe a pill. But there are things that you can do in order to improve his sleep. It's not that only tablets can help the sleep. There are different strategies. Improving bedtime routines, sleep restrictions, stimulus control, relaxation. There are things that are available in the literature, but we can actually utilize those methods before we are prescribing pills to the patient. There are options, we should utilize them, we should learn and utilize them, obviously. Sleep is more important than screens. So we should tell our patients that at least 1 hour before sleep, you should stop all the mobiles and whatever screens that you are utilizing, and if you want to have a good sleep. Summarizing, we all have to do our part. We are everybody, all IMA members are treating diabetes, and we have to do our part. We have to protect the heart. Protect the heart through statins, whatever possibility that we can do. But we have to employ multi-pronged approach, and we have to obviously individualize. The multi-pronged approach in order to fight this multi-dimensional war should begin right from the beginning, because the disease is progressive and should be adjusted at every visit. Diet, exercise, monitoring and follow-up should be there in every individual's prescription, should be clearly prescribed. Diet, we only prescribe drugs. Diet has to be prescribed. Exercise, monitoring and follow-up apart from the drugs should be written in the prescription of the patient and prescribed accordingly. Motivation should be taken care of. You have to devise your own novel methods to motivate the patients. It may be telephonic counseling from your receptionist, it may be some WhatsApp messages sent by your dietitian, whatever. But motivation has to be taken care of, and we usually take care of motivation by employing some of the family member into the patient's prescription, that this family member will take care of this patient. Cardiovascular protection, kidneys, sleep and gut and intimacy issues are all important. Long-term quality of life and quality of work, both are important. It's the primary target. Yes, please. Thank you. Thank you.
Thank you for an excellent talk, sir. Now we will move on to our next session that will be taken by Dr. Mukesh Srivastava, sir, and he will be talking on star operation for ODS. So kindly, sir.
विशाल ने बोला एक्सरसाइज करना है, तो सब लोग खड़े हो जाइए. विशाल, come on. Exercise for 2 minutes. Zumba. विशाल आओ. ठीक है सर.
सर उसको सर लिंक भेज दीजिए बस. हाय गाइस, नमस्ते. अपना काम कर
Sabe o som que arrebenta, la 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 la, F250 explosiva, la 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 la, a explosão do som automotiva, la 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 la, sabe agitar e leva a loucura, la 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 la.
प्रेजेंटेशन मैं चला दे रहा हूँ. मैं प्रेजेंटेशन चला दे रहा हूँ. पेन ड्राइव उससे ले लीजिए. मैं 1 मिनट से पेन ड्राइव ले मैं यही चला दे रहा हूँ. हाँ, चलिए नेक्स्ट आपको करना रहेगा. आपको यहाँ कुछ नहीं दिखा, तो यहाँ डिस्प्ले करेगा, आपको देखना और नेक्स्ट.
कुछ नहीं वीडियो पीपीटी वीडियो नहीं बोलना है पीपीटी
Hello. So kindly make sure that the talk is completed within stipulated time because many of the speakers are waiting since morning.
I'll try to be very brief and just give an overview of this is a group of or a form of constipation which is very prevalent particularly in middle-aged females, and we know only the iceberg of this in these because of the hesitancy as well as patient don't come forward very easily, and when they are having a very long standing disease then they come for consultation to initially to the physicians and then to some colorectal surgeon or gastroenterologist. So the problem is this disease is that this is not a simple constipation, and this is a type of surgical constipation where if after proper selection of cases, diagnosis of the cases, if treatment by surgical means, the operation name is very catchy, the STAR operation, where we do the transanal resection of the distal rectum by staplers, sequential staplers, and thereby correct the defects which are there, anatomical and morphological defects which are there in the lower rectum, like the anterior and the posterior rectocele, as well as the occult rectorectal interception, intrarectal interception, and other deformities. So all can be corrected by this simply excising the full thickness of the lower rectum and correcting the, because this is a very distressing disease where the patient is having the very bad quality of life, healthcare issues. Patient has to go for motion multiple times in the morning, straining during the severe straining during the defecation. Also, when patient, also the patient in spite of multiple attempts and having the prolonged time in the toilet, still they are having the insufficient evacuation, and whole day they feel like, we know all that the constipation if is there, how it does badly, it affects our daily life. So what happened, Mishra ji? Mishra ji, my slides are not opening actually, I don't know why. So I'll just give a brief about this, what we do in this surgery, how we diagnose the ODS. The ODS are the obstructed defecation syndrome. Other than the slow transit constipation, we know that some patient, they come to you with history of passing 2 or 3 stool per week, or even some patient I have come to me with 1 stool per day. So this is a form of slow transit where their patient don't have any urge to defecate in the morning, and they say that they are okay, their appetite is okay, their normal life is there, but they don't pass the stool. So this is a type form of constipation where there is colonic inertia, or the colonic motility has decreased. So now I'll come to the मिश्रा जी यहीं से करना वहाँ से next ना. So this is the surgery. I'll just briefly give about it. The stapled transanal rectocele resection for ODS. This is the latest layer now recently developed surgery. The person here is the Dr. Antonio Longo. He is a legendary colorectal surgeon from Italy who has invented the PPH system as well as the stapler hemorrhoidopexy, which we all surgeons do commonly, has developed this procedure for STAR.
It's not moving. Okay. So what is ODS? ODS is also synonyms like pelvic floor dyssynergia. Means there is a dyssynergia between the muscles of defecations, and there is some anatomical and morphological defects which has developed in the lower rectum or in the rectum, like form of a rectocele, anterior, posterior, and occult rectorectal interception. There is in the definition is that there is a urge to defecate, but an impaired ability to expel the fecal bolus. And it is, as I have told, that this is because of some functional or the morphological defects are developed in the lower rectum or rectum causes this thing. It is a complex and multifactorial disease, and what we know is very small amount of the middle-aged females, male patient also they suffer, but mostly the patients are middle-aged, 35 to 55 years of his age, and they present with us in mostly. As I told that basically 3 types of constipation: the slow transit, IBS, and ODS. IBS is according to Rome 3 criteria defined as abdominal discomfort or abdominal cramps associated with constipation. Patient has to go 2-3 times a day, 2-3 times a week for motion, but there is abdominal cramps or discomfort is there. While in slow transit, there is no abdominal discomfort, only the frequency has very much decreased in these patients. And obstructed defecation is other type of form of constipation. Mishra ji, pani denge please. Yes, dekhna pani hai. So symptoms basically straining, incontinence, insufficient evacuation, in long standing cases, perineal pain, prolapse of the mucosa, mucosal prolapse, hemorrhoidal prolapse, and the most important pathognomic of this is the patient says that he passes the fragmented motion and he has to use his palm, his fingers for assisting the motion during the defecation. Either he or she puts his fingers in the anal region to defecate, or to put his or press his posterior vaginal wall or push the anterior perineum to facilitate the defecation. Basic difference between functional and obstructive is 2. Here the laxative in ODS doesn't work. Patient will be taking lot of laxative, lot of other things, in spite unsatisfactory result. While in functional, patient will have good satisfaction with the newer drugs, proclopride, as well as the good polyethylene glycol and the isabgol husk and other things. And second major difference is, or the differentiating point is, the use of fingers or the palm for assisting the defecation. Diagnosis is usually, it's a teamwork, gynecologist, radiologist, a colorectal surgeon, they are all involved in diagnosing this. Clinical history, as very classical symptoms of ODS are there. You do a complete systemic and parectal examination, do proctoscopy, colonoscopy to rule out any proximal cancer, irritable bowel syndrome, anismus, which is a form of where there is a spastic puborectal sling is there, and do, if available, the manometry, anorectal manometry, which rule out the anismus. And the most important investigation is to diagnose this disease is the MR defecography. We do in our clinics various Longos ODS score, Wexner constipation score, and symptom scoring system used for making this, giving the grading to this, how much ODS these patients are having. MR deficography is now available in our city. It is a deficography or a real-time or a cine mode of the MRI where the in sagittal section the ultrasound jelly is put in the rectum and the patient is asked to do the maneuver in the four positions: at rest, squeeze, strain and defecate. And this is the normal deficography, magnetic resonance deficography, and usually what we see in 90% of these suspected patients when they are submitted for the MR deficography, the anterior or the posterior rectocele or the intrarectal intersusception. This is observed in almost 90% of the patients, and if it is there, we measure the length of the rectocele and decide how much stapler we are going to use for resection of these rectocele. So this is in the squeeze mode of the MR phase of that rectocele is there and patient is defecating now, and we see the how much pelvic descent of the rectum has occurred to see for the rectal intersusception as well as the anterior and posterior rectocele.
Recording in progress. Recording stopped.
Initial management of all these cases is medical management by giving them the lifestyle modification, high fiber diet, and a biofeedback mechanism, which is a retraining of defecation in this patient. We trained by audio-visual measures. It is a special branch now, the biofeedback, where the patient is retrained for his defecation. And usually this work in about 30% of cases, and with lifestyle, high fiber diet, most of the patient with biofeedback, they respond. But when there is a failure of these medical patients, then patient is discussed with the surgical management, and we do this star operation where these staplers, the PPH1 is used. I'll not go detail in procedures. This is the OT table setting for star operation, where we use this spatula, the malleable spatula, to protect the anterior and the posterior wall.
Sir, we have very limited time.
Yeah, I'll finish in 1 minute. So initially anoscope is inserted, and then the by sponge test we see that how much is the redundant rectal wall is there, anterior posterior, and by giving the using the parachute sutures we ligate this, and full thickness stitches we take and we excise this. So basically we excise the lower or the distal rectum in full thickness by using the 2 or 3 sequential stapler in this procedure. So this is the donuts which come usually, a large 5 to 8 centimeter of donuts of full thickness. We recognize by full thickness by seeing that the whole of the perirectal fat is there or not. So this is the diagrammatic picture. What we have done, we have removed the whole of the distal rectum and anastomosis with this. So although it's a very safe and effective procedures, there are post-operatively very few complications. This is minimal invasive procedure, patient having very less post-operative pain, but there are some complications which may occur as occurs with every surgical procedure, but the complication is very, very rare in this operation. It's an effective cure for rectocele, rectal intersusception. Also, if patient is having the prolapsed hemorrhoid, they will also be cured by this procedure. And also there is one condition, SRUS present, solitary rectal, that is also be excised by this. So various studies, retrospective studies, colorectal registry in Europe has shown that this is a very safe, effective procedure, particularly if selectively after diagnosis of these ODS we do it, then the results are very good. Almost 90 to 95% patient will having the very excellent, very good and the good results. Thank you very much.
Thank you, sir. Nice session. That was nicely presented by Dr. Mukesh Srivastava, sir. Now I would like to call Dr. Virendra Ardwa, sir, to come, and his topic is thyroiditis, a self-limiting disorder.
Good afternoon, everyone. I would like to congratulate the organizing committee for this excellent meeting. The topic that has been allotted to me is thyroiditis, a self-limiting disorder. You see, there are few terminologies. Thyrotoxicosis is a state because of excess of circulating thyroid hormones. It may be of exogenous origin, it may be of endogenous origin, it may be a Graves' disease, it may be multinodular goiter, it may be struma overi. Any cause which leads to excess of thyroid hormone would lead to thyrotoxicosis. While hyperthyroidism is a condition in which there is ongoing release of thyroid hormone in excess of what is required. So every case of thyrotoxicosis is not hyperthyroidism, while every case of hyperthyroidism is thyrotoxicosis. Irrespective of the source of thyroid hormone, signs and symptoms are same. If patient has high T3, T4 level, irrespective of its source, it would produce certain symptoms and signs which are identical. These are the common causes: the Graves' disease, the commonest cause of thyrotoxicosis or hyperthyroidism, toxic adenoma, TMNG. There is inflammatory disease which may be silent, which may be dequirvin, which may be drug induced, or which may be radiation induced. These are cases in which there is inflammation of the thyroid gland which leads to release of stored hormone. There is no ongoing overproduction and continuous release on an ongoing basis. These are some other causes of thyrotoxicosis. Today's presentation deals with thyroiditis. Here is a 28-year-old lady, Gravida 1, Para 1, delivered a full-term child, normal vaginal delivery about 35 days prior to presentation. Relatives informed short-temperedness, irritability, poor appetite, not taking care of the newborn for last 20 days. She was non-communicative, weighed 47 kilos, had tachycardia, slightly elevated axillary temperature, staring gaze and hand tremors. Her T3, T4 free hormones were elevated and TSH was decreased. So she has thyrotoxicosis. But looking at the temporal relationship with pregnancy, with delivery, it was a case of postpartum thyroiditis in toxic phase. And she was prescribed only propranolol and responded with symptomatic benefit, and over a period of time the symptoms disappeared. Here is a 30-year-old man complaining of severe pain in neck for 4 weeks, painful swallowing, fever was moderate to high grade initially, but it was mild grade on presentation, had lost 4 kilos of weight in 1 month, had received antibiotics, paracetamol and PPIs. His thyroid hormone profile showed elevated T3, T4 and suppressed TSH. So he had painful thyroiditis along with circulating hormones being elevated. He was sick looking, warm to touch, had severe pain even on swallowing, tender thyromegaly, tachycardia, elevated temperature, differential and total counts were normal, but ESR and CRP were markedly elevated. This is pathognomonic of subacute thyroiditis. TLC, DLC is normal, but ESR and CRP are elevated, suggestive of inflammatory pathology. He was advised prednisolone in tapering dose, pantoprazole and propranolol. He reports 14 days later with complaints of reappearance of pain during swallowing during the tapering from thrice a day to twice a day schedule. Switched back to tapering regimen. 1 month later he was relieved of symptoms and subsequent course was uneventful. There is a 34-year-old lady presented with weight loss, tremors, palpitation. She had tachycardia, hand tremors, lid lag, grade 1 goiter, hyperthyroxemia, anti-TP antibody was positive. She was advised carbimazole and propranolol. Based on classical clinical picture and hormonal profile. 2 months later, she complained of lethargy, tiredness, weight gain. She had put on more than 2 kilos of weight. Pulse rate was low normal. Facial puffiness, dry skin and hoarse voice. And thyroid hormone profile was in grossly overt hypothyroid range. So within 2 months of treatment from thyrotoxicosis, she became hypothyroid, clinically and biochemically. So we have seen 3 cases, one of postpartum thyroiditis, second of subacute thyroiditis or post-viral thyroiditis, and third of silent thyroiditis. Thyroiditis is inflammation of thyroid parenchyma which leads to release of stored hormone and signs and symptoms of thyrotoxic state. There is no ongoing overproduction and release. The released hormone is tackled and there is hypothyroid phase with varying duration and of varying severity. During this phase, patient may require thyroxine supplementation. Many of these patients revert back to euthyroid over a period of several months. The only painful condition of thyroid is dequerulin thyroiditis, which occurs after a viral infection, Coxsackie, Eco, mumps, and more recently SARS-CoV-2 have been implicated in causing painful thyroiditis. This familial clustering and HLA-B35 association has been demonstrated. It is rarely recurrent and mostly it leads to complete recovery. In very few cases it leads to permanent hypothyroidism. Silent thyroiditis is usually autoimmune. There is thyromegaly, painless, non-tender thyroid enlargement. Anti-thyroid antibodies are positive, and on starting anti-thyroid drugs, within a matter of 2 to 3 months they become hypothyroid, which is unusual in a case of thyrotoxic state. Postpartum thyroiditis is again autoimmune, resolves in 2 to 3 months, initial psychiatric and toxic manifestations, and 4 to 6 months later they become hypothyroid and may require supplementation. This is the progress. In the acute phase, T4 is elevated, TSH is suppressed. For a period of 2 to 3 months, there is a reversal, T4 declines and TSH begins to rise. And in the acute phase, thyroid uptake scan shows suppressed uptake, while in a case of hyperthyroidism, it should be increased uptake. So, based on clinical suspicion, we ask for anti-thyroid antibodies, and if we are suspecting Graves' disease, the specific antibody is TSH receptor antibody. It is a bit expensive, but it is worth it to make a correct diagnosis, and technetium-99 scan is the diagnostic in the early phase. Normally, in overactive gland, there would be intense uptake of thyroid, intense uptake of tracer in the thyroid bed, while in this lady there is hardly any uptake. This is pathognomonic of thyroiditis leading to thyrotoxicosis, and this patient does not require anti-thyroid medication. As against this is a patient with multinodular goiter with 4 areas of uptake of radiotracer. She is multinodular toxic goiter. Thank you.
Thank you, sir. Thank you for such a nice presentation. Now I would like to call Dr. Kaveri Shaw ma'am to take over mic, and her topic is management of DUB.
Good afternoon, and I really congratulate our team IMA, Dr. Amrin Pandey, for making this event a wonderful success, that today we are all here in single roof, that we are attending with so many dignitaries in this place. I'm thankful to everyone, and I'm going to talk on abnormal uterine bleeding. Myself, Dr. Kaveri. So what is the prevalence, why we are talking about? Abnormal uterine bleeding is one of the disease we can say every female is facing in day-to-day life. When they are suffering, it really affects her social and family life. It affects the quality of life, and the prevalence of disease is around 3 to 30%. The higher incidence occurring around at menarche to perimenopausal women. So this is the age group where most of the women, they don't come with the problem directly, and they really try to be at the home and try to escape to come to the clinician. So how to go ahead with treatment plan and how to decide how we should give the treatment. First and foremost thing, we should make aware our society that abnormal uterine bleeding is one of the things one should always alarm, and all the clinicians should go ahead with the Palm-Cohen classification. Previously, we used to say that abnormal bleeding is like 3 days, 5 days, in intermenstrual bleeding like that. But nowadays, we need to follow a proper strategy. The strategy is said Palm-Cohen classification. It is the acronym used by Federation of International Gynecological Society, where the P stands for polyp, A for adenomyosis, L for leiomyoma, M for malignancy and hyperplasia. These are the structural causes. Other than that are non-structural causes like coagulopathy, ovulatory dysfunction, endometrial disorders, iatrogenic causes, and otherwise not classified causes. So one has to go with the detailed history of the girl and the woman. One should ask for the concomitant use of any medication, any medical illness if she is suffering from. The coagulopathy part need to be assessed very nicely because it may be the one of the cause. History of heavy bleeding starting at the menarche is important. Other than that, any women who has suffered with the postpartum hemorrhage, bleeding associated with dental work, surgery-related bleeding has suffered, at least 2 of the following symptoms she has ever faced, like at least 1 episode of bruising of mouth, epistaxis, frequent gum bleeding, family history of bleeding. In such cases, coagulopathy assessment needs to be done. So how to ask a woman and how we can judge that the bleeding is abnormal? We need to go ahead with the frequency of menses. The frequency should be less than 24 percentile women should have 30 days cycles. If it is less than that, we need to ask how many days they have suffering from. Regularity of the cycle is need to be assessed. 12 months total cycle, they have to chart it out, and if it is absent for 1 year, it is no bleeding case, it is not, no, it is menopause in the higher age. But it is in the young age, it is abnormal. It really need to be worked. If it is regular in 30 days, it's good. It is irregular, we need to ask 2 to 20 days or more than 20 days. More than 20 days, if it is irregular, need to be assessed. The flow of the bleeding should be, if it is 4 to 8 days, normal. More than 8 days or less than 4 days is again abnormal. The volume need to be assessed. The normal flow is 20 to 80 ml. If it is less than 20 ml or more than 80 ml, need to be assessed. So what is the basic pathophysiology? If we see the blood supply of the uterus, the uterine and the ovarian arteries supply the blood to the uterus, and these make the arcuate arteries. These arcuate arteries send off radial branches to the myometrial layer, endometrium, and then the layer of the endometrium is formed after the progesterone shut off. This layer is fallen off. So when there is a bleeding, these vessels are opened and there is heavy bleeding. So the breakdown of the functionalis layer lead to the bleeding. This is the anatomy of the uterus. So how to assess? Need to go for the initially laboratory testing. A complete blood count. A woman with anemia maybe have the one factor. Blood type and cross match need to be done. Pregnancy test should be done in any women who is having abnormal bleeding, irregular cycles, or having absent cycles. Disorders of hemostasis like prothrombin time, activated prothrombin time, fibrinogen time need to be assessed. Other than this, valve-relevant factors and other laboratory tests like thyroid stimulating factor, serum iron profile, liver function test should be assessed. How to go for imaging? The best method is MRI, which provides detailed images and that can provide a useful guide for surgical assessment as well. But if it is not, it is becoming costly, one can go ahead with the hysteroscopy and sonohysteroscopy, which gives a better diagnosis of the cause. Most of the time, polyps are missed in transvaginal USG. But mostly we go ahead with the first choice as a transvaginal USG as a primary assessment. So this is the take-home message, that if a primary assessment TVS, as we are doing because of the cost, we can go ahead with the hysteroscopy. We can offer for the hysteroscopy and MRI when the treatment plans are not helpful for low-cost patient. So what should be the treatment strategy? Treatment of abnormal uterine bleeding depends on the multiple factors with the etiology, AUB, fertility desire, clinical stability of the patient, and other medical comorbidities. So acute abnormal bleeding need to be assessed fast and should be treated immediately with the hormonal methods as a first-line medical treatment. IV conjugated equine estrogen, combined oral contraceptive pills, and oral progestins can be given to acute episodes. Other than this, we can use tranexamic acid and NSAIDs.
And please summarize the topic. So we are very limited.
In the coagulopathies, tranexamic acid and desmopressin are helpful. Ovulatory dysfunction cases need to be assessed and PCOS should be treated. Other than that, endocrine pathies, hyperprolactinemia, thyroxine disorder should be treated. Endometrial disorders have no specific treatment and mechanisms are not understood. Other than this, iatrogenic causes like IUCD, if kept inside, has to be judged. So, take-home message is acute abnormal bleeding should be treated with hormones and treat tranexamic acid. Thorough clinical assessment and detailed history is important. Histopathology is required for long-term treatment. Treatment as per Palm-Cohen classification should be done. Individual therapy should be tailored based on the patient's reproductive wishes and medical comorbidities. Thank you.
Thank you, ma'am. Thank you so much for such a nice presentation. Now I would like to call Dr. Abhishek Srivastav sir to come. His topic is sexual dysfunction in males from basics to advancements. Next, Dr. Piyush Jain sir, please ready रहिएगा.
किस फोल्डर में है ये?
Now no more number we exchange serial number. So please come to your serial number and no exchange will be accepted now.
अरे मैंने ग्रुप में भेजा था ना यार.
पीयूष जैन सर रेडी रहिए आप, इसके बाद आपका टॉक.
इसमें नहीं है यार, देखो और किस ग्रुप में है.
Sir, if you have any
Aajo,
problem,
aajo.
then we can.
Aajo.
Okay. Now I would like to call Dr. Piyush Jain sir to come. I take over to Dr. Abhishek Srivastava sir, and his topic is paradigm shift in management of cancer. That is modern day linear accelerator. Dr. Piyush Jain sir. अभिषेक श्रीवास्तव सर के बाद डॉक्टर छवि द्विवेदी मैम प्रिपेयर रहें. इज शी देयर, डॉक्टर छवि मैम?
Good afternoon, everyone. I am Dr. Piyush Jain, radiation oncologist. So, first of all, I would like to thank the organizing committee for giving me this opportunity to speak in this conference. So, as we all know, that cancer is curable if detected early, but this is a partial statement. The complete statement is cancer is curable if detected early and treated correctly, because even if an early stage cancer is not treated correctly, it will become an incurable cancer later on, and that will be life-threatening also. So what are the prerequisites for a correct treatment? So first is the appropriate workup, that is appropriate metastatic workup. It consists of good clinical examination backed by appropriate pathological and radiological investigations, and appropriate infrastructure in terms of the best of expertise like radiation, surgery and chemotherapy, and best of the equipments. Those are the modern equipments which are available for curing the cancers. So depending on the site of disease and the stage of disease, we decide whether a single modality, that is oncosurgery, radiotherapy or chemotherapy will be used, or a combination of all three of these or any two of these will be used to treat the cancer. So in my today's presentation, I'll be speaking on the technological advancements in the field of radiation oncology that has changed the face of oncology in terms of the management of cancers. So to begin with, what is radiation oncology or radiotherapy? Radiotherapy is nothing but it uses X-rays, gamma rays that targets the DNA within the cancer cells, thereby destroying their capability to reproduce. Now coming to what we want to achieve with radiotherapy, the aim of radiotherapy. The first is delivering the tumoricidal dose to the tumor target, and at the same time minimizing dose to the surrounding structures. We can compare it with airstrike, where it strikes the enemy targets without doing collateral damage to the civilian population. So before proceeding further, briefly about the history of radiation oncology. As we all know, X-rays were discovered by William Röntgen in 1895, and the first treatment of cancer using radiotherapy was done in 1896. So initially, the equipments those were used for treating cancer using radiation were very low energy X-ray machines. But the disadvantage of this machine was it could treat only the superficial cancers and not the cancers that are located at the depth in the body. So then came the era of cobalt 60 machines. It again used lower energy gamma rays, which were not capable of treating tumors located at the depth. And the biggest disadvantage of this cobalt 60 machine, what it can deliver only the two-dimensional manual radiotherapy techniques. So this caused the prescribed dose to the tumor. In addition to that, surrounding tissues also used to get the same dose. So when we used to deliver a high dose to the tumor target, the surrounding tissue also used to get the same dose. So this resulted in high rates of high-grade toxicities. So the compliance with of patients with this technique was very less, and when and patients used to leave the treatment in the middle also, and they were not able to get the complete treatment. So this resulted in high rates of failure. So again, coming back to the same slide of what we want to achieve with radiotherapy. So as we have seen, the lower energy X-ray machines and the cobalt 60 machines were not able to achieve this target of curing the patients and avoiding the collateral damage. So now the question arises, is it possible to achieve this aim? So the answer is a big yes. With the help of modern linear accelerator machines, which deliver high-end sophisticated radiotherapy techniques like IMRT, IGRT and VMAT techniques. So LINAC basically is a X-ray emitting machines. It can deliver very high energy X-ray beams in the range of 6, 10 and 15 megavoltage, and it can penetrate deeply with very improved precision and accuracy. So before proceeding further, briefly about the workflow in a radiotherapy department, which most of us are not aware of. So depending on the site of the disease, we immobilize that part of the patient body using thermoplastic sheets, as we can see in the image alongside. And we take CT scans of that area of interest, and these CT scans are transferred to the treatment planning system, where radiation oncologist and medical physicist work in tandem to generate multiple plans. And the best plan is chosen for the actual treatment on the patient and is transferred to the LINAC machine. So this is a schematic diagram to show the difference between the modern radiotherapy technique, that is IMRT, and the older conventional radiotherapy technique that we used to deliver with cobalt 60 machines. As we can see that the kidney shaped region in the middle is the tumor. Consider this as a tumor, the red colored, and the green dot is a organ at risk, which may be any organ. Like for gynecological malignancy, it can be rectum and bladder. For head neck, it can be spinal cord, parotids. So the arrows shown from the three directions is the radiotherapy beam. So it is directed towards the tumor. But since the target is irregular in shape, the old cobalt conventional technique used to deliver same dose to the tumor target as well as the organ at risk. But nowadays, with the advent of IMRT, we can safely exclude the target, exclude the organ at risk from the high dose and deliver the required tumoricidal dose to the tumor,
Sir,
thereby
please,
achieving high
summarize.
rates of cure and avoiding collateral damage, and patient can live can be cured with good quality of life without have to manage the side effects. So there are some applications of IMRT and VMAT which I would like to show here. So
Sir, please summarize the topics.
Yeah, just 1 minute. So as we see, this is a prostate cancer. So the red shadowed area is the prostate, and we can see how beautifully the IMRT has conformed to the target. But at the image at the bottom shows that in addition to the high dose to the target, other structures are also receiving the rectum, bladder, some adequate, good amount of radiation. So it resulted in bladder and rectum toxicity, which even after achieving cure, patient used to suffer from these toxicities afterwards also. But with IMRT, we can achieve cure without the patient dealing with these toxicities. So again, in case of head neck cancer, we can prevent parotid glands from receiving high dose of radiation, thereby preventing permanent dry mouth or xerostomia, preventing spinal cord from radiation myelitis, and much less acute mucositis and skin reactions as compared to the older techniques. Then again, in gynecological cancers, we can achieve high cure rates without the patient receiving high-grade genitourinary and gastrointestinal toxicities. And again, we can see in brain tumors, the brain tumors are also irregular in shape, but the high-end radiation has beautifully conformed to the shape of the tumor, as against conventional radiotherapy, where high dose is delivered to the superficial tissues and the part of tumor is not getting the adequate dose, resulting in lesser cure rates. So, to conclude my talk, first of all, we should be convinced that cancer is curable, because we as doctors, we only break the news in front of patients that you have cancer. And if we sound depressing, then the patient loses hope. So we should be very confident that if a patient is diagnosed with cancer, that if he receives a correct treatment by with the help of good expertise and high-end technologies, cancer can be cured, not even in the early stage, but advanced cancers we are seeing nowadays, they are being cured for a very long period of time. So, just one minute. So the treatment of cancer should be done by a team of oncologists to achieve the best outcomes. And again, LINAC is, as I have shown, is capable of delivering all the high-end radiotherapy sophisticated techniques which were not possible in the olden era. And we can achieve high cure rates with good quality of life. And lastly, world over, cobalt centers are getting replaced by modern radiotherapy machines. Thank you for your patient listening.
Thank you, sir. Thank you for such a nice presentation. Now I would like to call Dr. Abhishek Srivastava sir to come and present. His topic is sexual dysfunction in males from basics to advancement. Now I would like to request all of you rest of lectures, please try to concise your lecture because we have very limited time. So just 5 to 6 minutes maximum, you complete your lecture.
हाँ बस फर्स्ट स्लाइड लास्ट स्लाइड यार ये कैसे दिखेगा ये तो आ नहीं रहा है भाई आज लगता बोल नहीं पाऊंगा
नीचे ना मैम वर्ड में नहीं नहीं माइक्रोसॉफ्ट पीपीटी में खुलेगा
ये क्या
वो पिक्चर मैंने जरा वो नहीं मेरा भी वही आया था फिर मैंने बाद में चेंज कर देना कन्वर्ट कर रहा है इसको तुम कंप्यूटर में तो पैसे
याद तो
प्रोग्राम लो प्रोग्राम
हाँ
ऑफिस में जाओ ना ऑफिस मैं इसमें नहीं
हाँ है ना
ये एक्चुअली क्या कर रहा है ना ये पिक्चर कन्वर्ट कर दे रहा है मैं वहाँ से ओपन कर भी उड़ा दिया
हाँ वही ओपन कर दो हाँ स्लाइड चेंज करते रहना
इसमें पीपीटी का वो डालो
अरे इसमें लग जाएगा
दूसरा लैपटॉप लगा लो
6 मिनट हो गए बस 2 मिनट बच रहा है ग्लोबल कॉल बंद करके हेलो भैया at last my talk came. So good afternoon everyone. Thank you Amreen and the whole organizing committee for inviting us and organizing such a beautiful and huge conference. And today my topic, I'll be very quick क्योंकि किसी को शायद interest है नहीं. And I'll be quickly briefing on the male sexual dysfunction from basics to advancement. The two most important problems which a male faces actually are the premature ejaculation and erectile dysfunction. Okay. Now premature ejaculation, there is no need to tell what or to explain what is premature ejaculation, but it is actually the loss of control over ejaculation and it causes distress to either one or both the partners. There are various categories as how we can define the premature ejaculation. But all agree that intravaginal ejaculatory latency time of less than 60 seconds can be termed as premature ejaculation. But most different countries have different categories as how they define premature ejaculation. But in Africa, less than 120 seconds is actually defined as premature ejaculation. So we can compare it. In India, it is less than 60 seconds, and in Western and African countries, it is less than 120 seconds. Now, epidemiologically, if I say the prevalence of premature ejaculation actually in male varies between 20 to 30% in South Asian subcontinent. These data are the Western data, the US data, but still if we look at the US data also, the prevalence varies between 4 to 39%. That is the most distressing part. And rates generally not affected by the age, marital status, race or country of residency. And what is the problem? The first is the Indian disconnect between the diagnosed and the reported prevalence of premature ejaculations. Male do not often spontaneously go to the doctor and get and complain themselves about the problems, and clinicians also don't inquire about this common condition. And more on the disconnect, if we talk about the global study of sexual attitudes and behaviors, if we look at this data, only 9% of men reported that they had been asked about their sexual health by an MD or the managing doctor. So this is the most distressing part, because we as a doctor do not tend to take these problems seriously, and we do not actually discuss these things with most of our male patients who are actually in their mid age of 45 to 50. And believe me, males, those who are between 45-50, and if they suffer from dyslipidemia or diabetes or hypertension, the prevalence of premature ejaculation or erectile dysfunction increased by almost 50%. Embarrassment, certainly. Do not medicalize the problems and perceive that the provider is not able or willing to address the problems. Why don't providers ask about these problems? Lack of the knowledge about premature ejaculation, low prioritization by medical system, and no FDA or DGCI approved treatment options, basically. Because the data are very limited. Etiology, basically not known, exact etiology is not known, but it could be combined as a physiological and psychological factors. Primary premature ejaculation, more of a neurophysiological, while acquired could be attributed to psychological or related to a medical condition. No physical examinations actually are there to diagnose premature ejaculation, and no laboratory test available to confirm the diagnosis. Only thing by which we can assess is through the conversation between the dialogue between the patient and the doctor, and can consider psychological tests to assess for anxiety disorder. See, anxiety is one of the most common problem which actually male faces, and it is one of the most important cause where a male suffers with premature ejaculation and erectile dysfunction, anxiety. So basically, treatment of anxiety also helps in treating these patients. Now, treat the underlying cause, whether there are infections, UTI also could cause premature ejaculation. Some pharmacological interventions are there, and certainly behavioral interventions. Most importantly, behavioral interventions are the cornerstone of the treatment of premature ejaculation. So if we talk about the pharmacological interventions, some topical anesthetics are there, tricyclic antidepressants certainly, SSRIs, and PDE5 inhibitors. Now, topical anesthetics, most of us do not actually use, but their mode of action actually desensitize penis and therefore increase the ejaculatory time. How to use? Apply to penis 20-30 minutes prior to intercourse and wash off before the intercourse. That is, but most of us do not actually prefer these things. Now, tricyclic antidepressant, certainly mode of action could be presumed to act via neurotransmitters involved in inhibiting ejaculation or cavernosal muscles. Some drugs could be clomipramine, and but potential side effects are there associated with clomipramine, and dosing and regimens are not standardized as per the FDA or DGCI approved protocols. SSRIs could be one of the most important drugs where premature ejaculations could be treated. Mode of actions act certainly through serotonin receptors in inhibiting ejaculation. Paroxetine, most important and most beneficial drug in the treatment of premature ejaculation. How to use? Can take OD or on a continuous basis or on a combination of both. Potential problems, side effects, and doses and regimens not standardized as per the FDA or the DGCI guidelines. Now, the most important side effect with paroxetine or dapagliflozin or duloxetine is hot flushes, even in males, headaches, and some symptoms related to irritable bowel syndrome. If we talk about the doses, fluoxetine 5 to 20 milligram per day, but 20 milligram per day is most effective in treatment of premature ejaculation. Paroxetine 40 milligrams, varies between 10 to 40, but 20 milligrams 3 to 4 hours before the intercourse is the prescribed doses. Sertraline and clomipramine are usually not prescribed because of potential side effects, but the only two drugs which can be prescribed safely are fluoxetine and paroxetine. Dapagliflozin are also used for the treatment of paroxetine in combination with PDE5 inhibitors. Now, PDE5 inhibitors for the treatment of premature ejaculation, data are very limited, and it is controversial whether PDE5 inhibitors are beneficial in treatment of premature ejaculation, but certainly premature ejaculation associated with erectile dysfunction, then PDE5 inhibitors could be of benefits. So one of them example is sildenafil, and 25 to 100 milligram 1 hour before intercourse could be given easily. But problem is limited benefits in many studies, side effects, and expensive. Now, if we compare of oral medication, multiple studies proving efficacy in delaying ejaculation in many SSRIs and TCAs, but SSRIs are selective serotonin reuptake inhibitors are most important and beneficial drugs in the treatment of premature ejaculations. For SSRIs, paroxetine seems to work the best, with sertraline and fluoxetine close behind. And the evidence of sildenafil is the weakest, particularly without concurrent erectile dysfunction. Now, secondly, very quickly, we'll discuss erectile dysfunction. Now, the consistent or recurrent inability of a man to attain or maintain an erection sufficient for sexual performance. 5 to 35% of men have moderate to severe erectile dysfunction, and if a person or a male is suffering from metabolic disorders, then the prevalence rises to almost 50% of men, those who are in the age group of 45 to 55. Now, if we talk about the men's attitude of life events and sexuality, even in India, this study was done and the prevalence was found to be 20 to 23% in Indian subcontinent. And in the males study, 8% of men in their 20s also reported erectile dysfunction. So it's not only the males varying between 45 to 55 years of age, even males who are at the age of 20 to 25, they also actually suffer from the various degrees of erectile dysfunction. Epidemiology, age-dependent disorder, and rates depend on how it is defined. What causes erectile dysfunction? Most importantly, neurovascular phenomenon is there, basically, and how it's very pathophysiologically बहुत ज़्यादा हो जाएगा, but I'll not go into that, basically. But vascular causes, cavernosal muscle relaxation problems, neurological problems, and hormonal causes, and psychological factors are could be attributed with the most common causes of erectile dysfunction. And among those, vascular and neurological problems, and neurological basically anxiety, depression, any kind of what we can say neurological problems then increase the prevalence of erectile dysfunction. Medications known. Many medications linked to erectile dysfunction. Most importantly, antihypertensive drugs, thiazide diuretics, and beta blockers. Among beta blockers, metoprolol is the most common drug which causes erectile dysfunction and hypogonadism also. And antidepressants, certain antidepressants are there which causes erectile dysfunction. Among them is duloxetine is the most common, and certain hormonal drugs which also cause erectile dysfunction. Now, treatment. Counsel and educate the patient and partner, most importantly. Identify and treat any psychosexual dysfunction, most importantly, and then medication and devices and surgery. Surgery is the last option for the treatment of erectile dysfunction. Weight loss, if a person is obese. Exercise, smoking cessation. We all know smoking, alcohol intake is actually one of the most common modifiable causes of the prevalence of erectile dysfunction. Now, the drugs. Cornerstone, PD5 inhibitors, sildenafil, tadalafil, and vardenafil. Most importantly, all three are similarly effective, and 75% of men on medications have satisfactory erection to complete intercourse. And no large head-to-head trials still have done to compare the three available medications. That is the reason why all three drugs are similarly effective, and some patients prefer one over the others. If we talk about the dosage, sildenafil 50 to 100 milligrams, when to take 1 hour prior to the sexual intercourse, and the duration of action is less than 4 hours. Tadalafil 10 to 20 milligram, half an hour to 12 hours prior to the intercourse, and duration of action is 36 hours. And vardenafil could be taken half an hour to 1 hour before sexual intercourse. Among these, tadalafil has the most highest or the longest half-life. So tadalafil has a benefit, has a more of efficiency and efficacy. Now, what to tell patients about PD5 inhibitors? They still require sexual stimulation to have erection.
Sir,
1 minute. 1 minute. Sildenafil's absorption may be reduced by foods, especially fatty foods. Expect maximum efficacy in 1 hour and 2 hours after tadalafil. And first few doses may not be successful. Try 6 to 8 times before giving up. And side effects: headache, indigestion, flushing, nasal congestion, and blue of the vision. Contraindications: not to give in with nitrates, most importantly, not to use if severe cardiovascular disease or congestive cardiac disease. Caution: use of vardenafil if it has prolonged QT, and care if on alpha blocking agents may cause significant hypotension. Thank you.
Thank you, sir. Thank you. Nicely presentation. Nice presentation. Now I would like to call.
The important message, Abhishek, what you have given, the premature ejaculation is 1 minute in India and 120 seconds in Africa. So if the person is performing more than 1 minute, then he is having no premature ejaculation. And in Africa, if he is performing more than 3 minutes,
Just one clarification I would like you to elaborate upon. You've been talking about premature ejaculation and erectile dysfunction. That is all right. Erectile dysfunction we can understand. What about premature ejaculation? How do you measure the female premature ejaculation?
Hello.
most of the females might be coming to, sir, you might also be seeing the patients that males are not saying, but females are saying that the patient is having premature ejaculation. But what is the definition? They don't know that how much time is normal and how much time is abnormal. So what is the take home message?
Female sexual dysfunction is more difficult to manage. Both hypoactive sexual disorder as well as dyspareunia, they tend to compromise the sexual health quality of females. Regarding premature ejaculation, it is quite subjective and it can be tackled to some extent by digital manipulation.
Thank you, sir. Now I would like to welcome Dr. Chavi Divedi ma'am, and her topic is pediatric eye disease and overview.
Recording in progress.
Good morning, everyone. First of all, I would like to thank the organizing committee to give me the opportunity to speak. I am talking about the local anesthetic agents. Local anesthetic agents are the drugs which upon topical application or the local injection causes reversible loss of sensory perception in a localized area of the body without loss of consciousness and without loss of control of vital functions. Broadly, they are classified based on the duration of action into ultra short acting, medium acting and longer acting. Lignocaine comes under the short acting group with a duration of action of 1 to 2 hours. And bupivacaine, ropivacaine, they come under long acting local anesthetics with a duration of action of 4 to 8 hours. Now, based on the mode of application, they are divided into topical anesthetics and the injectable anesthetics. Cocaine, lignocaine, tetracaine, benzocaine comes under topical anesthetics, that is the surface anesthetics, and lignocaine, tetracaine, bupivacaine and ropivacaine comes under injectable anesthetics. Briefly, procaine and chlorprocaine are the low potency and with the short duration of action. Lignocaine, prilocaine have the intermediate potency with the intermediate duration of action, and this tetracaine, bupivacaine, ropivacaine comes under the high potency with the longer duration of action. Based on the chemistry of local anesthetics, they are again divided into ester-linked and amide-linked. Ester-linked are metabolized in the plasma by the pseudocolin esterase, so they are shorter acting, and amide-linked are metabolized by liver enzymes, so they are longer acting. In case of liver diseases like the cirrhosis of liver or where the hepatic blood flow is decreased, their metabolism is decreased, leading to the toxicity. So amide-linked examples are the lignocaine, bupivacaine and the ropivacaine. Now, allergy rarely occurs with the amide-linked group, and cross-sensitivity occurs with the drugs in the same chemical class. Mechanism of action, they block the nerve conduction by inhibiting the sodium influx through the sodium ion channels. Now, coming to the individual agents, lignocaine is effective by all routes like in surface anesthetics, and they are also effective in the injectables. They are faster acting and they have long intermediate duration of action. Addition of adrenaline in 1 in 2 lakh concentration will prolong the duration of action. In the therapeutic concentration, it has quicker CNS effects, but in case of overdose, it causes muscle twitching, fall in BP and respiratory arrest. Lignocaine is also used as anti-arrhythmic agents. Amla cream. Amla cream is the eutectic mixture of local anesthetics, that is the lignocaine and prilocaine. We apply it 1 hour before the IV catheter insertion, and in case of skin grafting, that is the plastic surgeries. Now coming to bupivacaine, it has no topical effect but is more potent and has a longer duration of action. And the techniques by which it is used are the infiltration, spinal block and epidural block. In a concentration of 0.25 to 0.5% injection, it is an excellent analgesia without significant motor blockage. So it is mainly used in the post-op pain relief and also the labor analgesia. It is more cardiotoxic than other local anesthetics, so it's never given IV. It prolongs the QT interval. Levobupivacaine. Levobupivacaine is the S enantiomer of bupivacaine. It is equally potent, less cardiotoxic, and it is less prone to cause seizures as compared to bupivacaine. Ropivacaine, it is a newer bupivacaine congener. It is equally long-acting, but is less cardiotoxic. It blocks the A delta and C fibers, which are mainly responsible for the pain perception more than the A beta fibers. Now coming to the clinical application, surface anesthesia. Surface anesthesia is topically, we are using it on the mucous membrane and the abraded skin of the nose, mouth, bronchial tree. Example are the lignocaine spray on the in throat, which acts within 3 to 5 minutes and action lasts for 45 minutes around. Infiltration anesthesia is the dilute concentration of local anesthetics are injected directly into the tissues under the surface skin, irrespective of the course of nerve. It will block the sensory nerve endings. And the dose required here is more as compared to the area involved. And we use it in the minor operations, as in case of hernia or FA, etc. And field block. Field block is the injection of local anesthetics subcutaneously. All nerves coming to the field are blocked, and the knowledge of neuroanatomy is required. Now, dose required here is less with a prolonged duration of action. Now, field examples are the field block of the anterior abdominal walls and scalp block. Nerve block. Local anesthetics injected around the individual nerves or the plexus. Now, here the area of resulting anesthesia will be larger. Examples are the brachial plexus block, intercostal nerve block, and the muscles coming in the nerves are also blocked. Now, coming to the spinal anesthesia, it is mainly used for the lower limb and lower abdominal surgery. Drugs most commonly used are the 0.5% heavy bupivacaine. Next is the epidural anesthesia. Epidural anesthesia we have divided into lumbar epidural anesthesia, thoracic epidural anesthesia, and the cervical epidural anesthesia. And drugs here most commonly used are the lignocaine, bupivacaine, and the ropivacaine. Now, newer techniques are the iontophoresis and the liposomal bupivacaine formulation. Coming to the local anesthetic systemic toxicity, it is because of the excessive plasma concentration of the drugs, because of the accidental intravascular, intrathecal injection, or the unwanted excessive dose. The clinical manifestations are the CNS toxicity and the CVS toxicity. CNS toxicity, early stages are the lightheadedness, dizziness, disorientation, and the drowsiness. Later, occurring the muscle twitching, tremors, and the generalized convulsions leading to the respiratory depression and the respiratory arrest. The CVS toxicity causes direct action on both the heart and the peripheral blood vessels. It causes the myocardial depression and the hypotension. And finally leading to the severe hypotension, arrhythmias like the sinus bradycardia, ventricular tachycardia, or the asystole. So how to manage the local anesthetic toxicity? It is stop injecting the local anesthetic, seek help. Initial focus will be on the airway management and the control of seizures. Now, also the lipid emulsion therapy we are using, and first we will give the bolus followed by the infusion. Finally, the lignocaine sensitivity test. It is the local anesthetics are injected on the extensor surface of the arm in a small volume, and the reaction produces a wheal of few in diameter within 15 to 20 minutes. Thank you, sir.
Thank you, ma'am. Thank you for such a nice presentation. Now I would like to call Dr. Nishant Tiwari, sir. And his topic is pediatric eye disease and overview.
Good afternoon all. We are already late of time, so I will try to finish it early. First of all, I would like to thank IMA Scientific Committee to give me this opportunity. So pediatric ophthalmology and overview. Today I will be covering about the visual milestone, how to assess vision in children, their GLASS prescription, myopia prevention, amblyopia treatment are little bit about the strabismus and pediatric cataract. So first visual milestone in our children are eye contact. Eye contact, like in this photo you can see the father and the kid is having a very good eye contact. So this is not only a pediatric developmental milestone but also a visual milestone. The kid with good vision will have good eye contact, and this is even can be seen in the first week of the kid's life. When the eye contact is poor, like in this photo you can see the mother is trying to look at the kid's eye, but the kid is placing his face here and there. Also you can see his elder brother is standing here with glasses. So there is a genetic history of glasses. So the kid is hypermetrop, kid is able to see the distant object but unable to recognize the mother face. And as soon as +4, +6 glass is given to kid, the kid first sees his mother's eye, and now look, after glasses this kid is having a very good eye contact, and you can appreciate the kid's smile after first time seeing his mother face. So glass may be required in children even in first 6 months, first 3 months of age also. So this is a special kid showing no interest in his surroundings, but when glasses are given of hypermetropic glasses, these kids start seeing the near object. So kid when born, these are generally hypermetropes, they use their accommodation and they see clearly the world. But these special child and flaccid type of palsy have poor accommodations and hence the poor near vision. Awareness of hands and hands in the midline is another milestone. These kids tend to see their hands, they change the shape of their hands, and this help in their developmental milestone as well as visual milestone. The kid tend to bring both the hands in the midline and sees them properly. You can see the convergence, the eyes are coming inwards. So these, when these kids use their accommodation, these all milestones show that the kid has a good vision. Goal directed reach to the age of 6 months. At 6 months, these kids tend to see other kids and they copy their activities. So these all activities are possible with good vision only. If kid does not do these type of activities, then this is a sign that the kid should get an eye checkup. Recognition of familiar faces, that strangers' anxiety should be present by 7 months. If not, then again, it's a sign for eye examination. Visual assessment in children require time, patience, understanding, motivation and attention of the patient. So this is a central study and maintain fixation. Like you can see when the recording device is moving, you can appreciate the kid's eyes are moving. These are straight, there is no deviation, and these eyes are following the recording device. So the fixation is known as central study and it is maintained throughout the movement. Now these are the charts which are used to check the vision. These are preferential looking charts. These are the cards with a hole at the center. The kid is seated in front of that card and the examiner looks through this hole. The kids have a tendency to look towards the striped lines. And there are several other charts with narrowing of these striped lines, and you can then appreciate the vision and even compare it with the Snellin's type of visual acuity of the kids. So these are Teller's acuity chart. The circular optotype is known as Keeler's acuity chart. Then there are Lea grating. These are just like your table tennis bat, and you can just swing it around the child and see whether the child is fixating or not. So these are Lea symbol chart. Only 4 symbols are used in this: square, circle, house and apple. What we do, we generally give the patient around 2 to 3 years a sample of these chart and ask them to bring it, and through a distance of 3 meters, these chart visual acuity can be calculated. These are the Cardiff type of chart. So another which is generally used by neurologists is VEP, visual evoked response. Even in patients with very poor vision, this response can be appreciated. To detect the amblyopia, what we do, we generally patch one eye of the kid. So when we patch the eye with the poor vision, the kid will be comfortable, like seen in this first image. And in second image, when we patch the better seeing eye, the child will become cry and he will not be appreciate the vision. So glass prescription in kids is a pretty tricky topic, and it requires much time, dedication and corporation from the kid. Retinoscopy is done using atropine cyclopentolate, and based on the retinoscopy data, glasses are prescribed. Very small children, age around 1 to 2 years, they all have some amount of refractive error, but these are not given. This is the chart by American Association Academy, which shows when to prescribe a child. So when there is deviation, the child glass prescribed at very less age also. Now coming to the myopia, myopia prevalence is increasing particularly in the Southeast Asia. So this was the data from year 2000 when high myopia was there in 2.7% of the kids, and with time it is increasing to 4 and 5.2%, and it is expected that the population in kids will be half with myopia, about 10% being in the range of higher myopia. If you will see...
Sir, please summarize. We have very limited.
Myopia trend is increasing particularly in Southeast Asia. You have seen Chinese people, Singapore and Japanese people wearing very thick glasses. So to prevent the myopia, first of all, the child should be given a proper glass prescription. These are the pamphlet by the Singapore government. The child should give less time to computer games. Even reading causes high myopia. Outdoor activity should be increased. The sunlight and low dose atropine are being used presently for myopia. So to prevent amblyopia and to treat the amblyopia, traditional treatment is patching, and current some binocular games and binox therapy is also available to treat the amblyopia. Now to treat the strabismus, it can be either esotropia and exotropia. First I will show some esotropia. So this kid is having esotropia, and this presented to us at the age of around 2 years. Right eye is the dominant eye, left eye is non-seeing eye. Left eye squint surgery was done, and these are the result post squint surgery. So what you can see, the child become more beautiful and good cosmetic correction. But why we did the surgery? To prevent the amblyopia in this eye and to get the child a better three-dimensional vision, stereopsis, and a better binocular single vision. So these children should be operated below 2 years of age to get the functional outcome. These are the accommodative esotropias in which eyes are aligned using the hypermetropic plus glasses. You can appreciate a very large angle esotropia which is corrected with glasses only. Now exotropia, again this child we are following this child since 6 months of age, having left eye exotropia, operated at age around 18 months of age, just to get the well alignment and stereopsis. These are some of our kids with very good alignment and even getting stereopsis post-operatively. So our neuro friends must get these patients like this. This lady is having a traumatic bilateral third nerve palsy. Both eye medial rectus recession and vertical recti transposition is done. What you can see, a very good alignment. The residual amount of esotropia was later on managed with the prisms. Then the superior oblique palsy. Okay, so thank you for your patience.
Thank you, sir. Thank you for such a nice presentation. Now we'd like to call Dr. Hajit Kaur ma'am, and her topic is digitalization in healthcare. Ma'am, please come and take over. Dr. K.K. Sohana sir, sir, is he there? Oh. Amitesh Dove sir.
गुड आफ्टरनून एवरीवन। काफ़ी देर हो गई, हाइपोग्लाइसीमिया हो रहा है तो हाइपोग्लाइसीमिया में बोल दूँ नहीं, पर दूसरा टॉपिक ज़्यादा इम्पोर्टेंट है तो अभी प्रेजेंटेशन आने में टाइम है। डिजिटलाइजेशन इज़ वेरी इम्पॉर्टेंट। सभी फील्ड्स में डिजिटलाइजेशन हुआ है। हेल्थ केयर हैज़ रियली लैग बिहाइंड एंड स्पेशली इन इंडिया, जहाँ पर कि को प्री कोविड टाइम्स तक हम लोग लास्ट 3 में आते थे as far as digitalization is concerned. COVID has really been very challenging और पूरा मेडिकल फ्रेटर्निटी जो है वो एक सेंस ऑफ अर्जेंसी फील कर रहा है टू कन्वर्ट टू अ डिजिटल वर्ल्ड। तो हम लोगों के सामने बहुत बड़ा काम है और इट इज़ एक्चुअली गोइंग टू हेल्प अ लॉट। अगर हम लोग सही तरीके से अपना काम करें तो बहुत सारे एफर्ट्स विल बी सेव्ड एंड प्लस वी कैन गेट डेटा विच वी कैन यूज़। चालू हुआ? ओके, सो people are talking about robots, cabots and other things. ह्यूमन एफर्ट को डिक्रीज़ करने के लिए बहुत सारी चीज़ें हैं और फुल स्क्रीन। सो हाउ कैन वी अप्लाई दैट टेक्नोलॉजी टू आवर साइंस, दैट नीड्स टू बी सीन। सो इट हैज़ बिन फाउंड दैट ओवर 90% ऑफ द डॉक्टर्स फील कि हमको अर्जेंटली डिजिटल वर्ल्ड में चेंज करना चाहिए और इसकी यूज़ करनी चाहिए। नेक्स्ट प्लीज। सो इज़ इट अ रेवोल्यूशन? क्या हम डिजिटलाइजेशन में जा रहे हैं तो क्या ये रेवोल्यूशन है? मैं तो कहूँगी नहीं, रेवोल्यूशन नहीं, इट इज़ एन इवोल्यूशन। लाइक वी हैव इवॉल्व फ्रॉम एप्स एंड ऑल, so this is also part of evolution, and if we don't do it, maybe we'll go extinct in some time to come. So the evolution is from bedside of the patient to website. Next. Next please. So everybody has a smartphone in the hand and maybe they know to operate it better than us. So having a smartphone makes you very smart. The patient has become very demanding. So the new concept now is patient-centric. And we have to think beyond prescribing drugs. उसके आगे सोचना पड़ेगा। Drugs prescribe करना हमारा basic काम है. But now we have to think of customer experience. Next. There is a growth of on-demand healthcare. Patient बोलता है हमको ये चाहिए और उसको gradually हम लोगों को एक continuous healthcare में convert करना है, where we have to follow our patients. बहुत सारा data generate होने वाला है. Virtual reality, wearable devices which are becoming intelligent every day are coming into play. So medical fraternity will have to spend a lot on artificial intelligence so that they can stay abreast with the things which are coming forward and use it for their benefit. Next. Industry has to innovate, find out methods to meet the patient demands. And organizations who do this will definitely be far ahead others. They will definitely better benefit most and get dividends sooner. Next. So what do we do for a transformation? अभी हमारे क्लिनिक में पेशेंट आता है, हम देखते हैं, दवाई लिखते हैं। फॉर कंप्यूटर एक ऐसी चीज़ है जिसको जो हम सिखाएंगे वही मालूम है। इट इज़ नॉट गोइंग टू थिंक एनीथिंग बाय इटसेल्फ एट प्रेजेंट। विद आर्टिफिशियल इंटेलिजेंस भी वो वही सीखेगा जो हमने उसको सीखने के लिए बताया है। सो फर्स्ट वी हैव टू स्ट्रीमलाइन आवर प्रोसेसेस। पहले क्या करना है, बाद में क्या करना है, उसके बाद क्या करना है, एंड दैट वी हैव टू पुट इनटू द सॉफ्टवेयर और आवर इंटेलिजेंस सिस्टम। इसको करने के लिए वी हैव टू अंडरस्टैंड द पेशेंट रिक्वायरमेंट्स। व्हेन वी अंडरस्टैंड द पेशेंट्स रिक्वायरमेंट्स, तो हम उसको, और हर पेशेंट के रिक्वायरमेंट अलग है। सर्जरी पेशेंट नीड्स समथिंग एल्स, मेडिसिन पेशेंट नीड्स समथिंग एल्स, एंड मे बी ऑप्थेल्मोलॉजी में कुछ और चाहिए। तो पेशेंट को अंडरस्टैंड करके उसके अकॉर्डिंग प्रोग्राम्स करने पड़ेंगे टू क्रिएट अ बेटर यूज़र एक्सपीरियंस। इफ द यूज़र, भाई अभी सिंस वी आर in consumer forum, so our patients are not only patients, they are consumers. So better consumer experience create hone pe they will be loyal to us, loyalty will be built up. Next please. So digitalization के लिए हमको internal और external दोनों सिस्टम को इंटीग्रेट करना पड़ेगा। तो इंटरनल हुआ आपका हॉस्पिटल मैनेजमेंट सॉफ्टवेयर, जो कि आपके हॉस्पिटल के अंदर वर्क कर रहा है, और एक्सटर्नल हुआ पेशेंट इंटरफेस। पेशेंट इंटरफेस मे बी योर वेबसाइट, मे बी एन ऐप, मे बी अ कियोस्क विच यू सेट अप इन योर क्लिनिक, और इनपुट शीट्स लाइक गूगल फॉर्म्स, जैसा फॉर्म हमने अभी IMA में भरा है फॉर registration. So all these things all together will form external interface. So there has to be a connection between the external and internal interface. Next. पेशेंट के लिए जो भी इंटरफेस है उससे बहुत सारी चीज़ें हो सकती हैं। अपॉइंटमेंट शेड्यूलिंग, पेशेंट आया दमों से और डॉक्टर साहब है नहीं, so maybe if he has that facility he can find out whether the doctor is here or not. He can come and take a consultation, or he can take an online consultation. He may not come, he can save a lot of time and money. He wants to show to Dr. Behrani, and Dr. Behrani is in Jabalpur, so he may not come. He can have an online consultation with him. Prescriptions can be uploaded, and even for patients who are admitted, a post-discharge follow-up can be done online. Next. So, using a patient interface, all the persons involved in patient care can interact seamlessly. Patient is also detailed on day-to-day progress. Medical records can be updated on that, and history of the patient can also be updated on that. Next. We have various digital assistant. हम लोगों ने सबने IRCTC पे अपनी बुकिंग की है, और उसमें एक दिशा मैडम है जो पूछती हैं, may I help you? Now Disha madam is nobody. She's a virtual lady, she's a chatbot. So maybe we can also employ a chatbot in our system, or we can use texting apps and other things. Next. In the hospital, by installing a good system, we can go paperless. हम राउंड लेते हैं तो we can dictate notes. 2 मिनट और है ना? हाँ, we can dictate notes, और वो notes dictate करेंगे तो वो directly voice to text ऐप से कन्वर्ट होके उसमें चले गए। कॉस्ट इज डिक्रीज, एफर्ट इज डिक्रीज, एफिशिएंसी इज इंक्रीज। नेक्स्ट. देयर इज लिंकिंग ऑफ डिपार्टमेंट्स। हमने सोनोग्राफी बोला तो रेडियोलॉजी वालों को दिखेगा कि इसकी सोनोग्राफी होनी है। दे विल गिव एन अपॉइंटमेंट टू द नर्सिंग स्टाफ. द नर्सिंग स्टाफ विल शिफ्ट द पेशेंट ओनली व्हेन रिक्वायर्ड. देयर इज नो paper communication, no person running in between the wards. The patient portal पे भी patient will able to see कि क्या हो रहा है. Next please. Artificial intelligence is going to grow exponentially. It is an underestimate if I say 10 times in 5 years. All these things are going to come, and huge data is going to be generated. Next. So for a huge data, we need a robust AI system which can analyze the data. Data आज भी है हमारे पास, पर हम उसको यूज़ नहीं कर सकते क्योंकि बैठ के उसको sorting कौन करेगा. With the artificial intelligence, we can sort out the data and we can use it to increase our business. But there are challenges. Cyber security is one challenge. But even AIMS में भी cyber security attack हुआ. यूज़र ऑथेंटिकेशन किसको क्या काम देना है ये बहुत इंपॉर्टेंट है. ज़्यादा देना भी प्रॉब्लम है, कम देना भी प्रॉब्लम है. और हमारे सॉफ्टवेयर में ऑडिट ट्रेल होना चाहिए सो दैट वी कैन सी हु हैज़ डन व्हाट. नेक्स्ट प्लीज. तो फिर प्रॉब्लम्स हैं तो क्यों जाना है? बिकॉज इट इज़ इवोल्यूशन, नॉट रेवोल्यूशन. इट इज़ अ नीड ऑफ द डे एंड बेनिफिट्स आर इमेंस. नेक्स्ट प्लीज. न सिर्फ हम लोग ये बात सोच रहे हैं बल्कि इवन द गवर्नमेंट हैज़ कम अप विद आयुष्मान भारत डिजिटल मिशन. So whether we like it or not, we will have to convert to a digital world. The Aadhaar card allows the patient to upload reports, the doctor to upload prescription. Through the Aadhaar card, the patient goes to a government hospital and scans the QR code and gets an appointment with the doctor in a government hospital. So if a government hospital is doing this much, we definitely have to surpass that. Next. Thank you so much.
Hello. Thank you, ma'am. Thank you for such a nice information. You are nicely presented. Now I would like to call Dr. K.K. Sohana, sir, to come, and his topic is bariatric surgery. Next speaker, Dr. Vishwas Sharma. Is he there? Dr. Vishwas Sharma. Okay. Dr. Amitesh Dubey, sir.
Hello. If you need some time, can we proceed with the second presentation?
Organizing secretary and everybody for allowing us to have a presentation on this slide. Bariatric surgery is one of the common topic nowadays in metro cities, but definitely as the population with the diabetes is increasing, it is the need of the hour for the every city in the India. Greetings from the Laparoscopy Center, Jabalpur. We are doing the regular laparoscopy and bariatric surgery and metro hospital in the private sectors. I'm very fortunate to have the experience with the leading surgeons from the India, like Dr. Chaube and Dr. Palanivalu. They are the masters of the bariatric surgery in India.
Sir, this presentation was from Dr. K.K. Sohana.
Case summary. Then my past experience with the bariatrics is very long, for last 10 years. So this is my case that I did in 2016. The lady was having a weight of 130 kg, type 2 diabetes with the HbA1c more than 10, hypertension, hypothyroid 150 microgram dose, OSA, bilateral joint pain and psychological stress related to the overweight. After 5 or 6 years span in 2022, she is now she is having a weight of 65 kg. Diabetes complete resolution. So basically the complete resolution is if there is a HbA1c is less than 6.5 for consecutive 3 years, then it is a diabetes resolution. Hypertension complete resolution, hypothyroid dose decrease, OSA improved, joint pain decrease with the medication, and psychologically patient improved. So this is the beauty of bariatric surgery, that it can change everything in the patient in the form of hormonal balance and the lifestyle. Bariatric surgery, basically bariatric surgery, the meaning is the burrows. That means it's the obese patient surgery is known as bariatric surgery. It is basically a human organism is having a dependent on environmental, genetic and endocrine factors. That are the major cause related to the obesity in the Indian continent. Prevalence in India, probably we are right now leading country with the obese and diabetes. And we are having a more than 5% population that is obese with the diabetes. As the timing passing, the obese patients rate is increasing progressively, and the measure of concern is that in the young population, the rate is reaching up to 5.4%, is less than 14 to 15 years. That means the sedentary life right now is affecting all the people in the India. Medical complication and resolution of the surgery, every factor, every organ, every system is affected by diabetes. So it is affecting everything in the body, from hormonal imbalance to everything. So basically, if we are obese, then we can measure our body mass index by the underweight. If we are having a body mass index more than 30, then it is the need of the surgery for the patient. Who is the appropriate candidate? The one who is having a BMI more than 40, or the one who is having a BMI more than 35 plus any comorbidity like diabetes and hypertension, that patient should undergo bariatric surgery if it is not controlled with the medications by the physician. Basically, obesity surgery is not a single surgery, it's a multidisciplinary approach that requires a surgeon, physician, chest physician, cardiologist, dietitian, and everyone is having a equal proportion for the treatment of the patient with the obesity and diabetes. In India or in world, the bariatric surgery is further divided into 2 or 3 procedures. Either they are the restrictive procedures, that means we are restricting the meal to the patient. Either we are malabsorpting the procedure, that means we are not allowing the food to absorb into the intestine. The surgical treatment for obesity basically divide on the basis of the procedures. Either it is a restrictive procedure or a malabsorptive procedure. So basic 4 procedures we are doing in all over the world is Roux-en-Y gastric bypass, adjustable gastric banding, vertical sleeve gastrectomy, and BPD procedure for heavily diabetic patients. Mechanism very similar, that we are not allowing the patient to have a food by decreasing the size of the stomach, or we are diverting the food from the small intestine, so there is no absorption of food into the small intestine. Basically, whatever the mechanism there, it could the hormonal changes into the intestine or in the body. The main hormone associated with the control of the diabetes is the GLP-1 and hormone YY. So usually it increase the level of the GLP-1 that directly affect the insulin release and other factors in the body. So basically, GLP-1 and GIP hormones stimulate the insulin release and inhibit the glucagon release, and that basically lead to the lowering the blood glucose level. Nowadays, we are using the gliptins to block the DPP-4 to increase the level of the GLP-1 in the body in the form of medications. So first procedure is the sleeve gastrectomy. This is the most common procedure we are doing in the world. It's acquire more than 70% proportion of the bariatric surgery. And this is wonderful surgery which is having a good results. In this, we are releasing the 80% of the stomach is cut out from the stomach part, and the 20% part is having a sleeve-like structure in the body. So it helps in the decrease in the intake of the food and allow the food to pass directly to the small intestine with a rapid speed. That increase the GLP-1 level in the body, and that helps in control of the diabetes in the patient. Gastric bypass surgery, this is also known as metabolic surgery because it's also affect all the metabolic function like blood, hyperlipidemia, diabetes and other factors. So this is one of the common surgery usually done in the USA because the proportionate of the obesity and the diabetes is more in the US side. The last procedure, this is having a more anastomosis complications were more. So to modify this procedure, a newer procedure was developed in the Indian by Dr. Rutlag, that is known as mini gastric bypass. This is also having an equivalence with the Roux-en-Y surgery, and fortunately we are very fortunate that we are all doing all the 3 procedures in Jabalpur. This is the last procedure that is basically allowed for the diabetic patient, and it is having a highly satisfactory result, more than 90% resolution of diabetes in type 2 diabetes. This is the paper that was presented in the Toronto in 2013, and it's having a my study also. So in comparison with the Lutwal, the resolution of diabetes in my patient series was more than 80%. And in Roux-en-Y gastric bypass, this was 100%. And the total patient count was more than 230. My experience is short for last 10 years, but in Jabalpur, we have already performed more than 10 cases with a satisfactory result and no comorbidity. So conclusion is, we are in Jabalpur and we are doing the regular bariatric surgery for the obese and diabetes patient. And it is a life-changing procedure that can change the life of a patient by controlling the diabetes and decreasing the weight loss. Thank you very much.
Thank you, sir. Thank you so much for such a nice presentation. Now I would like to call Dr. Amitesh Dubey, sir. And his topic is endoscopic approaches in neurosurgery. नेक्स्ट प्रेजेंटर डॉक्टर मुकेश निगम सर, रेडी हैं सर, और उसके बाद डॉक्टर अलका अग्रवाल मैम.
अभी तो आ गया था. इसमें लग गया था. प्रॉब्लम क्या है इसमें?
नेक्स्ट प्रेजेंटर प्लीज. निगम सर, आप आ जाइए सर. एंड निगम सर के बाद में जो हैं अलका मैम, आप प्लीज़ अपना प्रेजेंटेशन एक बार यहाँ पे चला के देख लीजिए इफ़ इट इज़ रनिंग, सो दैट वी डोंट वेस्ट एनी टाइम ऑन दिस टेक्निकल इश्यूज.
हाँ सर, बस
अमितेश भाई, आप चाहे तो यहाँ साइड में वर्क करके देख लो तब तक.
पेन ड्राइव में
निगम सर को प्लीज इनवाइट कर लें क्या, या अलका मैम, जो भी नेक्स्ट स्पीकर रेडी हो। निगम सर
नहीं पेन ड्राइव नहीं, पेन ड्राइव नहीं, इसमें चल जाएगा ना, अभी चलाया था पहले, देखो एक बार सबका वहाँ साइड चेक कर लो ना यार एक बार। आपके एससी चल रहा है मेरे उस पे, हाँ आगे चलो आगे। प्रेजेंटेशन मोड में नहीं चल रहा तो वैसे ही कर देते हैं, वैसे ही चला दो। वो प्रेजेंटेशन मोड में दिक्कत आ रही है, अब इसको वैसे ही चला दो। इसको क्लोज करो, प्रेजेंटेशन मोड नहीं इसमें नहीं आ रहा ना आप, हाँ चलो हो गया। ओके, good afternoon everyone, and first of all I want to thanks all the organizer for letting me present this topic. So, and my topic is endoscopic approaches in neurosurgery. So neuroendoscopic treats the pathology of the central nervous system by applying an endoscope, and currently the field of neuroendoscopic, which initially started as a ventricular procedure, and it is currently applied for all types of neurosurgical treatable disease like intracranial cysts, tumors, hypothalamic skull-based tumors, craniosynostosis, degenerative spine disease, and all this. So I'll just skip the history, but it started at 1910 when the surgeon L. Espinasse used a cystoscope to treat hydrocephalus. So what are the advantages? Small incision, we can see, because of endoscope, we can see around at the corner, which is difficult by microscope. Short hospitalization, minimal or no pain. Early recovery, less complication, better results. Although there are a few obstacles, like there is very little margin of error. And the intraoperative bleeding is a problem, because even a small bleeding looks massive in endoscope and it can soil the scope. Larger lesion and vascular lesion is still an obstacle, and proper instruments, if not available, then it causes a problem. So it is broadly, it is classified as a pure endoscopic neurosurgery when there is a system in which the scope and all the instrument goes through the system. Other is endoscopic controlled microsurgery, where the endoscope is only used for visualization. The rest of the surgery is carried out with using the microscopic instruments. And endoscopic assisted neurosurgery, where primary surgery is done using a microscope, operating microscope, and endoscope is used to look around the corners. So we'll start with first the most common indication, and the first indication for endoscope, hydrocephalus. Now, obstructive hydrocephalus is the main indication, although in TBM with hydrocephalus due to tuberculosis, at least 60-70% patient can be treated with ETV, endoscopic third ventriculostomy. Then multilocular hydrocephalus, ventriculitis, shunt blockage, and slit ventricular syndrome. The advantage is there is better result with endoscopy, and if it is up to 90% successful, and if it is successful, then no other treatment is required. Whereas in shunt, there is 50% chances of shunt blockage in 5 years, and we may require redo surgeries in such cases. And there are many complications related to VP shunt, ventriculoperitoneal shunts. So this is just I don't think I will be able to play this. Okay, I cannot play the video, no problem. So then the other common indication is pituitary macroadenoma. The approaches are transnasal, transsphenidal, which can be done microscopically or endoscopically. And transcranial approaches, which is obviously done using an operating microscope. But there are advantages of endoscope over microscope. Like you can see in this picture, the microscope gives you a tubular view, like a tubular, and the vision is still, you have to focus repeatedly and it is not as much clear. While in endoscope, it gives you a panoramic view, and you can look around the corners very easily. You can use a 0-degree endoscope to even 30-degree scope and look around the corners if any tumor or anything is left. And there has been a meta-analysis for endoscope versus microscopic surgery, and based on the current evidence, in non-functional pituitary adenomas, patients treated by endoscopy had higher rates of GTR, gross total resection, and functional pituitary adenomas patient had higher rates of visual improvement, GTR, as well as lower rates of meningitis. Then another indication is hypertensive bleed, where endoscopic approach has been effective and safe because it has better visualization. So there is better surgical removal, complete removal of the hematomas, and better hemostasis. Like in this, you can see there is a large basal ganglion bleed, and in this patient we just did a small 3 centimeter size craniotomy, put a tubular retractor, endoscope, and removed all of the hematoma. Then another newer indication is chronic subdural hematoma, where burr hole is the conventional surgery that is done. So like in this scan, you can see there is a small, almost homogeneous hematoma. So a burr hole can be sufficient for this patient. But in another patients like this, where there are multiple membranes, loculations, these patient, it is mandatory to use an endoscope, because you cannot break this membrane by a simple burr hole alone, and then you will leave the hematoma and will label as a recurrent disease, although it's a residual hematoma. So this was again a small video. I'll just skip that because of shortage of time. Okay, and another indication are ventricular tumors like choroid plexus papillomas, colloid cysts. These are also done transcortically through endoscope. Trigeminal neuralgia, the conventional treatment usually start with medicine and radiofrequency ablation. When surgery is required, microvascular decompression is the treatment of choice. We have done full endoscopic vascular decompression and found to be as effective as microvascular decompression, with advantage that brain retraction was not required. Also, in various studies, it has been seen that 23% has compression from not single vessel but double vessel in such cases, and 17% has compression anterior to the fifth nerve. So in such cases, in microscope, you cannot visualize that completely, and you need endoscope to actually visualize, and without visualizing, you cannot do a decompression in such cases. I'll just skip these videos because of shortage of time. This was a small video. Then I'll come to endoscopic spine surgeries. So first, lumbar disc diseases. So there are two main approaches for this, the interlaminar approach and transforaminal approach. Because I do interlaminar approach using Karl Stoll's EasyGo system, so I'll talk about that interlaminar approaches. So this was a study which we did on 920 patients and compared with the conventional procedure. So in my single level lumbar disc disease, the treatment of choice, the gold standard treatment is microscopic microdiscectomy using an operating microscope. But our endoscopic system is also accepted and valid and safe. Similar results, similar to the microdiscectomies, can be obtained using endoscopic discectomies. But endoscopic, it allows better visualization. We have done both the technique, and we observed that we had better visualization using an endoscope. And there are few hidden spaces in the microscope that can be seen well using an endoscope. Also, when there are bilateral symptoms, so endoscope has obvious advantage because you can do unilateral approach with bilateral decompression with endoscope, which is a little tedious job if you do it with microscope. So in our study, we found that viewing angle, total area exposed were better visualized by MED. Okay. Now, similarly, endoscopic cervical discectomy can be done anterior or posterior approaches. Anterior approach, we do only 30% of the disc is removed, and so because of this, no fixation or fusion is required. Like in this comparative scan, you can see no fixation or fusion was done, and the disc was removed, and patient was symptom free. Another emerging indication is spine tumors. Well, smaller size 1 to 2 level intradural extramedullary tumors can be excised during endoscope. Up to 2 to 3 levels of only hemilaminectomy.
So can you please concentrate on salient points now?
Yeah, hemilaminectomy is required, and the and spine stability is not, the spine stability remains the same. So to conclude, I'll just conclude it that it has a lot of indication and it has been proved to be safe and effective. And I'll just finish with this sentence that further innovation in optical physics, electronics and robotics will dramatically improve the potential of endoscopic neurosurgery in the next decades, hopefully. So thank you, Dhanyavad, Jai Shri Ram.
Thank you, sir. Thank you for such a nice presentation. Now I would like to call Dr. Mukesh Nigam, sir, and Dr. Kanupriya Nigam. His topic is green anesthesia. Yes, green anesthesia.
Good afternoon, everybody. I am very thankful to the organizers who have given me this opportunity to speak upon this topic. But I am not speaking on this topic. My daughter, Dr. Kanupriya, who is second year resident in Netaji Subhash Chandra Bose Medical College, she will be taking over after a few words of mine. Our planet's alarm is going off and it's time to wake up and take action. Greeting to everyone. So just a few days back, I happened to read an article somewhere which pointed out how trees were being chopped down to put up billboards, sending message of how alarming global warming is ironic, isn't it? It is almost certain that we cannot undo the effect we have created on this planet, but we are not too late either to start a difference. Despite the urgency of the situation, climate change is the only beginning to appear on the medical conference agendas like today's conference. We doctors may feel helpless about it, but we should not underestimate our collective influence. As a gesture to pay homage to the recent Turkey-Syria earthquake, here is a short presentation of being more sustainable, especially as an anesthesiologist. Now, I will ask Dr. Kanupriya to take over the talk.
Good afternoon, everyone. Good afternoon, everyone. First of all, I would like to extend my gratitude for giving me this opportunity today. And it is a pleasure for me to introduce myself. I'm Dr. Kanupriya Nigam. And today I'm here because I'll try to unleash an unseen aspect of our profession and how to substitute it with a more sustainable approach towards green anesthesia. So why did I use the term green anesthesia? With the term green over here, I'm trying to refer to all the practices and all the policies that don't negatively affect our environment. Climate change is no longer some far off problem. It is happening here, it is happening now. So, the IPCC, that is the Intergovernmental Panel on Climate Change, has already concluded that we have less than 10 years to dramatically reduce our greenhouse gas emissions. At this point, I'd like to bring forward an uncomfortable paradox by quoting that although healthcare systems respond to this disease burden, healthcare itself pollutes the atmosphere, land, and the waterways. India is the world's 4th biggest emitter of carbon dioxide, and in the UN Climate Change Conference, which was held in UK in the year 2021, our dynamic Prime Minister, Mr. Narendra Modi ji, has set a target to cut down India's emissions to net zero by the year 2070. So how severe is this problem and how are we as anesthesiologists involved? Before answering this question, at some point of time in our childhood, we've all read about the greenhouse effect. So a greenhouse basically traps the sun's energy inside it and keeps the plants warm. The earth, if we revisit the same concept, functions like a greenhouse because of the jacket of gases it is surrounded with called the atmosphere. These heat-trapping gases include methane, nitrous oxide, fluorinated gases, and majorly carbon dioxide, and are collectively known as the greenhouse gases. So these greenhouse gases are responsible for what we know as the greenhouse effect. So what the greenhouse effect basically is, when the sun radiates its energy towards our planet Earth, some of its heat is entrapped in the atmosphere, keeping our planet warm, and the excess heat is made to escape into space. However, the greenhouse gases are increasing in quantity, so more and more heat is entrapped in the atmosphere and less heat escapes into space, causing an increase in the Earth's temperature known as global warming. And this is the human enhanced greenhouse effect. It is not the natural greenhouse effect. So again, coming back to the question, how severe is the problem and how are we as anesthesiologists involved? So halogenated compounds account for almost 11% of the global warming, and the volatile anesthetics or the inhalational agents that are being used in the OT come under the category of these halogenated compounds. When a patient is under general anesthesia or general endotracheal anesthesia, he is made to inhale these anesthetic vapors, which are minimally metabolized in the body and are exhaled predominantly unchanged and unregulated into the atmosphere. Once they enter into the atmosphere, they tend to stay there for a longer duration. For example, the tropospheric lifetime for isoflurane is 3.2 years, for sevoflurane it is 1.1 years, and for desflurane it is 14 years. And as you can see, for nitrous oxide, it is a hefty duration of 110 years. So once these gases are released from the OR into the atmosphere, they tend to stay for this longer duration in the environment. So if we take the global warming potential of carbon dioxide as standard, that is to be 1, and compare it with that of the other gases, we'd notice how much more potential do these gases have compared to carbon dioxide. 130, 265, 510, and even 2540 times that of carbon dioxide. So on one hand, we are considering carbon dioxide as the main culprit for global warming, be it from fossils, industrial sector, commercial sector, or transportation. But I think the figures are quite evidently picturing the potential of the agents which are continuously being used in the OR. Another anecdote to make it more relative, if we were to replace petrol with 1 Mach-hour quantity of these gases, then we will easily be able to travel a distance of 6.5 kilometers using sevoflurane, 13 kilometers using isoflurane, and 300 kilometers using desflurane. And on top of that, if we were to add 0.6 Mach per hour quantity of nitrous oxide, it will result in an additional 100 kilometers of distance traveled. So what is the solution to this problem? The solution is to avoid and to switch. Avoid using desflurane and nitrous oxide wherever clinically possible and switch to using air. We should switch to practices like TIVA, that is total intravenous anesthesia, because it completely excludes the use of inhalational agents. We should switch to low flow anesthesia and regional anesthesia, again wherever clinically possible. Now with great power comes great responsibility. As clinicians, we have immense power in our hands, but a greater responsibility over our heads. Almost a quarter of the hospital waste comes from the operating suites. These wastes include plastic syringes, covers, packaging, preloaded drugs which are discarded if not used, the plastic OT attires, intra and post-operative notes in innumerable number of pages, single-use LMAs, ET tubes, IV sets, monitors, machines, suction machines, the catheter, everything which is kept switched on in anticipation of cases. So unintentionally, we are all involved in making our life unsustainable in due course of time. It is inevitable to avoid these practices. However, certain changes can absolutely be made, and therefore, our mantra should be to reduce, to reuse, and to recycle. We should ditch the DES. We should reduce the use of desflurane as much as clinically possible. We should think TIVA. We should encourage the use of total intravenous anesthesia. We should encourage low flow anesthesia, that is, we should go low flow. We should stop the SUD. We should stop using single use devices. We shouldn't be a waster. We should flush the syringes with distilled water and reuse whenever possible. We should say no to N2O. That is, we should try using air wherever clinically possible. We should relish RA, we should relish regional anesthesia, and we should switch it off. We should switch off the monitor, the anesthesia machine, the suction machine, the cautery, everything that is electrically driven at the end of the OT. So I think we are all familiar with the anecdote of how an anesthesiologist cannot survive without his or her coffee. So we can choose to be more sustainable even in this aspect by switching from disposable to reusable. Though this may sound like a very small change, however, it will have a very impactful outcome. So environmental sustainability, particularly in anesthesia, is now a rising concern and being discussed all over the world. The atmospheric science behind global warming, including the specific role of anesthetic agents and anesthesia practice, has already been discussed in an article in British Journal of Anesthesia. Concluding, clinicians are in position of authority and responsibility to make valuable contributions in the transition to sustainable healthcare, and doctors can make informed choices to reduce their practice-related carbon footprint. Thank you.
Dr. Alka Agrawal, ma'am. Congratulations, Kanupriya, for successfully presenting in front of your father and proving yourself. And also congratulations to Mukesh, sir. You must be feeling very proud. The claps were loudest from your hands, I suppose. Claps. Batele sir is saying claps are for only Kanupriya. Alka ma'am, please. Dr. Jaya Upadhyay, please be ready with your presentation. If you want, you can test it with the technical team. Dr. Jaya, here is the technical team if you want.
I think after the wonderful presentation by Kanupriya, very interesting presentation for all. My presentation may be little boring for all of you, and because these young children, they are very good in presentations, and I am from the old clan. I think.
Ma'am, you have already proven yourself in support of the green, ma'am. Your sari is very beautiful.
Thank you. Yes, green. In our time, I think we were not have to present the presentations, and it's my son and my daughter, they are doing this, but in our time, we are learning from them. We are learning from the young generation how to present, but this learning curve is always there in our life. We can learn till we die. So I am working on that path only. Teething trouble is still going on. Mishra ji, you promised me, but इधर तो करें ना. वो वहाँ से नहीं ना, यहाँ से लगाओ. नहीं, but I have to read ना. नहीं, that is very difficult. Mishra ji promised me that it will work.
डॉक्टर जया प्लीज अपना प्रेजेंटेशन भी एक बार चला के देख लें. इफ इट इज रेडी प्लीज गो अहेड. हाँ, नेक्स्ट प्रेजेंटेशन आई विल बी.
So, a very good afternoon to the August gathering who is still present after the lunch. I think all the presenters, the present persons are presenters. So, okay, thank you very much. And at the outset, I am very thankful to the organizing committee, Dr. Amren Pandey, chairperson of this global call conference, and Dr. Nachiket Panse, secretary, organizing secretary, for giving me this opportunity to present my topic on role of progesterone in preterm labor. The preterm birth and its complications are the leading causes of infant morbidity and mortality worldwide. Infants born preterm have a significantly higher likelihood of dying during the neonatal period than term infants. Getting the interventions right will inevitably save millions of infants and their families. The preterm labor was defined as contraction or labor occurring before 37 weeks of gestational age. The worldwide burden is 15 million preterm births contribute to 1 million neonatal deaths. And in India, among the total 27 million babies born annually, 3.6 million babies are born preterm, and over 300,000 of these preterm babies die each year because of the associated complications. India, with its highest number of preterm births and highest number of preterm deaths worldwide, contributes 25% of the overall global preterm related deaths. The major causes of preterm births are, in 20 to 30% cases, premature rupture of membranes, and iatrogenic causes in 20%, like maternal indications like preeclampsia, diabetes, prior classical cesarean delivery, and fetal indications are non-assuring fetal testing, intrauterine fetal growth restriction, and in 25% cases, spontaneous, that is unexplained preterm labor. And infection and inflammation is also an important cause of preterm birth. Then my topic comes, the progesterone, to prevent preterm labor. Progesterone is we all know that progesterone is an endogenous steroid hormone that is commonly produced by the adrenal cortex as well as the gonads, which consist of the ovaries and the testes. Progesterone is also secreted by the ovarian corpus luteum during the first 10 weeks of pregnancy, followed by the placenta in the later phase of pregnancy. Progesterone is progestation, essential for pregnancy preparation, implantation, support, and continuation. It is an immunomodulator also, which is essential for normal pregnancy. It increases nitrous oxide production, thus increasing the uterine blood flow and endothelial adaptation. It decreases the contractility of myometrium. So, before birth, coordinated uterine activity is associated with connective tissue changes resulting in cervical ripening and dilatation. Progesterone has an essential role in primarily through establishing uterine quiescence. The mechanism, the progesterone acts in uterus at 4 places to prevent PTL. At placenta, it regulates timing of labor via controlling stress hormone. In amniotic fluid, it limits prostaglandin production. At fetal membrane, it blocks pro-inflammatory cytokines induced apoptosis, preventing PROM. At myometrium and cervix, suppresses inflammatory responses and myometrial contractility. There are different guidelines for the use of progesterone in preterm labor. In FIGO guideline, FIGO recommends the following. Sonographic cervical length measurement should be performed in all pregnant patients at 16 to 24 weeks of gestation using transvaginal ultrasound. This can be done at the time as the ultrasound performed for the anatomical survey. Women with a sonographic short cervix equal to 25 or lesser than that millimeter diagnosed in the mid-trimester should be offered daily vaginal micronized progesterone treatment for the prevention of preterm birth and neonatal morbidity. The progesterone formulation to be used is vaginal micronized progesterone, 200 mg vaginal soft capsule every night, or vaginal micronized progesterone gel, 90 mg each morning. Universal cervical length screening and vaginal progesterone treatment is a cost-effective model for the prevention of preterm labor. The use of the progesterone is very specific, is very good in few of these cases like short cervix, history of preterm birth, twin gestation with short cervix, maintenance tocolysis, risk of PTL in IVF ICSI conceived pregnancies as an alternative to cervical surclase. In short cervix, relative risk of SPTD less than 35 weeks, there is a graph showing the SPTD less than 35 weeks and cervical length at 24 weeks. And TVS carried out at 16 to 24 weeks. And cervix either 25 millimeter or less than that. The conclusion was intravaginal progesterone enhances preservation of cervical length in women at high risk for preterm birth. So this updated systematic review and meta-analysis reaffirms that vaginal progesterone reduces the risk of preterm birth and neonatal morbidity and mortality in women with a singleton gestation and a mid-trimester cervical length equal to or less than 25 millimeter without any deleterious effects on neurodevelopmental outcome. Clinicians should continue to perform universal transvaginal cervical length screening at 18 to 24 weeks of gestation in women with a singleton gestation and to offer vaginal progesterone. In previous preterm delivery, this is the strongest risk factor. After one preterm birth, the risk in the next pregnancy is 20%. And after 2 preterm deliveries, this risk increases to 35 to 40%. And if fetal fibronectin positive women with a prior history of preterm birth, if cervical length is equal or less than 25 millimeter, then estimated recurrence risk of preterm birth in less than 35 weeks gestation is 65%. And if this length is 26 to 35 millimeter, then risk is 45%. If cervical length is more than 35 millimeter, then risk is 25%. And in patients who are fetal fibronectin negative women with a prior history of preterm birth, then if cervical length is less than 25 millimeter, the risk of delivery is 25%. And if length is 26 to 35, then risk is 14%. If cervical length is more than 35, the risk is 7%. So cervical length is very, very important in prognosis of preterm labor. Then oral micronized progesterone prevents recurrent spontaneous preterm birth. And it increases in the, it causes increase in the maternal serum progesterone also. Then progesterone and 17-oxy-hydroxyprogesterone caproate for prevention of preterm birth. Vaginal progesterone, by the studies it was found that vaginal progesterone was more effective than intramuscular 17-hydroxyprogesterone caproate for the prevention of preterm birth and had fewer adverse effects.
Ma'am, can we
yes.
sum it up a little?
In twin pregnancy, administration of vaginal progesterone to asymptomatic women with a twin gestation was found to be less effective. And in maintenance tocolysis after arrested preterm labor, when results with maintenance tocolysis with progesterone may be useful for patients who had an episode of threatened preterm labor successfully treated with acute tocolytic therapy. In conclusion, maintenance tocolysis will, with oral micronized progesterone, significantly prolong pregnancy and decrease the number of preterm births. The risk of PTL in IVF and ICSI conceived pregnancies, the administration of 400 mg vaginal natural progesterone from mid-trimester reduced the incidence of preterm birth in singleton, but not in twin IVF pregnancies. Pregnancy outcome in short cervix related to progesterone via cervical and cerclase. It was found that micronized progesterone is as effective as cervical surclase in prevention of preterm labor in women with singleton pregnancy with short cervix. And which progesterone? Natural micronized progesterone or hydroxyprogesterone caproate? This micronized progesterone is natural, and it is natural, and micronization improves oral bioavailability, and it is it's pregnancy category B drug, no effect on mood, HDL cholesterol and pregnancy. So in both of them, this is better. And both these things can be used in history of preterm births, but progesterone is better in short cervical length and effective in twin gestation also.
Ma'am, please conclude.
Yes. The risk of PTL, short cervix and multiple gestation, and guidelines across globe support progesterone treatment for prevention of PTL. Looking at the multifaceted etiology of preterm labor and huge financial burden involved in tackling perinatal morbidity due to a preterm birth, we can conclude that using progesterone as a co-treatment to prevent preterm labor, especially in women with a definitive history of a preterm birth in past and those with accidental short cervical length on routine screen, would be a safer bet, as it's cheap, easily available, and does not pose any serious threat to either mother or the fetus. So let us ensure full bloom. Thank you very much for your patience listening.
Thank you very much, ma'am. Now I invite Dr. Jaya. Please come up with your presentation. She'll be talking about the red flags in the neonatal care.
Change my slides from here, no? So a very good afternoon to all of you. I'm Dr. Jaya Upadhyay. I have done DM neonatology and presently working as assistant professor at Super Speciality Hospital, Medical College, Jabalpur. My slides are visible. So today I'll be talking on red flags in neonatal care. I'll just keep it short so that the time can be saved. Red flags is all about distinguishing what is normal from abnormal and when to seek for intensive care. So just talking little on the problem statement, neonatal care is a topic of national importance. Multiple health programs and missions are directed towards getting a single-digit neonatal mortality. According to SRS 2022 data, the neonatal mortality rate of our country is 19 per 1,000. But any guesses which state has got highest neonatal mortality in India? Unfortunately, Madhya Pradesh. And it is 33 per 1,000. So we are lacking much behind in the neonatal care. So this was a normal newborn. We have two evidence-based intervention which I want to mention here for stable newborns, or what we say healthy newborn. One is delayed cord clamping for 30 seconds, which is a form of placental transfusion. It is a right of all the normal newborns. They should be delayed cord clamp for 60 seconds, which will give extra 30 to 40 ml per kg blood and hence prevent the incidence of anemia and blood transfusion. Secondly, specifically if the baby is premature, it has got mortality benefits as well. So now coming to red flags, where are they derived from? A study was done, published in NAGM in 2008 by Young Infant Clinical Study Group. They studied 31 clinical signs and symptoms, and they filtered them to 7 clinical signs and symptoms based on the prevalence with high sensitivity and specificity, which are now defined as red flags in neonatal care, which is difficulty in feeding, hypo or hypothermia, convulsions, lethargy, fast breathing, chest and drawing, yellow palms and sole. So if a baby is coming to you with any such condition, you need to refer that baby to a tertiary care in ICU. And these symptoms has got a sensitivity of 85% and specificity of 75%. Now, not digging deep into the topic, I'll just give an overview what we do in neonatology. So I'm thankful to ma'am for giving a preview of preterm care burden. So now we have a baby who is just born, just 920 gram baby, feeble cry, flaccid with fast breathing. So this is how the baby looks. And was it preventable? Sometimes no. Preterm birth is not preventable in few cases, but we can definitely do something about it. Specifically in the context of medical college, ANC booking is not done in most of the cases. That we can do. Second is steroid. So there is enough evidence for the use of steroid in improving the outcomes of premature babies. If you are not able to complete the course of steroid, at least give a single dose dexamethasone to all the babies who you anticipate is going to deliver in next 7 days. Second drug is Maxsulf. In every baby who is less than 32 weeks gestational age, giving Maxsulf reduces the incidence of cerebral palsy in such kids by 30%. So this is a big number. So this is evidence on antenatal steroids. Now just an overview of what are the game changers in preterm care. First is delivery room CPAP. It can be given by an instrument like this called T-piece resuscitator or a full-fledged machine. This is from our NICU, and it has shown to improve the mortality as well decreases the treatment failure. Second is exogenous surfactant. This is an age-old concept that any baby who is having a lung like this should be given exogenous surfactant. What I want to emphasize here is now this particular surfactant is gaining importance because of very rich formulation of phospholipid. So Curosurf is now advised to be given. And talking of technique, there are two specific techniques that I will give emphasis on. First is ensure, that is intubate, surfactant, extubate. Second technique that came into our knowledge since last 5 years is LISA, that is less invasive surfactant administration. This technique has shown improvement in reduction in the incidence and outcome of death as well as BPD by 25%, which is definitely a big number. Then comes non-invasive ventilation. This is a baby in non-invasive mode of ventilation in our NICU. So we are using our Bella Vista ventilator, but it is present in all the ventilators, neonatal ventilators nowadays. By use of simple nasal interface, you can use an IV for post-extubation primary support, respiratory distress syndrome, and apnea of prematurity. If the ventilation is not avoidable, then use volume control mode, specifically volume guarantee ventilation. Why? Because much more beneficial than conventional ventilation. Then all the babies, in order to cater, again, give evidence-based complete care, you need to have central line insertions. What we are following is first 10-day umbilical catheters, after 10 days peripherally inserted long line. Caffeine citrate. No preterm care is complete without caffeine citrate. It is called as silver bullet in neonatology, and it has shown to improve the mortality as well as it has got neurodevelopmental benefits at 18 months of gestation age in premature babies. Now a new concept is immediate KMC or IKMC. We all know kangaroo mother care since our MBBS day. What is new is it can be given immediately to all the premature baby irrespective of their clinical condition. This was a trial which was conducted in India and Safdarjung was a part of it. So it has shown mortality benefits in first 28 days of life. The only problem is logistics because you need specific kind of MNICUs for its application. Now screening. None of the premature newborn care is complete without screening. You need to screen for ears, brain and eye. I am emphasizing specifically on eye because retinopathy of prematurity has got medico-legal implication in neonatology. So we are following RBSK 2017 guidelines for retinopathy of prematurity screening. Second common scenario that we come across is birth asphyxia. So a baby who is born did not cry immediately after birth. So and had thrown seizure at first 4 hours of life. So the diagnosis is birth asphyxia with hypoxic ischemic encephalopathy. Only in our society, the second biggest killer of neonates is birth asphyxia or hypoxic ischemic encephalopathy. What best can be done? Apart from TA, BC or supportive care, I want to emphasize here on therapeutic hypothermia, which is the newest modality that can prevent the morbidity in birth asphyxia patients. What it does is you cool the baby at 33 degrees centigrade within first 6 hours of life for next 72 hours, it has shown to reduce the neurodevelopmental delay and mortality in cases of birth asphyxia by 30%, which is a big number. But all the evidence of therapeutic hypothermia was coming from high income country. How the cooling is given? In India, we were using, this is the criteria for hypoxic ischemic encephalopathy. Now, how we are cooling? In India, we were using gel packs or ice bags, but it has got no evidence. So phase-changing material called Mira Cradle was devised by our team in CMC Vellore, and other high-technology servo-control devices are Blanketrol 2, Criticool, Tecotherm Servo. These are present in India, but again the evidence was coming from high-income country. So there was a trial conducted called Helix trial, which has shown increased death in patients from LMICs or low-middle-income countries. So the criteria for application of therapeutic hypothermia has now become much more stringent, which was given in October 2021 by our own body NNF. Now, third most important case that we routinely come across is a yellow baby or jaundiced baby. So this is a common case coming on day 5 of life.
Dr. Jaya, please complete it.
Sure, I'll just show the pictures. So this was the jaundiced baby. Case of RH isoimmunization with severe hypobilirubinemia in acute bilirubin encephalopathy. So what could be done with this case was just screening with a simple instrument called transcutaneous bilirubinometer, which we are using routinely in our hospital. And since the train has already left the station, this was done double volume exchange transfusion, IVIG administration. And these are the simple developmentally supportive interventions that can be done in all the NICUs for intact survival. Thank you.
Thank you, Jaya, for such a nice presentation. Now I would like to call Dr. Avijit Vishnoi, sir, and his topic is recent advances in laser treatment for glaucoma.
I think so we should all congratulate Dr. Jaya. What she has covered in one presentation actually needs a full lecture, and through her we can also congratulate all the doctors of super specialty who are doing fantastic job in all the field. So a big round of applause for doctors of super specialty. I was taking a note of your ROP point, since I was also screening ROP, and I regularly receive patients who have been properly guided by super specialty pediatricians to get an ROP checkup. So they are doing fantastic job on each and every aspect, not just doing their work just because they have to do it, but they are actually following all the regimes. So congratulations, super specialty.
नेक्स्ट स्पीकर इज डॉक्टर आशा तिवारी मैम, तैयार रहिए, और उसके बाद अर्चिसा सक्सेना.
So I would really like to finish before time because जितने लोगों को मैंने रोका सब मेरे को मारेंगे नहीं था. So I'll be talking about recent advancement in the laser therapy, particularly in the field of glaucoma this time, and I would also like to keep this talk a bit simple so that people from all the other specialty can actually get a gist of what exactly I want to communicate the message in the forum of a super specialist. So glaucoma, as we all know, is a disease which is having problems in the intraocular pressure. And when we talk about intraocular pressure, it's not just the rise in intraocular pressure, it is basically the destruction of the ciliary body with the primary cause as a rise in intraocular pressure. So basically there was a technique called transscleral cyclophotocoagulation. This is a thermal kind of laser which was initially designed to treat glaucoma, but because it was of a distracting kind of nature, and eye actually is a very, very soft tissue and sensitive tissue, so it recently got all the failure reports, and now nobody is using it. So with this came the subcyclo laser. This is also the same laser using same principle, that it is a thermal laser but actually not providing so much heat. Basically it is delivering a micropulse laser to those cells which are absorbing temperature, particularly the pigment epithelium which is present in the ciliary body of the eye. So a continuous beam is passed in a micropulse way, and there is time on and off of that laser. So when the time is on of the laser, it basically stimulates the cell, but during the time of time, the cell cools down and thus reduces the damages to the cell. So by this way, because it stimulates the ciliary body, it not only decreases the aqueous humor production, but also facilitates its outflow through the UV scleral outflow, which is actually the least outflow considered in the normal physiological eye. So the advantage of this laser is this can be used multiple times, and it is fast, atraumatic. Basically, there is no amount of blood loss in the eye. So I would just come up to the video of this procedure. This is self-explanatory. So this is the subcyclo laser. Since it is a painful laser, thermal laser, so a block has to be given. Anesthesia people would agree with it. We usually give bupivacaine and keep the cornea hydrated. Now, the ciliary body anatomical location is around 3 millimeter posterior to the limbus. We use Castroviejo caliper, mark it on the surface, that is on the sclera, and then with the use of a tissue marker, we highlight these points. So a track is basically created where we have to move, and then we proceed ahead with the laser. So here is the laser probe. It has basically a glass tip which is smooth, and when we turn on the laser, we try to move as tangentially as possible. So a to and fro movement of a swiping type is actually done. So this is very smooth. We can also use viscoelastic just to minimize the amount of resistance faced by the tissues, and the laser is done. So this is totally atraumatic nowadays, bloodless, even with the help of minimum invasive glaucoma surgery. Nowadays the complications were very high, but with this, believe me, it is actually not there. No complications are there. This procedure unfortunately is now very, very less. In MP there is only one machine at Indore, that also not functioning. We have done this procedure here at my hospital, Anushri Ne Chikitsalaya. I called this machine from the Delhi. The guy was happy to help, and with basically the patient was on maximum drug regime, but still the IOP, which was normal, used to be 20, was at the range of 38, and 15 days after this procedure, the IOP came down to 15. So that was a magical thing. Patient was not actually ready for the surgery, and when they saw this kind of improvement, they were more than happy and could not really express their gratitude towards this procedure. So these are the basic fine details for ophthalmologists actually, but it is a very simple procedure. The total procedure don't takes, including anesthesia, the procedure is less than 15-20 minutes. So it is fast. It can be repeated if the effect weans off, and the post-operative treatment also consider just of mere some topical drops. So the patient is really very, very happy with all these kind of new emerges. So this is now available at your Jabalpur. Whenever you feel necessary, if the patient or known is suffering from it, you can definitely advise them cures. Thank you.
Thank you. Thank you, sir, for such a nice presentation. Now I would like to call Dr. Asha Tiwari, ma'am, and her topic is acute liver failure.
A very good afternoon to all dignitaries, seniors, my colleagues, my juniors, and my dear residents sitting over here. I am Dr. Asha Tiwari, Assistant Professor in Pediatrics Department, Medical College, Jabalpur. We also have super specialty gastro and liver care clinic. Hence, I have chosen this topic because I have special interest in pediatric gastroenterology, and hepatology. Next 5 to 6 minutes, I would like to focus on few things which are important to care about pediatric liver. I know I am fortunate enough to get this dais where I am having such a wide variety of medical professionals sitting with me, but I would like to focus few things which are important for each one of us, as we have kids all around, our own kids, kids of our relatives, as well as patients. What is aim of today's presentation? Although I had planned the aim as like how early we can identify that the child is going into acute liver failure from common acute viral hepatitis. Second is how it can be best managed at smallest center, and when to identify that this child has to be referred. Early referral to a center which have ICU settings and centers where liver transplantation is possible, we say is important if the child enters into acute liver failure. I am referring to child, otherwise for adults it states the same. Liver transplantation in children in India is no dream now. Liver transplantation is a miracle which is possible for a new life. Definition of acute liver failure, 2-3 things. The setting of liver dysfunction, acute in onset, uncorrectable coagulopathy, which means even after giving vitamin K, the INR is more than 1.5 with signs of hepatic encephalopathy, or INR more than 2 without signs of hepatic encephalopathy. This presentation is important not only for the management of acute liver failure, but to know that our common hepatitis A or E virus causes common acute viral hepatitis in our children, which leads to acute liver failure, although in less than 1%. But that 1% counts lot because it may be a toll on life. It is not so simple acute viral hepatitis. For somebody, it may be severe acute liver failure which may require liver transplantation, without which we may lose the child. What is unique picture in pediatric acute liver transplantation? It is the coexistence of condition. That is, we are having acute hepatitis A or acute hepatitis B, E, but there may be underlying metabolic liver disease which causes problem, hence such type of children enters into acute liver failure. Another condition, it may be a child with chronic liver disease and autoimmune hepatitis. Suddenly some hepatotoxic drug is given for another purpose and the child enters into ALF. So for pediatric, the two condition comes together which makes it unique and detrimental also. As far as causes of acute liver failure in infancy, hepatitis A, hepatitis E and mixed A and E together constitute a large trunk. So here I will not lose the opportunity to say that hepatitis A virus vaccination is for all. We have to fight for universal vaccination against hepatitis A virus to prevent acute viral hepatitis in children and young adults, to prevent most common cause of pediatric ALF, to prevent most common acquired cause of pediatric liver transplantation, and to save life. I recommend from this stage universal vaccination against hepatitis A. Factors precipitating ALF in acute hepatitis, this is for those dealing with acute hepatitis. If there is infection, fever is persisting, vomiting not settling down, hypovolemia and GI bleed, constipation, the child may be entering into ALF. GI bleed not settling down, fluid electrolyte disbalance is not settling down, referral is needed or high and intensive care is required. Causes of ALF in neonates are little different. They may be septicemia or metabolic disorders. Drugs causing ALFs, 3 important drugs, acetaminophen, paracetamol, anti-TB drugs and sodium valproate or other anti-epileptic drugs. Other causes are there. Factors indicating at risk, that is same. If the jaundice is deepening, persistence of vomiting, reappearance of fever after onset of jaundice, rapidly shrinking liver size and persistent hypoglycemia, these all are red alert signs that this child may enter into acute liver failure. Clinical presentation, it may be rapid onset within a week, 2 to 10 days, or there can be sudden bizarre behavior in a teenager. It can be like that. So look for early signs of HE in every child of acute hepatitis. Early child, it is like altered sleep cycle or change in handwritings. They are 2 very common things which have to be looked for in OPD practice itself. Causes of death is cerebral edema. We have to prevent cerebral edema in any way. Diagnostic workup is same. Point to emphasize is do LFT with PT-INR always, because whole acute liver failure is managed with PT-INR, what trend it follows. If PT-INR is improving, that means the liver regeneration has started and you are at safer hands. If it is not, then it is every 12 hourly you can do PT-INR, but LFT is not needed 12 hourly. Specific workup is there for viruses, for Wilson's disease, which is very important, 24-hour urinary copper, autoimmune, you can go for autoimmune panel. These are the diseases where you give specific treatment that you can prevent, then you can prevent them from entering into ALF. Hence, they are mentioned separately over here. Role of elastography. This is a recent trend in pediatric liver care. Now we have elastography fibroscan available for pediatric liver also. You can diagnose liver fibrosis at certain stage of the diseases. Even in common viral hepatitis, non-alcoholic fatty liver now coming up in our adolescents, drug-induced liver injury, primary biliary cholangitis, autoimmune hepatitis. We can go through serial fibroscans, which is ultrasound based, rather than going for invasive liver biopsy. Management says that timely referral to a center, secure the airway if HE grade is increasing. In biochemical parameters, I will again emphasize that do PT-INR 12 hourly and see when the liver regeneration starts. You can pick up the point when the PT-INR starts improving. This is the point where liver has started regenerating. Electrolyte imbalances, you have to look for all electrolytes. Supportive management. For as far as pediatric acute liver failure is concerned, NAC, N-acetylcysteine. Now the protocol is to give irrespective of the etiology in all cases and give early to prevent cerebral edema. L-ornithine, L-aspartate, which we give, has no beneficial role, and there is evidence to suggest that prophylactic proton pump inhibitors are helpful in prevention of GI hemorrhage and hence to be given from early stages. Prevent raised ICP in any form, raised intracranial pressure, prefer 3% saline instead of mannitol. Hyperventilation is a technique which you can use to decrease it. Coagulopathy, very important. Acute liver failure suddenly comes to our mind that the child will be bleeding, there will be deranged PT-INR, but I would say that routine correction of coagulopathy and thrombocytopenia is not recommended. Prophylactic FFP is also not recommended, as it will not reduce the risk of significant bleeding, but it will obscure the trend of INR as a prognostic marker. FFP should be given only before performing any invasive procedure or in situation of extreme coagulopathy when INR is more than 7, not on INR 2.53 or 3.5. Single dose of vitamin K should be given, platelet transfusion only when it is 10,000 to 20,000 or less than 50,000 with significant bleeding. Sepsis. Empirical antibiotics can be given if you suspect sepsis. Antibiotic recommended are third generation cephalosporin with vancomycin for gram-positive coverage and fluconazole for fungal coverage. Acute kidney injury is a part of liver failure. You can check for creatinine high and you can go for continuous arteriovenous hemofiltration or ultrafiltration or exchange plasmapheresis. Liver transplantation is the only definite treatment in 15 to 20% cases of acute liver failure. We have King's College classification criteria. Please go through it whenever you want to delineate which child need liver transplantation. It has 5-6 criteria. Okay. The liver transplant success rate in India, 1 minute. Liver transplant success rate in India is 95%. People return to their early life within 3 to 6 months. Children return earlier to their life, even earlier, that is within 2 months. Liver transplantation in children has better prognosis. We have good centers in India now, more than 10 centers in MP. I would like to say Indore and Bhopal have started doing pediatric liver transplantation. So whenever you find that some child is in need, you have people now available who are specialists in pediatric liver care. Fibroscan is available. One thing at end which I would like to say is कि जॉन्डिस जब लंबा चलता जाता है तो धूप दिखा दो ठीक हो जाता है, वो वाला कॉन्सेप्ट तो पुराना हो ही गया. साथ में वी हैव सीन इन नियोनेटल कोलिस्टेसिस, जिसको हम कहते हैं कि अगर किसी भी बच्चे को 14 दिन के बाद जॉन्डिस परसिस्ट कर रहा है, इसका मतलब गड़बड़ है. 14 डेज के बाद अगर जॉन्डिस किसी भी छोटे बच्चे को नियोनेट को परसिस्ट कर रहा है, द चाइल्ड नीड्स इवैल्यूएशन. ही मे बी अ केस ऑफ बिलियरी अट्रेशिया, जिसके लिए हमारे इंडिया में सबसे ज़्यादा लिवर ट्रांसप्लांटेशन हो रहे हैं. ये चार्ट बता रहा है, सी लिवर ट्रांसप्लांटेशन कितने ज़्यादा हो रहे हैं सिर्फ उस कॉज के लिए कि जॉन्डिस तो धूप में ठीक हो जाता है. वो जब तक हमारे पास पहुंचते हैं, चाहे मेडिकल कॉलेज में हो या हमारे खुद के सेंटर में हो, तब तक टाइम बहुत आगे निकल गया होता है. बिलियरी अट्रेशिया 35% कॉजेज. अगर आपको ऑपरेशन से सर्जरी से ठीक करने हैं तब भी हमें 2 महीने में उनको डायग्नोज करना है, और 2 महीने तो घर में ही निकल जाते हैं. उसके बाद सिर्फ लिवर ट्रांसप्लांटेशन एक ऑप्शन बचता है. इट इज़ नॉट फॉर द पुअर, इट इज़ फॉर द well educated group, I would say. कि जिनके बच्चों को हमने देखा है कि बिलियरी एट्रेशिया 3 महीने के बाद डायग्नोस हो पाया, तो प्लीज़ वो कोई भी ना करे एंड टेक इट, दिस इज़ माय टेक होम मैसेज कि 14 दिन के बाद कोई भी जॉन्डिस इज़ नॉट फिजियोलॉजिकल जॉन्डिस, यू नीड इवेल्युएशन. सेकेंड टेक होम मैसेज इज हेपेटाइटिस ए वैक्सीन इज़ फॉर ऑल. आई हैव सीन माई colleagues, my medico and non-medico very educated parents कि वैक्सीन नहीं लगवा रहे. अभी हमारे पास हेपेटाइटिस वैक्सीन लगवा रहे हैं, बट ओनली दोज वैक्सीन जो गवर्नमेंट रिकमेंडेड है. उनका कहना है आईएपी वाले वैक्सीन की बहुत जरूरत नहीं होती, दे आर फैंसी. इट इज नॉट फैंसी, इट इज लाइफ सेविंग. So hepatitis A I would recommend, and typhoid. These are vaccines which should be given to each and every child to prevent this detrimental condition. Thank you so much.
Thank you, ma'am. Thank you so much for such a nice presentation. Now I would like to call Dr. Archisha Saxena, and the topic is artificial intelligence in anesthesia. Next speaker is VD Suryavanshi sir and Pushpraj sir.
Hello. Good afternoon. I'm Dr. Archisha Saxena from the Department of Anesthesiology, NSCB Jabalpur. I wish to thank the entire committee of IMA Global Con, my HOD Dr. Ashish Sethi sir, and my guide Dr. Mayank Chansoria sir, for giving me this opportunity to present a rather riveting topic, that is artificial intelligence in anesthesiology. This is the Renaissance, the golden age for AI. Allow me to walk you through what some of the influencers have to say about AI. Sundar Pichai, the CEO of Google, has said that AI is probably the most important thing humanity has ever worked on. He thinks of it as something more profound than electricity or fire. Bill Gates, the founder of Microsoft, has said, and I quote, "Certainly we use AI to do drug discovery. The fact that we have vaccines for TB and HIV coming, that's partly enabled by this rich data advanced in biology and machine learning." Satya Nadella, the CEO of Microsoft, says that this is a software-powered world. They have used AI to help those suffering from visual impairment and dyslexia. As of this month, Apollo Hospitals has launched AI-powered clinical intelligence engine for doctors. Very recently, ChatGPT, or a chatbot tool, has cleared the USMLE examination step 1 and has found to show a high level of concordance and insight in its explanations. So what truly is AI? The Oxford Dictionary defines artificial intelligence as the theory and development of computer systems able to perform tasks normally requiring human intelligence. In 1950s, artificial intelligence was first introduced. Machine learning, a subset of AI, became popular in 2000s, which actually defines the ability to learn without being explicitly programmed. We are now in the deep learning phase, which is learning based on deep neural networks. There is a concept called the theory of mind, which works on emotional intelligence. We have two prototypes with us. In 1990, there was a social robot called Kismat, which would actually emote with facial expressions. And very recently, in 2020, the Economic Times released an article on Sophia, the world's first humanoid robot citizen. And she has been doing a tour of 65 countries. She came to Kolkata and interacted with a lot of students and professionals alike. All this just goes to show that AI is no longer a futuristic concept, but rather a present-day reality. None of this would have been possible without John McCarthy, the father of AI, who coined the term artificial intelligence in 1955. The use of AI in medicine began in 1960 via the first expert system called Dendral. Ever since, AI has evolved to include personalized medicines, electronic health records, advanced imaging, etc. 2011 is considered the landmark year of AI in anesthesiology due to the advent of robotic anesthesia. We have two categories of robots, the manual and the pharmacological. Now, manual robots include Kepler intubation system, which is a video laryngoscopy and robotic arm used for endotracheal intubation. We also have the Da Vinci surgical robot, nowadays used for regional blocks, and Magellan robot for peripheral nerve blocks. We may have heard of McDreamy and McSteamy from Grey's Anatomy, but McSleepy is our own invention, which is McSleepy intravenous sedation machine, or the humanoid anesthesiologist. It administers propofol, opioids, and muscle relaxants. The eye control RP machine is a closed loop anesthetic delivery system which delivers remifentanil and propofol. Sedasys system is indicated for minimal to moderate sedation, which uses propofol emulsion. It is done in patients above 18 years of age with an ASA status of 1 to 2 and patients undergoing procedures such as colonoscopy. Now, AI in pre-anesthetic checkup will soon become very popular. We have Google Translate, and that can be used frequently to communicate with patients in their native tongue or vernacular languages. Paperless hospital services for PAC documentation will also become very popular. In our OTs, we can ask Alexa to adjust the position of the OT headlights, or OK Google, increase the height of the table please, or Hey Siri, switch off all the fans and air conditioners in the OT. Anesthesia workstations will be operated by AI with voice commands. Monitors will be assessed and self-checked by AI. Augmented reality combined with AI will improve the concept of virtual anesthesia. Now, video conferences can put a lot of people to sleep, but never like this before. Dr. Thomas Hemmerling successfully conducted the world's first transcontinental teleanesthesia in a patient undergoing thyroid surgery. He is therefore known as the father of robotic anesthesia. Yet another intriguing study revealed how AI algorithms are now using facial recognition to predict difficult intubation. However, let's address the elephant in the room, the million-dollar question. Will AI replace anesthesiologists? Now, anesthesia requires dexterity-based skill labor, and that is something currently our robots lack. Therefore, anesthesia will never be fully automated. What AI can do is improve doctor-patient relationships and make healthcare human again. AI will catch silly mistakes and optimize patient care, but it will also introduce new errors that humans would never make. Currently, AI is not capable of handling many decision-making tasks that anesthesiologists perform on a daily basis. Also, no matter how intelligent a machine or robot may be, speaking with one is not the same as speaking with a skilled anesthesiologist. In conclusion, AI is destined to remain a useful adjunct to an anesthesiologist, but a dangerous substitute for an anesthesiologist. You can love AI or you can hate AI, but you cannot ignore AI. I hope you found this brief presentation informative and interesting, and know that I really appreciate you for listening. Thank you.
Thank you. Thank you, Archita, for such a nice presentation. Hope everybody enjoying here. Now, next speaker is Dr. V.D. Suryavanshi, sir. And his topic is osteoporosis management. Next speaker is Pushpraj, sir. Pushpraj Patel, sir.
Good afternoon, everybody. Thank you very much, organizers, for giving this opportunity to speak in front of you. The topic osteoporosis is not new to anyone. There are so many things you know about the osteoporosis management, starting from calcium, rich diet, vitamin D, sun exposure, exercise, this and that. I would be touching just a recent drugs which has come to at our hands for treating osteoporosis. As goes the definition, osteoporosis is an asymptomatic or silent killer disease and generally present as a fragility fracture. Global data indicate that 20% of women with hip fractures die within 1 year of fracture and 50% of them never gain their functional independence. Vertebral fractures have significant mortality and are associated with increased long-term morbidity. So the screening of osteopenia and osteoporosis is paramount of importance. The common sites of osteoporotic fractures are spine, vertebrae, hip and wrist. Vertebral fractures, it is common in both women and men. It increases with age. Increased risk of new vertebral fractures 4 to 5 folds. Increased mortality, chronic pain, kyphosis, height loss, disability and reduced quality of life. Low trauma fracture, clear indication for treatment independent of BMD and other risk factors. Hip fracture is one of the most disastrous consequences. Incidence increases with age in men and women. Determinants of risk, low BMD and falls. Mortality increased 15-25% in the year following hip fractures, particularly in men. Non-spine fractures, fractures were distal radius, most common, known as Colles fracture and all. One of the earliest manifestation of osteoporosis, increases in the early postmenopausal years and then stabilizes. Considered a minor 2 to 3 times higher risk of other fractures. Other sites includes proximal radius, ribs, pelvis, clavicle, femur and tibia. BMD testing recommendation. The BMD is the gold standard for detecting the osteoporosis. AS 2020 recommends BMD testing in the following patients: women age 65 or older, postmenopausal women with a history of fractures without major trauma, with osteopenia identified radiographically, or starting long-term systemic glucocorticoid therapy. Peri or post-menopausal women with high risk for osteoporosis, if willing to consider pharmacological intervention, with low body weight BMI, taking long-term systemic steroids, or with family history of osteoporotic fractures. Other indication for BMD testing includes the following: early menopause, current smoking history, excessive consumption of alcohol and secondary osteoporosis. So how to evaluate? The lab investigation includes serum calcium phosphate, CBC-ESR, TSH, testosterone, estradiol, and so many factors. Imaging, X-ray does not good for early detection. 20 to 40% of BMD must be lost before detection. So BMD is absolutely indicated. Other formation markers or resorption markers like serum alkaline phosphatase, bone alkaline phosphatase, osteolactin, these are all of importance for evaluation of osteoporosis. So whom to treat is the question. The NOF guideline 2013 says women more than 65-year age and men more than 75-year age or younger with some risk factor. DEXA is absolutely indicated in such situations. These are the various guidelines for DEXA T scores, which are not, I won't go into the detail of such things. Non-pharmacological treatment is also there, like lifestyle modification may improve musculoskeletal integrity and balance, preserve bone strength and prevent future fractures. These includes an adequate intake of calcium and vitamin D3, daily supplementation with vitamin D3 at a dose of 1000 to 2000 international unit. Recommended calcium dietary plus supplements if necessary is 1200 milligram a day. Lifelong participation in regular weight-bearing resistance exercises, balance providing exercise to minimize falls, avoiding tobacco and excessive use of alcohol, eliminating potential risk factor for falling. Pharmacological treatments are categorized in one: anti-receptive agents like bisphosphonate, denosumab, estrogen, serums, calcitonin, or anabolic group of drugs which are teriparatide, abaloparatide, and romosozumab. Osteoporosis therapy objectives are to improve bone strength, reduce the risk of fractures, prevent rapid bone loss. Mechanism of action, anti-remodeling drugs like bisphosphonate denosumab, or remodeling stimulators like PTH analogs, or modeling stimulators like serotonin antibodies. So the differentiating fracture risk are very high risk patients are those who have fractured in past 12 months or have multiple fractures. High risk are the postmenopausal ladies, or the low risk are the no prior fracture but T score is less. They're all so the thing which is of importance to discuss is role of denosumab. It's a recent trend in the treatment of osteoporosis. So it's a new drug. It's the mode of action is block. It acts by blocking the Rankel enzyme and accelerating the osteoblastic activity. It binds to cytokine Rankel produced by osteoblast, prevents binding of Rankel to rank on osteoclast, prevents osteoclast formation, activity and survival, thus reducing bone resorption and fracture risk. So denosumab for prevention of fractures in postmenopausal women and osteoporosis. The well-known trial is known as the Freedom Trial, which has been done in the West to recommend its use. It significantly lowers the relative risk of fractures at 36 months after starting. So these are all the graphic representation. I won't go into the detail. 10 years study data are available with this drug, the Freedom Trial. So denosumab in the Freedom extension, the treatment is for up to 10 years, was associated with low rates of adverse events, low fracture incidence compared with that observed during the original trial, and continued increase in the BMD without plateau. So now the question comes, what is the role of combination therapy? Another nice tool which has come to us is teriparatide. So the combination of denosumab with teriparatide, the most robust additive BMD effect, the rise in BMD is seen when it is used in combination with teriparatide. However, in certain situations, combination therapy indicated in fracture risk, especially where the fracture risk is especially high, suboptimal effect from relaxation to HRT, or recurrent fractures, high bone resorption markers, or progression of BMD loss.
Sir.
Okay, just give me a couple of minutes. So the data extension study conclusion, 2 years of concomitant teriparatide and denosumab therapy increases BMD more than therapy with either medication alone. Combination can be important treatment option in patient at high risk of fractures. So the conclusion is, just in short, switching from teriparatide to denosumab, BMD continued to increase. Switching from denosumab, teriparatide, just reversed. Switching from denosumab to teriparatide, BMD loss. Switching from denosumab plus teriparatide, continued on denosumab, largest four-year increase in hip and wrist BMD. These results should be considered when choosing the initial and subsequent management of postmenopausal osteoporotic fractures. So, in brief, what is better and what is best? So, it is a combination therapy which is highly recommended for in the osteoporotic, where the BMD or DEXA are supportive of osteoporosis. Denosumab versus bisphosphonates, all orthopedic surgeons are very well aware of the role of bisphosphonate. It is also a gold standard OPD therapy, but these denosumab and teriparatide both are in injectable forms. So indication for use, treatment of postmenopausal women with osteoporosis at high risk for fractures or glucocorticoid-induced osteoporosis. Dosage and duration, obviously everybody wants to know. The recommended dose of denosumab is 60 mg subcutaneously every 6 months into thigh, abdomen or upper arm. Patient must be adequately supplemented with calcium and vitamin D. Duration, optimal total duration of denosumab for osteoporosis has not been established. The need for continued treatment should be reevaluated periodically based on the benefits and potential risk of denosumab on an individual basis, particularly after 5 or more years of use. Provides continued anti-fracture and BMD benefits over 10 years of therapy, generally well tolerated. Special precautions are hypocalcemia. It is important to identify patient risk for hypocalcemia, renal impairment. Patients with renal impairment or receiving dialysis are at greater risk of developing hypocalcemia. The risk of developing hypocalcemia and accompanying PTH elevation increase the risk degree of renal impairment. Denosumab to osteoporosis patient with renal impairment, as no adjustment is required in patient with renal impairment. It is also safe for the hepatic problems. Denosumab and teriparatide, they are not in Goli form. Injective. बताया तो था अभी, फिर से बताऊं? चल बताता हूं. Sir, the evaluation of BMD by ultrasound is not very much authentic. The gold standard is at DEXA. DEXA is the gold standard for identifying this osteoporosis and all. So I hope the message has gone and people have realized the new thing in the management of osteoporosis. Thank you very much for the patient listening. Thank you.
Thank you. Thank you so much, sir, for such a nice presentation. Now I would like to call Dr. Pushpraj Patel, sir, who is one of the best cardiologists in Jabalpur, and his topic is heart failure recent advances. Also welcome Dr. Deepak Shahu, sir.
Sir, please, sir, we would like to grandly welcome Dr. Deepak Sahu, who has graced us with his magnanimous and enormous presence. Let us have a huge round of applause. Thank you so much, sir. Sir.
गुड आफ्टरनून एवरीवन. तो सीधे ट्रीटमेंट पे ही आऊँ क्या? स्लाइड्स. So as we know, heart failure is not a single pathological diagnosis, but it is a clinical syndrome consisting of cardinal symptoms like breathlessness, swelling, fatigue, and it may be accompanied by signs like raised JVP, pulmonary clefts, peripheral edema. The burden of heart failure globally, it is increasing. The number of patients around 21 million adults worldwide, and it has mortality of around 50% over 5 years. And the most burden of re-hospitalization in terms of cardiology. The staging of heart failure, it is NYHA grading, we all know that grade class 1, 2, 3, 4, and the stages are ACC stages A, B, C, D. Stage A is patients who are at risk of developing heart failure, that is high risk population having hypertension, coronary artery disease, diabetes, and who have family history of cardiomyopathy. Stage B is patients with who are asymptomatic but having low ejection fraction or previous MI, LV dysfunction or asymptomatic valvular heart disease. Stage C is symptomatic patients with heart failure, and stage D is refractory heart failure. So the treatment is aimed according to the stage. Patients at stage A, they are at risk, but they do not have any established heart failure. So in that group, subgroup, the goal of treatment is risk factor modification and treatment of risk factors like hypertension, CVD, diabetes, obesity, cardiotoxin agent exposure. So we will have to treat the etiology to prevent further heart failure. Stage B is patient having low ejection fraction but who do not have heart failure. In that subgroup, we have to treat according to the structural heart disease and evidence of raised filling pressure is there, then we have to add diuretics. Stage C is symptomatic and stage D is this refractory heart failure. Then we further subdivide this in 3 categories according to the ejection fraction. Heart failure with preserved ejection fraction where the ejection fraction is 50% or more. Heart failure with mildly reduced ejection fraction where the echocardiographic ejection fraction is between 40 to 50%, and reduced ejection fraction where the ejection fraction is less than 40%. The most common etiology of heart failure is ischemic, and other non-ischemic causes are like chemotherapy, rheumatoid or rheumatological, endocrine like thyroid disorder, familial cardiomyopathy, rhythm related, that is very common, tachycardia induced cardiomyopathy, hypertension, then infiltrative disease, myocarditis, peripartum cardiomyopathy. The lab investigations which are to be done in all the patients with heart failure are ECG, echocardiography, CBC, urine analysis, renal function test, sugar, lipid profile, liver function test, iron studies and TSH. Then BNP or anti-pro-BNP, it is also mandatory in all patients with heart failure. Apart from heart failure, the other causes of raised BNP level are RV, right ventricular heart failure syndrome, acute coronary syndrome, heart muscle disease, valvular heart disease, pericardial disease, atrial fibrillation, myocarditis, cardiac surgery, secondary to cardioversion. Then toxin induced. With advancing age, the BNP level rises. Anemia, renal failure is a common cause of raised BNP because BNP is secreted by kidneys. Then treatment according to the stage. Stage A is, as I have already told, the risk factor modification and treatment of the corresponding risk factor. Stage B is patient with pre-heart failure stage where the ejection fraction is low. If the EF is less than 40%, ACE inhibitor should be added to prevent symptomatic heart failure and reduce for the mortality. In patients with remote history of MI or ACS, the statin should be used to prevent symptomatic heart failure and adverse cardiovascular events. And in patients with remote history of MI or ACS and ejection fraction less than 40%, beta blocker should be used to reduce mortality. Then in stage C, which is most important, if the ejection fraction is less than 40%, we should use ARNI in patients with NYHA class 2 to 3 or ACE inhibitor or ARB in patients with NYHA class 2 to 4. Beta blocker should be used, then mineralocorticoid receptor antagonist should be used. SGLT2 inhibitors, they are recommended in patients with stage C heart failure, and diuretics as per need. Then in step 2, we have to titrate the target dosing as tolerated with lab and health status and ejection fraction. If the ejection fraction still remains less than 40%, then we have to further add according to if the patient is having hyperkalemia, then hydrolyzine nitrate combination, ICD implantation if the ejection fraction is less than 35%. If the ECG morphology is less than left bundle branch block and ejection fraction is less than 35%, then CRTD should be considered. If the ejection fraction improves and it comes more than 40% and previously it was less than 40%, then also we have to continue these guideline directed medical therapy. We should not stop these medicines in this subgroup also if the ejection fraction improves. Then the additional therapies over the guideline directed medical therapy, ivabradine can be added if the patient is already on maximal doses of beta blocker and still the heart rate is more than 70 beats per minute, then ivabradine can be added. Then verisuagot, it can be added in patients with NYHA class 2 to 4 with ejection fraction less than 40% who have recent heart failure or on IV diuretics and have elevated BNP levels. Then digoxin can be added with symptomatic heart failure reduced ejection fraction patients. Then PUFA can be added in heart failure with NYHA class 2 to 4, and in patients with hyperkalemia, potassium binding resins can be added. This I have already told. In patients with heart failure with mildly reduced ejection fraction, where the ejection fraction is between 40 to 50%, diuretics as per need can be added. SGLT2 inhibitors, they are class 2A recommendation. ACE inhibitor, ARB and ARNI, they all are class 2B recommendation. So SGLT2 inhibitor should be preferred as a heart failure medicine, not as a anti-diabetic medicine, because a lot of patients they come saying I'm not a diabetic and why you have started me on this drug. So this SGLT2 inhibitor is also a very good drug for heart failure management. Then in patients with where the ejection fraction is more than 50%, diuretics as per need, and SGLT2 inhibitor again as a class 2A inhibitor, class 2A indication, ARNI as class 2B indication, and mineralocorticoid receptor antagonist class 2B indication, and ARB class 2B indication. So SGLT2 inhibitor should be used in all patients with heart failure despite of the ejection fraction, whether ejection fraction is low or normal. If the EF is low, then it is class 1 indication. If the EF is normal, then it is class 2 indication, but still it is over and above ARNI and other heart failure medicines. In advanced heart failure, that is class D, they require IV inotropes and IV diuretics. In patients with acute decompensation, the common causes of decompensation are ACS, uncontrolled hypertension, rhythm abnormalities, other infections, non-adherence to medicines, anemia, hyperthyroidism. Comorbidities, the common comorbidities are thyroid disorder, sleep disorder, rhythm abnormalities, diabetes. So we have to treat the comorbidities accordingly. So evidence gaps and future research directions are to be like pharmacological therapies targeting novel pathways and endophenotypes, new device therapies including percutaneous and durable mechanical supportive device, invasive like pulmonary artery pressure monitoring catheter or non-invasive remote monitoring, studies on telehealth, digital health apps, wearable technology and artificial intelligence, and role of enrichment trials, adaptive trials, umbrella trials, basket trial and machine learning based trials, therapies targeting multiple cardiovascular, cardiometabolic, renovascular and pathological mechanism, and novel dissemination and implementation technique to identify patients with heart failure. The take-home message, that is SGLT2 inhibitor have a 2A recommendation in heart failure with mildly reduced ejection fraction, and weaker recommendations are made for ARNI, ACE inhibitor, ARB and MRA. The new recommendation for heart failure preserved ejection fraction, that is for SGLT2 is class 2A with improved ejection fraction. In patients who have previously the ejection fraction less than 40% and now EF has improved, they should continue with the optimal medical management, and evidence supporting increased filling pressure is important for the diagnosis of EF, where the EF is more than 40%. That evidence can be in form of BNP or diastolic function or in invasive testing with hemodynamic measurement. Thank you.
Thank you so much, sir. Thank you for the riveting lecture. So first and foremost, if I have ever thought about resilience, the definition of resilience, the people sitting in this room, they are the embodiment of resilience. I mean, पूरा सेशन खत्म होने तक आखिरी तक अपन लोग रुके. Thank you so much. It is a pleasure to be associated with you. I mean, it is no mean feat. I'm not mincing words in any way. So what we are going to be doing is, I'm going to be reading out, I'm going to be calling all the senior members, all the senior organizers on stage. We are going to be presenting the wonderful lecturers, the people who have presented cases and everything, and we are going to be giving them a token of appreciation. So, Babu sir, Neeraj sir, Arun sir, पुष्पराज सर, दीपक साहू सर, आइए सर. सूर्यवंशी सर, please come on in. Alka madam, Chitra madam, please. Please come on down. Please come on down. अरे madam, साहू madam, please come. हाँ? हाँ, of course. Sir, Arvind sir, please आइए. Please feel free to walk up on stage. and join us. Yes, because मैं बता रहा हूँ ना ये मैं मतलब I'm going to post it as resilience, nothing short of resilience. आइए please अच्छा everyone come on stage, we'll decide who gets the memento and all later. सब आ जाइए, let's take a picture and then we can go on. Sir, KK sir, where are you sir? Please come on, please आइए. सर कहाँ कोने में हाथ बांध के ऊपर आइए, फोटो खिंचवानी है, आखिरी तक रुके हो साहब. वो लोग भी एक्साइटिंग है, उनके आखिरी की फोटोज खिंच रहे, बोले अब जाने का टाइम आ रहा है. प्लीज ऑल द पीपल हु हैव प्रेजेंटेड टॉक्स प्लीज सर डेफिनेटली थैंक यू सो मच. अरे सर को देख के वो इनकॉग्निटो मोड ब्राउजर का याद आता है, सर दिखाई नहीं देते. सो आई विल बी कॉलिंग अप नेम्स. डॉक्टर अल्पना शुक्ला, इज शी देयर? Okay, Dr. Rajesh Kewat, please come on in. Thank you so much for helping us out in this very much needed hour. ऐसा मैं देते जा ऐसा नहीं ले चुका था, मैं ले चुका था. नेक्स्ट बोल दो. हां मैं ले चलो. नाम नहीं लिखना, आपसे डायरेक्ट ये अच्छी बात. नाम लिखे नहीं, नाम नहीं लिखे, सब देते रहो एक एक करके. So it's going to be like a group activity. हाँ नाम किसी का नहीं है. तो ठीक है. आयुषी कलसोलिया, is she there? Dr. आयुषी कलसोलिया, she's not there. हाँ जी. अलका मैडम को sir please anyone. I'm not going to take any names. फटाफट फोटो खींचते जाओ भाई. भारती मैडम आज we are turning the formal evening into an informal event. आइए please. प्लीज मैडम, आपको तो मिलना ही चाहिए. मतलब आपने तो जो साहस दिखाया है मानना ही पड़ेगा सीरियसली. और मैडम दीपक सर आगे 10 पॉइंट होने अपने को. थैंक यू सो मच. सो डॉक्टर सुहाने प्लीज आइए. डॉक्टर प्रदीप अरोड़ा सर प्लीज आइए. डॉक्टर अभिजीत विष्णु प्लीज. डॉक्टर केवट प्लीज कम ऑन. डॉक्टर सूर्यवंशी सर. अरे फोटो नहीं हुआ है, अरे जो चलेगा ही नहीं. फोटो इज द मोटो का ये. दिस आई एम टेकिंग डाउन फ्रॉम IMA-AMS. सर के साथ फोटो नहीं हुई एंड लवली. थैंक यू सो मच. सूर्यवंशी सर प्लीज आइए. भटेले सर एंड पुष्पराज सर, दोनों पुष्पराज एक समय सोचा था एक एक करके। सर आपको एक और देना चाहता हूँ, आप रुके इसके लिए, प्लीज आइए, मानना पड़ेगा सर, पूरा दिन निकाला सर, माहौल बना के रखा सीरियसली। थैंक यू सो मच पुष्पराज सर, आपके लेक्चर के चक्कर में मेरा अभी दिल चल रहा है, नहीं तो अभी साहू सर ने तो उड़ा ही दिया था विकेट अपना। डॉक्टर अनिमेश गुप्ता प्लीज कम डाउन इन। दीपक साहू सर आपकी भयंकर डिमांड है सर, आप आइए।
मेरा लेक्चर स्पेशल अटेंड करने आया दीपक सर, इम्पोर्टेंस।
मैं बता रहा हूँ सर आपको, इससे अंदाजा होगा ये इम्पोर्टेंस लेक्चर का। या तो उधर जाइए। थैंक यू सो मच अनिमेश। Am I? सर प्लीज एक कॉल सर, आइए आइए आइए। Now we will be talking about अभिजीत। हाँ भाई अभिजीत, एक मिनट सर, खत्म तो कर लूँ सर, आप लीजिएगा। anyone is anyone left? Am I missing anyone out? Who has presented, not presented, stayed with us, given us company, anything? Madam please. आइए 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 मैडम प्लीज। No, I will. I think we are pretty much done. But we should not forget the people who are working behind the curtains, who have made it all possible. 10 days back, this conference was not happening. This is actually the truth. All this has been made possible by your efforts, by the organizing committee's efforts, the proud IMA-AMS, and of course, Gilbert. He is one of my boys. He has done an excellent job. I mean, he has been working. JP. I mean, seriously, a huge round of applause. संतोष मिश्रा जी दिख नहीं रहे हैं, और बुलाना पड़ेगा। बुलाइए संतोष मिश्रा जी को बुलाइए, उनके लिए हम रुकेंगे। गौरव प्लीज कम ऑन इन, आइए। I mean, we should always remember the people who made it all happen. मिश्रा जी कहाँ हैं, हमारे प्यारे मिश्रा जी? उनके बिना जॉग्स नहीं चलेगा, और मैं तो अभी तक चला ही गया होता।
अपन ने सभी को अप्रिशिएट किया, सभी को प्राइज दिया, लेकिन अपन ने अपने एनर्जेटिक डायनामिक, हाँ जेपी बॉस, यस, वी आर फॉरगेटिंग आवर एनर्जेटिक हैंडसम डायनामिक डैशिंग ऑर्गेनाइजिंग सेक्रेटरी डॉक्टर नचिकेत। आप सभी लोगों से रिक्वेस्ट है कि डॉक्टर नचिकेत का भी सम्मान किया जाए एक शील्ड देकर। नचिकेत ने जो काम करके दिखाया, उनकी टीम ने जो काम करके दिखाया, वाकई सराहनीय है। इट इज फैंटाबुलस, अमेजिंग, ऑसम। जय माता दी।
there is one more person who is new to the family and one more person who was dealing with all the USB ka pen drives and the graphics ka glitches and PPTs not working and the Zoom links malfunctioning. Samal Singh ji, please आइए. आइए प्लीज, आपकी टीम को भी लेके आइए. We would like to have them on stage. अरे ऑडियो, I don't know his name. ऑडियो आजा. आ रहा हूँ. I'm coming to you. रुकना भाई, रुकना. हाँ, definitely. बिंदास. Technical team, fantastic job. It is not easy to manage this huge LED wall that they have created. They have made this a visual spectacle. 3 cheers for Samar Singh ji. Thank you so much. We will also be calling the lady who has been serving us tea. Please come on in. आइए, दीदी जी, यहाँ आइए.
संध्या.
One person who kept us awake, Sandhya. Sandhya ji, आइए please. हमको जगाए रखा. Thank you so much. No. As a grand finale, we have one last speaker who is going to shower us. Who will sing a song? Yes, that's a good idea. So we can actually do that after the lecture also. Samal Singh ji, एक आध lecture की आप हमको permission देते हैं क्या? Yes. अच्छा, only songs. चलो ठीक है. He's going to sing. Token of appreciation मिल गया है भाई. The IMA always, takes its debts. आइए अनिमेश, आ जाओ. मेरी नाक सुनी है क्या बज रही है ऐसी खनखनाती हुई.
बैठे हुए हैं.
चलो.
चलो सब गाएंगे.
सर आइए बाबू सर आइए. अरे सर आइए. सेठी सर कहाँ जा रहे हो?
सर आइए.
कहाँ जा रहे हो?
आओ ना. अरे आओ ना.
अरे म्यूजिक दो यार, छू कर मेरे मन को.
ये है ना, ये बिल्कुल सर. आओ, सब गाएंगे हमेशा.
बजाओ तो. नहीं बजेगा भाई. अच्छा ऑडियो. हाँ ठीक से भाई. श्री राम कॉलेज जिंदाबाद.
श्री राम को
हम लोगों को इन लोग का था, आँख वालों का था. हाँ तो ये मैडम को लेकर खुद ही बोल रहे हैं आँख वालों.
सर एंड्रॉइड फोन दे दो सर. ऑक्स केबल है उसमें.
और गाया और ऐसा फिर पीछे से आके दिलीप
नहीं है. हम बिना म्यूजिक के गाएंगे.
दिलीप को कान में फिर उस सर से उठा.
नहीं छोड़ो. चलो सेठी सर आ जाओ. म्यूजिक आपको ही देना है. आ जाओ सर.
ये एक नंबर.
शानदार.
नहीं मान लूँगा. वो वहाँ वो चला रहे हैं.
छूकर मेरे मन को किया तूने क्या इशारा. छूकर मेरे मन को किया तूने क्या इशारा. बदला ये मौसम लगे प्यारा जग सारा. छूकर मेरे मन को किया तूने क्या इशारा. बदला ये मौसम लगे प्यारा जग सारा, छू कर मेरे मन को किया तूने क्या इशारा। तू जो कहे जीवन भर तेरे लिए मैं गाऊं, तेरे लिए मैं गाऊं, जी तेरे बोलों पे लिखता चला जाऊं, लिखता चला जाऊं। मेरे गीतों में तुझे ढूंढे जग सारा, छू कर मेरे मन को किया तूने क्या इशारा। बदला ये मौसम लगे प्यारा जग सारा, छू कर मेरे मन को किया तूने क्या इशारा।
Thank you so much. Thank you so much. Thank you so much, everyone. Thank you, thank you, thank you, thank you. And do not worry, we are not going to take any requests. I am calling a closure to this wonderful evening, and thank you so much for staying behind, everyone. Thank you. It has been. अब नहीं, मैं अब जाइए तो नहीं बोलूँगा, मतलब
अलविदा तो अंत है और अंत किसने देखा, ये विदाई ही मिलन है जो हमने देखा। यादों में आकर तुम यूं ही बुलाते रहना, कभी अलविदा ना कहना, कभी अलविदा ना कहना। चलते चलते हमारे ये गीत याद रखना, कभी अलविदा ना कहना। God bless you, yeah, great. So well done. मजेदार endings.
ये वाले बटन है ट्रांसफर।